Good morning to everyone. It's really a pleasure to have you here for the fourth event about cocktail with science for lung cancer. One of my goal is, and I always try to teach to my youngster assistant, is make it simple. So sometimes also the meeting should be like this, easy meeting where it's possible to have a very good discussion despite of the complexity of how to treat cancer nowadays. So many opportunities, the multidisciplinary approach to take a decision, a completely different strategy for each patient. And this is raising a lot of questions, a lot of opportunity to go ahead with the research. Lung cancer has been one of the disease where we did the most improvement for care and cure. Now we are in this meeting. We are discussing all the aspects from the screening. It is going to be the first presentation up to the complexity of toxicity from immunotherapy, target therapy, how to choose a treatment, how to explore why there is a resistance to some target that we consider very strong. We have a new target, we have a new combination. We are exploring the homologous recombination as a target. We are combining immunotherapy and target therapy. So there is a lot to do. And I think this is the best opportunity to go ahead and define each year our strategy that is going to conduct our research for the whole year. So it's my pleasure to have you here, and I leave to Giuseppe some words to describe the meeting. Thank you very much.
Thank you, Professor De Bro. Colleagues and friends present live or connected online, good morning. For people who don't know me, I'm Giuseppe Lo Russo. I'm a medical oncologist and I'm work at the Thoracic unit at the Istituto Nazionale dei Tumori in Milano. It is a great pleasure and a great honor to be here with you today and to introduce the third edition of our annual meeting. This year meeting is in its fourth edition. It was born 4 years ago in the minds of the COVID era from an idea by Marina Garassino, who was my boss at the time. And today she will be with us in person, and I am very happy for this. This year, the meeting will be divided in 3 sections. The first in this morning focused on early and locally advanced non-small cell lung cancer. After the lunch, we will talk about oncogene-addicted and non-oncogene-addicted advanced disease. At the end of the section, we will have 3 very interesting special lectures. At the end of each section, we will have time to discuss and to ask questions to the speakers in the round tables. So it's time to start with the meeting. Let me to introduce you, my colleagues, that will be the chairs of this section, Dr. Sara Manglaviti and Dr. Laura Mazzeo. They both work with me at the Istituto Nazionale dei Tumori in Milano. Sara and Laura, welcome. C'è lo schermo, come vuole. Qua vediamo tutte le... Okay, perfetto.
Welcome everyone. First of all, I want to say thank you to Giuseppe for inviting me and for giving me the possibility, the opportunity to participate today here for this amazing conference. And let's start with the first speaker, Dr. Ugo Pastorino, the head of the thoracic surgery in our institution, Istituto Nazionale dei Tumori. And I'd like to remember that we will make the question at the end of the session during the round table. Today, Dr. Pastorino will talk to us about the lung cancer screening. Welcome, Dr. Pastorino.
Thank you. Pleasure to share with you what is the status of the advancement in the screening. Screening has has progressed quite rapidly in the last few years after a period of abandonment when the first study demonstrated that the spiral CT of the chest could change the story. There are basically 3 randomized studies proving the benefit of lung cancer screening in terms of reduction of mortality. The NLST is the largest study, 3 rounds in 2 years, 20% reduction of mortality. The European Nelson study had a longer 4 rounds intervention and achieved a 26% reduction. Our study, which is relatively small, but 4,000 individuals, but a longer intervention beyond the 5 years, 8 to 10 years screening. This is the only experience in the world. And we obtain a much larger reduction, 39%. All the randomized study proved that there was a higher proportion of stage 1. You see the red bar compared to in the screening arm compared to the control arm. Of interest, there's no relationship between the difference and the mortality reduction. As you see, the green are the 3 studies that turned to be positive, and the difference between the intervention and the control arm is relatively smaller compared to the other studies. You see the Lucy study, 56 versus 9%, and the negative study. So there is no immediate correlation between stage reduction and mortality reduction. What is important of the MILD study that was conducted in Institute is that if you look at 5 years on, you see that not only there is a reduction of the lung cancer mortality, but it is a significant reduction of the overall mortality, all-cause mortality. This is the only screening study in the world proving a reduction of all-cause mortality. In the last 20 years, we have performed 3 concurrent prospective trials, MILD and BioMILD, only screening, and the SMILE was screening plus prevention. You can imagine how is the difficulty and the burden to go on with the study, because usually you start another study when you have closed the previous one. But we continue to screen, and we have a very long-term screening experience, but we have to go on with these for years. And this is a big burden. There is a major difference in the quality of the CT. You see from the 16 slides that was the MILD to the 228 slides of the BioMILD to the 192 double source last, let's say, is the most performing machine available today in the market. And you see there is a decline in the dose. So the radiation dose was 2 millisievert in the MILD trial, which was already low dose. It went down to 1.5 millisievert in the BioMILD, and is now 0.4 millisievert, or 4.5, depends on the size, of course, of the individual. But we have cut progressively the radiation so that you can now do 10 years of screening with the radiation exposure of 1 single chest CT, conventional chest CT. We've demonstrated that volumetric assessment of nodules is essential. And by doing volumetric assessment instead of diameter, you save a lot of unnecessary repeats and a lot of false diagnoses. You have to consider that in the United States, volumetric assessment is not the rule, is not even the routine practice. So in the States, they continue to measure diameter, which for us is a nonsense. Using the new machine, we have tested in a randomized study 4 different types of ultra low dose protocol, and we demonstrated that there was reliability in the assessment of nodules, and not only the assessment of nodules among the different protocols, but we picked up the best performing. And this protocol was used in the SMILE and in the subsequent trials, such as the RISP trial. This is the first, the only available randomized trial testing different types of ultra low dose. And when you look at the performance, and this is a study we are trying to publish, and we have submitted, comparing the MILD trial, the two arms of MILD trial, so control and intervention in red, with the BioMILD. The BioMILD used a completely different risk-based strategy. So the negative individual baseline were sent to 3 years interval, which again is something no one has used. And we demonstrated that by using a personalized approach and a longer interval for low-risk individual, you can improve the performance, not decrease. And as you see, the percent of resection, the percent of stage 1, the percent of VAT resection increased significantly in the BioMILD trial compared to the conventional. But one thing we are particularly proud of is the fact that we implemented the surveillance of subsolid lesion from 2005. These are the results of the MILD trial that were published on JTO in 2018, showing essentially that the vast majority of these subsolid lesions don't evolve, remain, or disappear, and only a tiny minority, 5%, progress to invasive adenocarcinoma, but these are all stage 1. And we had no resection of benign disease, no resection of pure BSC or adenocarcinoma in situ in the MILD, and no deaths for progression. I'm happy to show you the data of the MILD, which is the risk-based trial that included more than 4,000 participants. These were presented 2 weeks ago at the European Respiratory Society Congress in Milan. ERS is a society that includes 35,000 associates. It's one of the largest society in oncology in the world. And we presented for the first time the results of BioMILD surveillance of subsolid with almost 9 years of follow-up. And as you see, the frequency was confirmed to be relatively high, 18.4%. We had only 48 lung cancer arising from subsolid, which represent 4.4%, and where 98% of them were stage 1. So it is essentially confirmed that surveillance is safe and effective. But if you look at the time of occurrence of these cancers, you see that these are spread over a period which is far beyond the 3, 4, 5 years. And we continue to see cancers up to 10 years, and we are convinced that we will see even after 10 years. So you can avoid useless resection, but you cannot stop the surveillance. The good thing of a CT is that the picture of the lungs is not only, is not only showing nodules, but it shows a lot of other elements which are essential in the assessment of risk of a lifelong smokers. So if you look at coronary artery calcification that we are now evaluating with a standard automatic software, is a Korean software, the AView, which we have used and tested in all the individuals participating in the various trials. So in the BioMILD trial, we have demonstrated that with 128 slides CT that the risk of dying for all causes was completely different according to the coronary calcification, and the CAC score above 400 had a very significant 10% risk of dying at 6 years. But when we applied to MILD, which is the oldest study with the 16 slides, so you would expect a slide scanner that is not performing well, without ECG gating, without all the control of heartbeat, well, it worked just as well. And as you see, in the middle, we have a 12-year follow-up, and we have a mortality risk that approaches the 20% for individuals above 400 Agatston score. That means we know who is going to die, not just for lung cancer, but for all causes. So we can activate selective prevention. You have to consider that 3/4 of these individuals had no cardiovascular story before screening. So they were not knowing what was the condition of their heart. The same thing you can get for emphysema. In the SMILE trial, we combined screening with drug support for quitting smoking, using a natural substance, the citizen. And in this randomized study that was conducted during the COVID, this is pretty interesting. We are convinced that the result could have been even better without lockdown. But anyway, at 12 years, CO confirmed quit rate was 32% with citizen compared to 7%. 7% is very close to all the reports in the screening. I mean, they go from 5 to 8% quit rate just with counseling and voluntary occasional drug. But with the citizen, we multiply the quit rate. Just a few words on blood biomarker. There are several blood biomarkers tested. In the screening context, we have only the autoantibodies tested that was tested in a randomized study in Scotland that turned negative because it didn't work. In our study using microRNA, there was a benefit in terms of assessment of the risk for indeterminate and positive pulmonary nodule. We have no data of the summit. In the long run, using the DNA fragmentation test will only start next year. This is the type of a prognostic prediction of our microRNA test. There is something promising, certainly, from the lung cancer cohorts, but the sensitivity for stage 1 remain a bit low. So for early diagnosis, biomarker, the blood still have to prove their efficacy in a screening cohort. We also have joined the NIH TCGA program, offering the chances of testing a screening population. This is the first study that will investigate screen-detected lung cancer in terms of complete genomic, proteomic, metabolomic profile. Just 2 words on the ongoing Italian RISP trial, is Rete Italiana Screening Polmonare. This is a project funded by the Ministry of Health that includes 18 centers around the country and has let's say experimental comparison of annual versus biennial CT. Everyone can choose the center of choice, 3 centers of preference. We have a different machine, but we are convinced that we can demonstrate that even with different scanners, we can obtain the same results, both in terms of assessment of nodule, assessment of coronary artery calcification, and emphysema. We have so far almost 18,000 individuals registered. The majority, half of them are eligible. 6.7 thousand have been screened, and we are planned to complete the expected number of 7,300 by the end of October. This was the commitment with the Ministry of Health, but we want to go on to 10,000 individuals. There is another, let's say, study going on to the CCM, essentially coordinated by the group of Florence, which is testing different modalities of screening, but on a much smaller sample of 1,000 individuals. We are part of two European consortia, EU funded. One is the Foreign the Land Grant, 5 countries in Europe. The other is the SOLACE consortium, 10 countries in more than 20 centers, aiming at setting up guidelines for screening. The good news is that England is not part of Europe anymore, but England has decided to make the step forward and funding a program of almost 1 million screens and investing something like £300-400 million in this program. And we do hope that we will be the first, Italy can be the first European country to join this program if the RISP proved to be successful. Thank you.
Thanks, Dr. Pastorino, for this presentation. Now let's go on to the next speaker. It's a pleasure for me to present Dr. Antonio Passaro from European Cancer Institute here in Milan. We will talk about adjuvant treatment in non-small cell lung cancer, both oncogen-addicted and non-oncogen-addicted disease. Due to work problems, Dr. Passaro has to leave the session early. So in this case, we will perform questions at the end of the presentation.
Thank you for the invitation. Thank you for the kind introduction. It's a very pleasure for me to be here today and to discuss this very difficult topic after a very elegant presentation about the screening and the direction between surgery and medical oncology, particularly with focus on the adjuvant treatment. This is my disclosure. I think that, of course, when we discuss adjuvant treatment in the setting of non-small cell lung cancer, the focus and the background and the very, very limited improvement what we achieve with the chemotherapy. The use of chemotherapy in adjuvant setting or neoadjuvant setting, that would be the topic of the next presentation, was very, very tiny in patients that receive chemo after surgery. And this were a lot of data that was presented during the years in the past, very, very in different kind of educational setting. But using this very, I think, educational slide presented during the World Lung Cancer Congress 3 weeks ago from Dolores Isla from Spain, I think that is very, very important to focus on the 2 main objectives that we need to try to achieve for patients with non-small cell lung cancer after surgery. Of course, the first is to increase the rate of curation, but we know that for patients with lung cancer, this is very, very difficult. The second is to delay disease recurrence. That maybe is one of the most important things that we need to focus more and stress more in the setting of patients that receive adjuvant treatment. We have a 2 big blocks of the significant improvement in the adjuvant setting. So we have a patient candidate to receive immune checkpoint inhibitors. And then we have some data for patients that are candidates to receive target therapy, in particular EGFR, in particular osimertinib ESMO, because maybe the new treatment in the future will be changed. And when we look to the rationale to use immune checkpoint inhibitors in the perioperative setting, we can see that we have a more rationale maybe that the use of the same drugs in patients with advanced disease. And also, of course, in my opinion, the most important, the most key topic is the less tumor heterogeneity. It is, of course, one of the most approaching for the use of immune checkpoint inhibitors in early stage. But when we try to move from the data of the literature, data of the science to the clinical setting, we know that it's very difficult to use, to apply the literature data of adjuvant immune checkpoint inhibitor resected non-small cell lung cancer. And we have, of course, prominent and content in this particular setting. But of course, the major advance here to have a tissue, a lot of tissue, to have a biomarker analysis, to stress this also not only in clinic, in educational setting, and also in science. And this, in my opinion, very, very important. One of the other very important, the use of MRD. MRD, in my opinion, is the real topic, the real key to improve the use of adjuvant treatment in patients with resected non-small cell lung cancer. But the use of the detection of a minimal residual disease now in clinical setting, of course, is not ready. And very, very different kind of testing methods now are able to try to improve our understanding in this particular setting. I think, as you know, the most important trial that focused the need to improve the advance in the adjuvant setting with treatment different from the chemotherapy was the IMpower010. This was the first trial that evaluated the use of immune checkpoint inhibitors. Here we have atezolizumab, randomized versus best supportive care after chemotherapy, standard chemotherapy, for those patients with resected stage 1B to 3A that receive a lobectomy or pneumectomy. So as you can see here in the study design, we can see that the tumor tissue for PD-L1 was one of the key, and there was a very, very complexity analysis that is the same, evaluated for the same industry in advanced disease, according to the different cutoff of the PD-L1 expression. So the different kind of endpoints was the overall survival in the intention to treat population and the disease-free survival according to the more than 50% of PD-L1 expression. We can see here in this summarized slide with the data of efficacy that for patients with a PD-L1 more than 1, there was a significant improvement in disease-free survival. But when we look to the subgroups analysis that the investigators perform, we can see that the benefit for patients with more than 50% without EGFR and ALK, and this is a key also for our clinic. Here, the investigators identify patients to exclude only with EGFR and ALK, but we know that a lot of patients with a different kind of driver have a similar clinical and biological behavior in this particular setting. And in the last 3 months was published the overall survival analysis update, and here we can see that there is a significant benefit for those patients that receive atezolizumab with the PD-L1 more than 50% after resection and alpha chemotherapy. Of course, here is very, very difficult, in my opinion, to translate this data in the clinical setting, to translate this data to argue with a different kind of clinical condition, different kind of biology. In the advanced disease, we are able to test our patient for 10 or 8 biomarkers that are targeted for different kind of gene, EGFR, ALK, ROS, BRAF, and 3K, RET, MET, HER2, that today, in a way or the others, are able to receive this kind of drugs in clinical setting. And in here, we have a benefit, of course, but of course, in patients that receive atezo, here we are excluding only EGFR and ALK, and maybe the benefit here could be much higher than these Kaplan-Meier curves. The second trial that he tried to identify the same benefit in the same and similar setting was the PIERS, named also Keynote 091, that was a trial powered by OTC and ETOP at the beginning of the history of this trial, and that included the same similar clinical characteristic of the patient after resection. In this trial, we have a different kind of drugs, so pembrolizumab compared to placebo. So we can see that the stratification factor are very, very similar. The dual endpoint are very similar. Disease-free survival, the main endpoint. And also for secondary endpoint, we have also the overall survival. So at the time of the presentation of these results, the results was very disappointing when we look back to the IMpower010 results, and we can see that there was a very limited benefit in disease-free survival overall. But when we focus on patients with more than 50% of PD-L1, we can see that there is a strange results here. So we have across the Kaplan-Meier curves, we have a no significant benefit for this kind of patient, and it's very difficult. So the investigator try in a different way to understand why these Kaplan-Meier curves have this behavior. And I think it is very difficult now, without a very mature overall survival analysis, to understand this analysis. But I think that one of these very interesting points is that more or less in this kind of point, there was a COVID pandemic. So a lot of patients in different kind of countries coming up from the trial. And maybe here we have also a high number of patients with high risk recurrence that stop the treatment with the adjuvant treatment here in this particular trial, particularly in the United Kingdom when the pandemic was very, very strong as in Italy. And using very elegant slide from Jessica Manis during the LCC 23 this year is we can do a lot of indirect comparison when we try to understand better the results. But these two trials very, very similar. It's very difficult to discriminate pro and contrast according to the trial. And these are very, very similar also considering the randomized patient trial, also the surgery, the kind of surgery, also the number of patients with a different kind of cutoff of PD-L1. In my opinion, we need to consider this a new point for a new cornerstone for the treatment of patients with early disease. But of course, the future, the next presentation will be focused on also for the real heterogeneity of the future, from adjuvant to neoadjuvant to different kind of combined treated perioperative treatment here. And I think it's very useful to use this slide of Martin Reck when they try to discuss the use of disease-free survival on major endpoint when we discuss of adjuvant treatment in the particular setting. That was also the great point when there was the first results of our trial that I'll discuss later. And we cannot consider in the same way disease-free survival over survival, of course, but at the present time, with the use of different kind of drugs, more than chemo, the use of disease-free survival could be considered as a surrogate point for overall survival, in particular when the significant advance is very, very strong. And in my opinion, the open issue at the present time, consider the adjuvant immune checkpoint inhibitors as a first are duration of this kind of treatment. So the history of a melanoma, I have a different kind of suggestion here. And I'm not sure that the use of 1 year, that was an empiric choice of treatment, is the correct ones. But here we need, in my opinion, the integration with the blood analysis, with the testing of MRAD to discriminate high-risk patient with low-risk patient. And of course, the safety. I think is a very, very important to understand the impact of the adjuvant treatment on the discontinuation treatment of the serious adverse events, and also immuno-related adverse events. Of course, the impact of the benefit of the empowerment 10, also the evolution of peers are very, very strong, but I think that we need to consider this to improve the future of our patient, also balance with the biomarker. So in the next presentation, we'll see a lot of data of biomarker in neoadjuvant setting, and I think that the use of a lot of tissue after surgery in this particular setting should be a key to improve also the adjuvant treatment. And of course, the financial toxicity that should be balanced with the toxicity and also with the duration of this kind of treatment. Jumping on the second topic of the adjuvant, so we have the TKI strategies here. So generally, when we discuss adjuvant or neoadjuvant, we are able to discuss all in the same way, but we are discussing two different kinds of disease. So we have a driver positive disease, there's a DNA alteration disease, and of course we have the block of immune checkpoint inhibitor that we discussed before. When we discuss about the TKI strategies today, the 99% of the data before ESMO is EGFR. As you know, after ESMO, maybe there will be the data of Alina that was presented as a positive press release with the use of ALK inhibitors in this particular setting, but no data released at the present time. And the history of adjuvant treatment in patients with EGFR positive disease started more or less 10 years ago. So here we have the first adjuvant trial that was evaluated, conducted, and concluded in China that compare patients to receive gefitinib to platinum chemotherapy, including patients with stage 2, 3A with N1, N2 only. So this was, in my opinion, a very important trial. This is in a history of the trial that push us to understand very well why we needed to improve this particular setting. So as you can see here, there was a very not strong benefit in the disease-free survival, and then we can see that the overall survival was a negative. But this trial, in my opinion, was the key to understand that the way was correct to try to improve the benefit of a patient with a driver alteration. And there was another trial that tried to improve the benefit in this particular setting, but all the trial was a positive or slightly positive for DSS improvement. It was a negative for overall survival. And this was maybe related to different kind of a clinical characteristic over the biology, but we can see that here the benefit was not so strong. And of course, looking forward, so there was the idea to improve why this kind of trial was not able to improve the benefit. And we can see that the trial was limited according to design if we compare to data that are available today, but today we have 10 years later from the beginning of the history. All the trials show no obvious benefit, and was very, very unclear to understand if this kind of treatment, so the TKI based on DNA alteration, was able to cure delayed recurrence in this particular setting. But the key from the different kind of investigators and using also the data from the metastatic disease, where the significant improvement in this particular setting for different kind of driver was linked to the improvement in the CNS recurrence, was to understand that this kind of drugs, as you know, was not so strong to improve the efficacy in the brain. And of course, WISA was one of the key that was at the base on the next trial. That the next trial was the development of ADAURA trial. ADAURA trial was the first phase 3 trial that used a third generation tyrosine kinase inhibitor, osimertinib, that we know very well that we use in metastatic disease with a high penetration of the brain, with a high CNS reduced recurrence. And this trial, we can see that the investigators randomized patients with a common EGF alteration, and during the meeting, you will be able also to understand different from common and uncommon with the Louis-Paz-RS. And this trial patient was able to receive or not the chemotherapy, adjuvant chemotherapy, and then was randomized in the one-to-one schema to receive osimertinib or placebo. I think that one of the most important key questions here to understand why was defined to use 3 years of osimertinib. So there is no clear answer here, but maybe consider the data of the activity in the metastatic disease and flower trial with 18 months of PFS. The investigator considered to double this time of treatment to try to improve this particularly biological setting. And the first primary analysis for disease-free survival was impressive. I think that if we look at this kind of Kaplan-Meier curves and we delete all the numbers, we delete all the names, we can see that we are looking to a breast cancer Kaplan-Meier curves, considering, of course, the historical benefit here. We can see that this primary endpoint, primary analysis was an hazard ratio of 0.17. In my opinion, it was very, very impressive, consider the kind of disease, considering that the patient with a driver generally have a very aggressive disease more than the other driver. And this was also confirmed in the update analysis, also the same trial with an hazard ratio of 0.23. In this Kaplan-Meier curves, I focus on the main topic of stage 2-3A, that was the primary endpoint. And of course, when we focus on the different kind of stage, we can see that the benefit is most stronger in patients with stage 3A, where of course the micrometastatic disease, the circulating cancer cell, is much higher compared to stage 1 and stage 2. But when we look through the subgroups analysis, we can see that the benefit was very, very strong, regardless of the kind of clinical characteristics, sex, smoking history, that of course is very, very limited here. Asian and non-Asian, we know that this is a key factor for osimertinib, also in FLAURA-3 and FLAURA-2 the same, and also for EGFR mutation, because we know that exon 2019 deletion is much sensitive to tyrosine kinase inhibitor that 21. And the key is adjuvant chemotherapy. So we can use, we cannot use, but of course, this is a key point, in my opinion, to argue with also the kind of stage of this particular patient, high-risk patient or low-risk patient. When we focus on the pattern of disease recurrence, we can see that, of course, lung and lymph nodes are the much interesting area when there is a reply, but the problem for this particular patient is a CNS. So we know that consider the history of the disease, that the patient with a driver alteration, EGFR, ALK, ROS in particular, very, very high propensity to go to the brain. And the data that are much impressive from the ADAURA trial, that the patient that showed a very, very limited progression disease compared to the standard arm. And in my opinion, this will be the key in this particular setting. We can see that in the first 24 months, there are very, very only 2% of patients that show a progression disease on the brain compared to the others. So starting for all these all this data, this year was published at the update analysis with the overall survival results in concomitant publication during the ASCO meeting with the presentation of the Roy Epps, when we can see that here we have an hazard ratio of 0.49 for all patients with stage 2, 3A. And of course, these data confirm the benefit, a new standard of treatment for patients with a drive alteration. In my opinion, focus the need to improve the understanding also of patients with other driver in the same setting, in the setting of a resective disease. And of course, this will be the first trial, then we will be ready to receive the ALINA results. ALINA in patient with the ALK is a little bit different as a study design. We have a randomization from alectinib to chemotherapy, and then there also in the next year we'll be able to have the data about RET inhibition in this particular setting. But of course, I think that this is not enough when we are trying to improve our patient. In this particularly slide that was presented last year during ESMO 22, published 3 days ago on JTO by Myung-Shu Han from Samsung Cancer Center, we can see that patient with the resected disease, with the EGFR positive disease, show 3 different kind of disease rate according to the baseline negative group, MRD, baseline ctDNA positive but MRD negative intermediate group, and baseline ctDNA positive but negative and also MRD positive. So this stratification, in my opinion, is very important when you try to translate also this in clinical setting. And in clinical setting, maybe we are discussing that not all patients are should be candidate to receive 3 years of TKI, because we should be improve our understanding of MRD and DNA on the circulating blood. So this, in my opinion, will be very, very interesting. Maybe we'll be able also to have some data from the other colleagues in the near future. But I think the key to improve also the safety and also financial toxicity is here to understand which kind of patient should be treated with a 3, 2, 1 or more. We know. So we know that at the present time, there are also other trials with a different kind of duration. But when we try to focus on the real key of the adjuvant treatment in the EGFR positive disease, I think that, of course, we need to focus, we need to strongly improve the long-term tolerability. So in my opinion, it's very difficult and different to treat a patient without a disease with a patient with a disease in clinical setting. So when we're treating a patient with osimertinib adjuvant setting, the compliance is very different from the same drugs in the metastatic disease. Of course, the relapse on the CNS, in the ADAURA trial, there was a no-brain MRI postponement. That's the study design. And this is very, very important for all patients that should be treated, including the adjuvant treatment, not only with EGFR inhibition. EGFR, HAL-cross, in my opinion, we need to stress the use of brain MRI at the beginning of this kind of treatment. And of course, we need to improve the survival, but also the cure rates. Today is very difficult to understand how we are curing this kind of patient. We have a very insignificant hazard ratio, but it's very, very difficult. And of course, the use of MRD and blood testing should be very, very useful here. Looking for the future, excluding neo-ADAURA that will be a test in the adjuvant setting, at the present time, there are also ongoing 2 similar trials in the same setting. So the ADAURA 2 that are including patients with stage 1A, and the target study. Target study is a phase 2 trial that include patients with the same characteristic of ADAURA and also patients with uncommon EGFR mutation to receive osimertinib adjuvant setting for 5 years. This is why, because of course, during the disease-free Kaplan-Meier curve, so we can see that after 36 months, there was a drop down in patients that was receiving osimertinib. But I think that concluding my presentation, when we are discussing disease-free survival from perspective of patient, we need to really understand the impact of these kind of drugs on the patient, on the family, and the quality of life of our patient. Thank you very much for your attention.
Thanks, Antonio, for your very interesting presentation. Are there any questions from the audience? No questions? I have a question for you. What about the role of adjuvant osimertinib in stage 1B TNM8 edition? Do you treat all patients in your clinical practice? Do you omit chemotherapy or no?
So the question of chemotherapy is very interesting, and there is no clear answer here, I think, looking on the data, because when we look on the data, we can see that the chemo is not required for this kind of patient. But I think that the stratification according to the stage show that there are very different stage 3A with the stage 1B. So for patients with a high risk stage, in my opinion, we need to suggest to our patient to receive chemotherapy and then to receive osimertinib. That, in my opinion, is very, very similar to the idea of the flower-2 in metastatic disease. So we are jumping back to the use of chemo in patients with the driver, because on the tumor heterogeneity, the chemo is the key. So in my opinion, for high-risk patient, the use of chemo should be considered and discussed with our patient. For patient with the stage 1B, no chemo, I think is a good choice.
I agree.
Hi, Giuseppe. I would like to raise back the question about the immunotherapy, because you presented the data and the explanation for the K-not failure essentially is just because the patient did not receive a proper treatment.
Yeah, maybe yes.
Because there is this big difference between the IMpower and.
So it's very difficult. So I have this idea because
two main topics. One is one anti-PD-L1, one is an anti-PD-1, and the patient population were similar. And
yeah. So if we translate the data of the metastatic disease, I think that the kind of drug is not too key to understand if one trial is positive, another is not positive, but not strong positive. But I was in a meeting with Mary O'Brien that was a part of the group with Benjamin and the others that explained that maybe the impact of the COVID could be an answer here, because it's very strange that there was a not so strong improvement. But in my opinion, the view and the flow of this kind of trial, of course, confirmed the benefit for this kind of patient.
We have a question from the online participants. In your opinion, which is the best treatment duration of osimertinib? Do you think that 3 years is enough, is too much? What do you think about?
I don't think that the 3 years is enough, but I think that the idea of the stratify this kind of approach on the stage, on the clinical characteristic, and maybe in the future with the MRD will be the key. It's very, very clear that the benefit is stronger, very stronger, but it's also very clear that after 36 months of treatment, there is, of course, a decrease in the benefit of the higher relapse there. So I think that maybe the target trial will be able to improve our understanding. And I'm very, very curious also to understand the results of the Alina trial in the similar setting, because it is not the same disease, to understand if we can also match some idea from the biologic perspective. So at the present time, of course, not less than 3 years, in my opinion.
There is a question from Professor Pazzares.
So Antonio, there is some reluctance from some people to use drugs when there is no impact in survival. So, I mean, let's say we have seen here a clear improvement in DFS in the relapse rate. The truth is that the survival is being improved in the trial, in the data, but the crossover, I mean, the number of patients that receive osimertinib in the control arm was really reduced. Is that, do you think survival is needed or is not that important to treat those patients? I can tell you that I'm happy. I mean, I'm not particularly obsessed with survival in this setting. I think it's more important to really decrease the relapse, because survival here is driven, but not having the proper treatment in the control arm as compared to. Another different thing is that we hope to cure more patients. Do you think we are curing more patients here?
No. So I reply to your last question. So I'm not sure that we are curing patients, particularly with the DNA-based disease. So here we have a predisposition of DNA. So we have a very different kind of disease to the IO treatment, for example. And I might agree with you with the concern of the ADAURA. So in the ADAURA, a high number of patients did not receive OSI in the control arm. This was also related to geographic use of the trial. Also, there was not the mandatory evaluation brain MRI after the surgery that, in my opinion, is very important to understand which kind of rate of this kind of patient is a micrometastatic or not metastatic disease. But jumping from my last slide with the patient perspective of DSF, I think that, in my opinion, it is not strongly required in US when we are discussing of a young patient with kids at home, with a very working daily life. And I think the disease-free survival here could be a strong option for our patient.
Yeah, because I think likely with the Alina, we are going to go back again to this discussion,
Yes.
you know, that remember the cisplatin versus carboplatin discussion we have some 30 years ago.
Thank you, Antonio. I have another question. What do you think about the role of ctDNA monitoring, which could be the role? I mean, its feasibility, or it's easy to do during the follow-up in advanced setting?
So I think that the problem of the easy or not is easy. So the problem is a financial cost of the use of our patient. So monitoring is considered that we need to test, I don't know, every month, every 3 months, every 3 months. I think that on the other hand, it would be more important to try to standardize this for before the treatment. So ctDNA, MRID, now I think it's be enough before the treatment. For the monitoring, I think that we are very, very far in the metastatic disease. This is not the standard. The Apple trial from Benjamin Jordi was very interesting to understand the monitor there, but in metastatic is not the standard. We are treating this patient with more than 10 years with this drug. So I think that less could be more if we are able to stratify our patient at the beginning with MRD and ctDNA. I think with also limited cost when we standardize with kind of testing.
Okay, thank you.
Thank you.
So let's move on with the next speaker, Dr. Tina Cascone from the Anderson Cancer Center. She will talk us about the neoadjuvant setting. Thank you.
Thank you. Thank you so much to Laura and Sarah for the very kind introduction. Such a pleasure to be here. Good morning, everyone. Wonderful to be home. Before we start, I really want to express my gratitude to the mastermind behind this meeting, Dr. Lo Russo. Thank you so much for putting this wonderful panel together and for having me as part of it. So I really want to build a journey today. I think Antonio did a wonderful job really setting the stage for me to now taking all these therapies in the earlier setting and really offer you an overview of what we have learned on neoadjuvant and perioperative therapy for wild type and oncogene addicted patients with non-small cell lung cancer. Here are my disclosures. So this is an outline of my presentation. So we'll really review the results of select phase 2 and phase 3 trial utilizing immunotherapy and chemoimmunotherapy for patients with resectable, and I should say medically operable and fully resectable non-small cell lung cancer. We'll also talk about some of the novel trials testing immuno-oncology agents in the neoadjuvant and perioperative setting. We'll touch base on some key of the controversies in the space, and we have some, and follow up with what we are doing for patients with oncogene addicted cancers in this setting. So very quick background, you all are aware of the fact that approximately 25% of patients with non-small cell lung cancer will present with, again, medically operable and fully resectable disease. And while surgery still remains the curative intent approach for these patients with some early stage and some locally advanced resectable disease, if treated with surgery alone, approximately 30 to 60% of these patients will experience recurrence of their disease. And based on meta-analysis over the past 20 years, we have learned that neoadjuvant, so preoperative or adjuvant postoperative platinum-based chemotherapy only offer a 5% improvement in overall survival. This is, we'll all agree, not enough for our patients. So what about the advantages? Well, first of all, the rationale and the advantages of giving therapy in the neoadjuvant or perioperative setting. So in the neoadjuvant setting, we can really hope for a robust activation of the immune system when an intact tumor is still in place, based on Swanton data with perhaps the highest tumor neoantigen burden, as well as a low clonal resistance. We have an intact immune system, an intact vasculature. And by combining chemotherapy, so cytotoxic therapy and neoadjuvant immunotherapy, we can really aim to a maximal response upfront, and we can examine the surgical sample for guiding therapy in the adjuvant setting. And perhaps one of the most important points while we really do neoadjuvant therapy, the rapid readout of therapeutic activity based not on hard endpoints, which we have discussed so far, so overall survival, disease-free survival, but based on surrogate endpoint of clinical benefit, MPR, major pathological response, or PCR, complete pathological response, and the opportunity to learn what's the next step, what are the next trials if we do translational analysis and pre and post-therapy samples. Now, in the perioperative setting, we're trying to give therapy throughout the surgical setting, here with the hope to enhance the micrometastatic disease killing and trigger anti-tumor immunity for the long term. So we have heard about PD-1, PD-L1. What about combination of multiple immune checkpoint blockade inhibitors? There are several lines of evidence that support this combination. Several investigators here, I summarize really the results from Jim Ellison's group, really have shown that combining PD-1 and CTLA-4 might make a lot of sense because we're really expanding two different populations of immune cells that could be responsible for an effective anti-tumor immune response. Remember that PD-1, PD-L1 axis blockade really expands and exhausted like CD8 T cells. Type of population within the tumor, so these are TILs. But the CTLA-4 inhibition really tends to expand what we call the TLP1 TBET positive effector ICOS positive T cells. And when we combine those two type of blockade, we really can exploit both mechanisms rather than utilize what are employed with monotherapies. So the NeoSTAR trial was the first randomized phase 2 trial, a single institution trial that really tested 3 doses of neoadjuvant nivolumab as compared to 3 doses of nivolumab, again, PD-1, with low dose, 1 dose only of ipilimumab, a CTLA-4 inhibitors, using a surrogate endpoint MPR as a primary endpoint of efficacy. So 10% or less viable tumor in resected tumor specimens. These were patients with resectable disease, stage 1 to 3A, AJCC 7th edition. And you can see here really the wealth of the translational analysis that we plan on this trial with pre and post therapy and longitudinal sample collection. In the intention to treat population, and you can see the results on the table on the left, the nivolumab plus ipilimumab led to a numerically higher MPR rate, so 38% as compared to 22% with the nivolumab monotherapy, and the PCR, which was a secondary endpoint here, 29% versus 9%. And then in the middle, you can see that in the population of patients resected on trial, these frequencies were even higher. The combination immunotherapy led to a 50% MPR rate as compared to nivolumab monotherapy, 24%, and a highly encouraging PCR rate, 38% with the combo as compared to 10% with monotherapy. And you can see on the right, hopefully, the magnitude of the pathological regression with these violent plots. So you can see a significant reduction of viable tumor with the combination as compared to nivolumab monotherapy. Now, I want to point out to a phenomenon that we really learned about as we were conducting this trial, a phenomenon that consistent in the apparent radiographic progression of nodal disease upon treatment with immune checkpoint inhibitors on the NeoSTAR trial. You can see here representative PET-CT, where really there is a flare of the mediastinal lymph nodes after therapy compared to baseline, what we call nodal immune flare. At the beginning, we thought that this was really a progression of the disease. We started taking patients off trial. But when this phenomenon started to occur more frequently, we decided to really do a thorough analysis of all the lymph nodes biopsied or resected compared to baseline mediastinal staging, and we did not find any evidence of tumor in these lymph nodes, but the evidence of non-cascading granulomas, so a sarcoid light reaction that was completely de novo. So this was not present at baseline. And this phenomenon occurred in 16% of patients on NeoSTAR. We leveraged what we call an icon set. This is a cohort of chemotherapy, neoadjuvant chemotherapy treated patients, and we saw that really there were no cases of non-cascading granulomas post-chemotherapy, telling us that perhaps this is a phenomenon to be expected more frequently with immunotherapy rather than cytotoxic chemotherapy. And it's particularly important because we don't want to take potentially surgery away from our patients. And so please biopsy these lymph nodes if you have a hint of potential progression after immunotherapy to really distinguish NIF from progression of the disease. Now, several phase 2 trial, I only selected a few here in this table, utilize this combination approach of platinum-based chemotherapy and immune checkpoint inhibition with PD-1, PD-L1 therapy. And really, as you can see on the right, led to highly encouraging MPR and PCR rates that really we have not seen in the past with chemotherapy. Remember, conservative MPR rates to platinum-based chemotherapy is approximately 15%. And for PCR, we have a median of 4%, 0 to 16% conservatively. So we amended the New Start trial, we dropped the randomization, we transformed this in a platform trial of single arm studies where we can use the MPR as a rapid readout of activity to really take a promising regimen to larger randomized trials. As you can see here for patients with resectable disease, again, AJCC 7th edition, we launched an arm C with nivolumab and chemotherapy for 3 cycles, followed by, upon completion of enrollment, an arm D with a nivolumab chemotherapy and ipilimumab, again, given a low dose, 1 mg per kg, learning from the toxicity in our melanoma patients. Again, cycle 1 only, 3 cycles, followed by surgery, standard of care at the discretion of the treating physicians, and pan sample collection for longitudinal analysis. So these data were just published. Really, you can see from panel A and being the intention to treat population at this time, EGFR and ALK mutant and rearranged respectively patients were not excluded. So you can see numerically higher MPR rates with the combination of Nivo, EP, and chemo, 50% as compared to 32.1%. And we'll see how this compare for the Nivo chemo arms, of course, in an exploratory fashion with the CheckMate 816. You can see similar PCR rates, but hopefully you can see a very nice numerical increase in the proportion of patients that had a near PCR with the quadruple therapy, as compared to patients who received chemotherapy, and a much higher proportion of patients with the Nivo chemo that had beyond 50% viable tumor. And you can see the pathological regression with the violin plot. When we did a post hoc analysis, excluding all the known EGFR and ALK patients, then you can see here even higher, 62.5% with the combination of Nivo, EP, and chemo, as compared to 41.2% MPR rate for the chemo Nivo. What about novel agents? In the locally advanced unresectable setting, we have learned that novel immuno-oncology agents can have significant therapeutic activity, specifically the oleclumab, which is an anti-CD73, blocks the production of immunosuppressive adenosine in the immune microenvironment. The monalizumab, which is an anti-NKG2A, so restores CD8 and NK cells immune activity. And then the dambatirsen, which is an anti-oligosense nucleotide, which blocks the STAT3 and reinvigorate the immune system. So we took the lessons learned from the COAST trial in the locally advanced unresectable setting, and we tested 1 dose of durvalumab, a PD-L1 inhibitor, with these novel agents in what is the NeoCOAST trial. This is a global randomized trial, and it's really the stereotype of a window of opportunity trial. Really, we don't want to look at significant differences between arms in terms of MPR or PCR rates, but really want to look at immunomodulation and learn on what to do next. And so you can see here for patients resected on trial, numerically higher MPR rates with all the combination as compared with durvalumab monotherapy, again, 4 weeks of therapy only, chemo sparing approach, where we had a 12.5% with durva only, pretty much similar to what we've seen with single agent, so monotherapy immune checkpoint inhibitor in the neoadjuvant setting. And again, the beauty of doing something that can lead to something else. So from the NeoCOAST trial that was just published last week on cancer discovery, we took the lessons learned from the CheckMate 816, what we learned from the NeoCOAST, and in a perioperative approach, we're now testing platinum-based chemotherapy plus oleclumab, monalizumab, or the MEDI5752. This is a brand new bispecific blocking PD-1 and CTLA-4. As well as other agents. We have the TROP inhibitor here, anti-leaf, and so forth, in a platform type of trials that really will allow us to build new arms as the science moves those agents forward. This is a phase 2 global trials with primary endpoints, PCR, safety and tolerability. You can see a wide spectrum of secondary endpoints. And really what this trial wants to do is to take a positive arm, an encouraging arm to the phase 3 randomized setting to benefit our patients on a larger scale. So what about the phase 3 setting? So what have we learned so far? So hopefully this slide summarizes for you some of the select completed and ongoing phase 3 trial in the neoadjuvant, in the adjuvant that Antonio nicely summarized, as well as in the perioperative setting. And for the sake of this talk today, I really want to focus on how the standard of care has changed with the CheckMate 816 and really explore what are we doing in the perioperative setting, as I truly feel that the treatment landscape, including immunotherapy for lung cancer, will continue to expand more in a perioperative fashion rather than in a neoadjuvant or adjuvant solo fashion. So this is the CheckMate 816 trial, AJCC 7th edition, patients with medically operable and resectable non-small cell lung cancer, stage 1B to 3A. 3 cycles of platinum-based chemotherapy containing cisplatin or carboplatin plus nivolumab, PD-1 inhibitor, followed by surgery and additional therapy at the discretion of the treating team. Primary endpoint, co-primary endpoints, PCR and EFS. So you can see on the left an incredible improvement in PCR rate. As I mentioned, recall that conservatively PCR rates to platinum-based chemotherapy are approximately 4%. With a range of 0% to 16% across 20 years of platinum-based trial in the neoadjuvant setting. So you can see here PCR rates 24% as compared to 2.2%, so close to what we have learned is the media, approximately 4%. And on the right, you can see I put here the updated EFS data at 3 years presented by Dr. Girard at the European Lung Cancer Conference this year. So you can see an EFS as a ratio 0.68, favoring the combination of nivolumab plus chemotherapy compared to chemotherapy alone. Again, very encouraging overall survival data from Dr. Girard's presentation at 3 years, and as a ratio of 0.62, favoring the combination of nivolumab plus chemotherapy to reduce the risk of progression of death with this combination for these patients. I want to point out one important piece of information. I know that this data will most likely inform the field soon, but for the CheckMate 816 in terms of biomarker analysis, approximately 46%, if my memory serves me well, of the patients who had available data had a clearance of ctDNA between cycle 1 and cycle 3 of therapy. And of these patients, approximately 54% had a PAT-CR. So it's very important to really bring the ctDNA and MRD monitoring in the early stage setting, but we do not have definitive data on what to do with that information at this point in time from the CheckMate 816. What about the perioperative approach? So neoadjuvant therapy surgery followed by a maintenance type of adjuvant approach with chemotherapy alone. So the AEGEAN was really the first randomized global trial that informed the field with these the results of this approach. So 4 cycles in the neoadjuvant setting with durvalumab, PD-1 inhibition plus chemotherapy with PCR and EFS. As results here, you can see again an improvement in the PCR rate with the combination of perioperative chemoimmunotherapy, 17.2% as compared to 4.3%. And on the right, a relatively not very long follow-up, so 11.7 months. So maturity of the data here will be paramount. But you can see still a very nice encouraging improvement in the EFS with a combination perioperative approach 0.68 as compared to chemotherapy followed by placebo alone. The Keynote 671 tested the same paradigms for cycles of pembrolizumab, PD-1 plus chemotherapy, followed by surgery in 1 year of pembrolizumab in overall a similar population of patients, so stage 2 to 3B resectable non-small cell lung cancer. Again, a significant improvement in PCR with the combination, and a very nice improvement with an hazard ratio of 0.58 in the EFS for these patients. And then the NeoTorch is a very important Chinese trial, phase 3 trial that is still ongoing. We have stage 3 patient results. I was fortunate to be the discussant of this trial, the ASCO plenary series. This trial had a particular type of approach because it tested 3 cycles similar to the Checkmate 816 of neoadjuvant toripalimab, a PD-1 inhibitor very well used in China, plus chemotherapy, followed by an extra cycle in the adjuvant setting, so a 4th cycle given later, followed by toripalimab maintenance. So again, only stage 3 data available. You can see here a nice improvement in PCR, 24.8% as compared to chemotherapy followed by placebo, and definitely an indisputable benefit with an hazard ratio of 0.4 for stage 3 patients who, remember, have a relatively worse prognosis across the resectable early stage locally advanced, with a nice separation of the curves, and again, not reached event-free survival for the tori plus chemo arm as compared to 15.1 months for the placebo arm. And as the treatment landscape keeps expanding, just 3 days ago, 72 hours ago, we learned about this press release from Bristol Myers, Checkmate 77T positive for EFS. Here we have the perioperative nivo plus chemo, followed by nivolumab as compared to chemo, followed by surgery and placebo. Please keep in mind, this is the only trial that, while testing an approach that has been already shown to be effective by a GN new torch and 671, this is the only trial that has the standard of care as the neoadjuvant component. So it will be absolutely critical to perform a landmark analysis to understand the contribution of components, and again, in an exploratory fashion, cross-trial comparison. And we look forward to see these results presented at upcoming meetings. So what about key controversies in the field? This is a particularly important topic to me, and I know to many of us in the field, because we really don't know at this moment in time if all clinical subgroups of patients really benefit from this therapy in a meaningful approach, especially if we think about stage 2 versus stage 3 and PD-L1 status. And then, as Antonio mentioned, really we don't know, because we don't have a randomized trial to answer this question at this time, whether the perioperative approach with the continuation of adjuvant after neoadjuvant chemoimmunotherapy is superior to a neoadjuvant or an adjuvant approach only. And when we think about this question, as we develop potential answers for this question, we have to think about really the clinical toxicity, the financial toxicity, the surgeries cancellation. A lot of our patients might not make to surgery if treated with neoadjuvant approach rather than an adjuvant approach. And again, what's the contribution of the components? So for the first question, very quickly, for the Checkmate 816, we have learned that while all subgroups really benefit from this approach, the stage 3A seem to benefit probably in a greater magnitude, as you can see from the hazard ratio compared to the stage 1B and 2. And as the PD-L1 expression on tumor cells grows, as you can see here from the forest plot, the benefit grows from chemoimmunotherapy as compared to chemotherapy. The same holds for the Aegean. Again, you can see a greater benefit with an hazard ratio 0.57 for patients with stage 3A disease, a greater magnitude of benefit for patients with 50% or higher expression of PD-L1. Similarly, again, for the 671, stage 3 patients had a relatively greater benefit compared to stage 2, and definitely an hazard ratio 0.42 as compared to 7.7 for patients with PD-L1 positive, highly positive disease as compared to PD-L1 negative. And then in NeoTorch, a very impressive hazard ratio 0.3 for patients with stage 3B disease. And although patients with positive PD-L1 disease benefited the most, really an encouraging 0.59 hazard ratio for patients with PD-L1 negative. So perhaps from this approach, also some select patients with PD-L1 negative disease might benefit. Toxicity, this should not be neglected, especially in a population of patients that is potentially curable. So approximately 40% of grade 3 to higher treatment-related adverse events across trial, non-new safety signal. But for the perioperative approach, and I'll just go quickly as the next 3 slides are really making the same point, we have some deaths from the administration of adjuvant therapy post-neoadjuvant immunotherapy, 1.8% for the Aegean trial, and 1% for the Keynote 671 with a death that happened in the adjuvant phase of the study. And for the NeoTorch trial, definitely a higher 3% treatment-related adverse events leading to that. That is something we cannot neglect when we think about this prolonged therapy on trials. Approximately 20% of patients don't make it to surgery, so 17 to 22% with the overall comparable resectability rate and R0 resection rate across the new torch, the Checkmate 816, the Aegean, and the 671. Now, I want to leave you with another important type of answer to the second question that I had in the issues that we want to discuss. As you can see from the Checkmate 816, patients who do not achieve PCR but do receive nivolumab still do better than those patients who don't achieve PCR treated with chemo alone with an hazard ratio of 0.87. If you look at the Keynote 671, the separation of the curves for the non-PCR patients is much greater, suggesting that perhaps that adjuvant component might be beneficial, but we cannot make really final conclusion. And the same is held for the NeoTorch, where you can see that magnitude of separation of the curves might be perhaps related to the adjuvant administration. If we need adjuvant therapy, do we need it for 1 year? So the Nadim-2 treated patients with stage 3 resectable disease with a neoadjuvant and nivolumab plus chemotherapy, followed by 6 months of nivolumab, not only show benefit with the perioperative approach, specifically in the PCR populations, but to me what's very striking from these supplementary figures is that for patients who had an R0 resection and completed adjuvant nivolumab, really those were the patients who had the best survival outcomes as compared to placebo control and to those who were resected but did not complete adjuvant therapy. Oncogene addicted patients, we do not have much data. A lot is cooking for this population of patients in the neoadjuvant setting. This is a trial led by Colleen Blakely at San Francisco, UCSF. Just presented at ASCO this year, a really small population of patients, single arm, 27 patients treated with osimertinib for 4 to 6 weeks of therapy. Very surprisingly, 48% of patients had a reduction at least of 50% residual viable tumor, but no PCR and 15% of MPR, which is overall similar to what we learned with old chemotherapy. The Aegean results in the GFR population was just presented a couple of weeks ago at the World Lung by Dr. Harpole. You can see here a little bit of discrepancies between a small number of patients, 51 with EGFR mutant non-small cell lung cancer on the Aegean. But really the point is that there is not much benefit apparently from the Durva plus chemotherapy in terms of PCR rate, so 3.8%. Compared to nothing as compared to the what I've shown you already, the intention to treat population, and really no differences in benefit, no meaningful clinical benefit with an hazard ratio 0.86. This is really what is going on for this patient population. So a lot of trials in the context of the LCM-C4 with a neoadjuvant and perioperative targeted therapy that will be matching really the alterations for these patients. And so in summary, we have learned that these therapies are effective. Still would strongly encourage all of us to discuss these patients at tumor board. Phase 3 trials in the perioperative setting will tell us more about really the contribution of components, although we don't have yet a randomized trial to answer these questions. And perhaps for patients with no PCR, we really should think about how to rationally intensify and change therapy, learning from our breast colleagues perhaps, and think about how the molecular profiling can inform us. We know that there is no clear benefit from these therapies for our EGFR mutant patients. We'll learn for the other oncogene addicted population, but I really want to take a second to remind us to really profile these patients before disposition them to neoadjuvant immune-based therapy. Now that we have the ADAURA, we'll have the ALINA soon, and so forth. So with this, I thank you for your attention, and it's been a pleasure really to be here today.
For this brilliant presentation. Now I'm very happy to present Professor Benjamin Bess from the Thoracic Oncology Unit at the Instituto Giuseppe Lo Russo in Paris. He will give us an update about locally advanced non-resectable non-small cell lung cancer. Thank you. Welcome.
Thank you very much, Sarah. Thank you for this very nice invitation again. I was there last year, and it's always very pleasant. We saw an amazing bunch of data on preoperative chemo IO, and we are dealing now with unresectable non-small cell lung cancer. So you will face a phase 3 patients. Surgeon will say, well, it's really borderline. I don't think I can make it. What will you do tomorrow? Will you do directly to chemorad, or will you try upfront chemo IO just to see if with this type of high efficacy regimen, you will not be able to have surgery in your patients? And I think during the panel question, this is something we can raise, is that my fear is that chemo IO will be for any stage 3, and then we will see what happened. The data I present now are data at the time where chemo IO was not an option in these patients up front. My disclosures. So we need a definition of what is a resectable non-small cell lung cancer. There is no clear definition. You know, there is a gradient in Europe. North of Europe, chemorad. South of Europe, surgery. So IRCCS, which is a European network, said, we need to set up at least a definition so that in randomized trial, we all use the same terms to define what is a resectable non-small cell lung cancer. So they did a very, very nice initiative, while it was led by the IRCCS Lung Cancer Group with other scientific societies. So it's a very classical consensual definition with the Delphi process, and this is where they come. So you can see that N2, single N2 seems to be in most of the cases, except for T4, something that is resectable. I have to say that in my institute, if it's a pneumonectomy plus N2, usually we don't think it's a good candidate. Well, now you see that N2 multiple is really where there is debate. When bulky N2, which is defined by more than 2.5 centimeter or invading around is something where it's not resectable. And then we have the T4, and we know that for T4, depending on what it invades, it can be different. So I think this definition is very good for clinical trials. Chemorad is supposed to be the standard of care in unresectable non-small cell lung cancer. Where it comes from, it will be very fast. It will be 30 years of history of chemorad in non-small cell lung cancer. So the first trial of chemo plus radiotherapy versus radiotherapy was done in the 90s. And then meta-analysis was done 20 years later with more trials. It shows that on the left side, chemorad is better than chemo. You have 4 curves because you have the PFS improvement and the OS improvement. And then the pooled analysis showed that concomitant chemorad was superior to chemorad, sequential chemorad, not on the distance relapse, obviously, but because of a better local control. So it became a standard of care. Then more chemo is better. So induction chemotherapy is a way to give more chemo. The first trial was negative, and additional trials showed that consolidation chemo showed that it's not an effective way. So 2 cycles of platinum-based chemotherapy combined with radiotherapy is now standard of care. Which regimen we have to combine? Well, etoposide plus cisplatinum is very popular in some region, in particular in the US. Vinorelbine plus cisplatinum is also very popular, whatever the histological subtype. Pemetrexed can be used. I don't know if you use in non-squamous pemetrexed, but it is a very safe combo. It has been compared to etoposide cisplatinum in a very large study, 600 patients randomized between eto-cis versus pemetrexed cis. It was a superiority study, so the study is negative. But if you see the overall survival curves, it seems to be pemetrexed cisplatinum seems to be a very decent regimen. And in terms of toxicity, you divide by 2 the number of neutropenia and 30% less thrombocytopenia. So this is, at least in my institution, a standard of care for the non-squamous. PCI has been tested, prophylactic cranial irradiation, and is not relevant there, but just take a look at this. In the N2 positive patients, at 3 years, 44% of your patients will have brain mets. 44% will have brain mets. It will decrease probably with the use of durvalumab, but it means that you have to use brain RMI in the follow-up of your patients. Radiotherapy, I'm a medical oncologist, so it will be only 2 slides, but we have seen improvement of radiotherapy using PET scan, using also device to block respiration during the radiotherapy, so you can decrease the toxicity. And obviously one of the big question is proton better than photon? In my country, we have only 3 proton centers. I don't see the number rising very soon. So even if the trial is positive, I'm not sure it would change practice in 99% of the world. So consolidation immunotherapy is the standard of care. You know by heart the Pacific data, it increased the PFS, giving 1 year of durvalumab compared to a placebo in stage 3 post-concurrent chemorad. 1 year durva post-concurrent chemorad. It increased PFS and it increased PFS in the PD-L1 positive, although in the negative, it doesn't. A lot of discussion around this data. It's a post-hoc analysis. Only 2/3 of the patients had tissue to be analyzed. So with that, the quality of this data is really debatable. FDA gave the green line to all comers and PD-L1. EMEA restricted the indication to the PD-L1 1+. Sometimes EMEA said, I really don't like post-hoc analysis. And sometimes EMEA said, oh, I will give my approval based on the post-hoc analysis. So I think it's a bit unfair, and there might be some benefit in the PD-L1 negative population. What about the real-life data? We have the Pacific R, which is a collection of more than 1,400 patients treated with chemorad followed by durvalumab. It shows that the PFS in real life is very near to the one of the randomized trial Pacific. And if you look at the data, PD-L1 positive versus negative, yes, you enrich in responder like almost any studies with PD-L1, but it's not randomized data, so it doesn't support strictly the use in PD-L1 negative. We have a second randomized trial that is a Chinese trial, and there we have 2 main differences with Pacific. Here, the patients were treated by either concurrent chemorad or sequential chemorad. And the second point is that sugemalimab with PD-1 inhibitor was given for 2 years and not 1 year as durvalumab. But as you can see, the hazard ratio for PFS is very close to the one that you see for durvalumab. Interesting to see that the benefit was seen in the sequential and the concurrent chemorad, but PD-L1 was not formally tested. The tissue was available in half of the patients only, so there is no formal data that help us to again understand what is the role of immunotherapy in the PD-L1 negative patients. A good thing is that FDA said in the US, durvalumab is approved post-concurrent chemorad, but EMA said durvalumab is approved after chemorad. And in the label of durva in Europe, you don't have sequential or concurrent. So by the book, you can use it, not in the PD-L1 negative, but you can use it after sequential chemorad. And I think these data support the fact that it works also in this population. Can we escalate immunotherapy? Well, a way to escalate chemotherapy is to give immunotherapy earlier. So instead of giving immunotherapy as a consolidation part, you will give immunotherapy during radiotherapy. We have 5 small phase 2 trials that shows that in terms of 1 year overall survival, it's very concordant among all these studies. Roughly 80% of the patients are alive after 1 year. Response rate, there is nothing you can say really strictly because response rate after chemorad is very difficult to assess. And in terms of toxicity, it seems to be very reassuring. But I always have a concern on those small phase 2 because usually they have strict criteria in terms of tumor size. So it might not mimic exactly what you face in a clinical practice. And there is a large randomized trial, Pacific 2, that will compare the Pacific regimen to an earlier introduction of durvalumab during chemotherapy. So this data might, again, change the field. Another way is to intensify immunotherapy. So maybe we can do something else. And Tina talked about that with the NeoCOAST trial. And in fact, so you remember it was mostly these 2 drugs, oleclumab and monalizumab. I'm not completely convinced by the preoperative data that we have seen. I think it's a very small cohort. There might be a signal, but the same trial was done after chemorad, and it compared in a phase 2 durvalumab or durvalumab plus one of the two drugs. And the trial is quite positive. If you look at the PFS, it's very convincing. Both drugs seems to boost durvalumab efficacy, but the main issue is that the durva curves is a catastrophe. So the PFS here is like, I think 6 months or something like that. Yes, 6 months for the PFS. It's 17 months in durva. So by chance, you have a control arm that completely underperformed. There is a trial ongoing called Pacific-9 that is a randomized phase 3 trial. But I think that this is what is sometimes a bit scary with immunotherapy, is that patient selection is something you cannot control so much. And maybe by chance, in the durvalumab only arm, you put patients with poorer prognostic factor, but this is something you cannot see. Well, you will hear at the end of the day what senescence means and what other factors can be used, but probably just PD-L1 is not enough to select the patients. And it reminds me a lot of this. You remember this study. This is metastatic patient, but it's in PD-L1 high positive. They have compared atezolizumab to atezolizumab plus tiragolumab, an antibody against TIGIT. But again, if you look here, the PFS was a catastrophe in the control arm. The PFS of atezolizumab was 4 months when you expect 6 to 8 months. And we heard, well, long time ago now, 18 months ago, we heard that the phase 3 is negative, but we haven't seen the data. And I think this is also something that is not completely fair. Having a press release in May 22 and today in September 23, we still don't see the data. I think it's not very fair. If there is a press release, we should see the data within 3 months. Well, anyway, TIGIT will be also maybe a player in the field, and a lot of studies compare durvalumab or durvalumab plus an antibody against TIGIT. The last strategy to escalate immunotherapy is to give it even earlier, so before chemorad, as an induction regimen. So there are a lot of trials here. Data from melanoma, I like very much data from melanoma because for immunotherapy, they are 5 years ahead. So I always said, if you want to know what will happen in lung cancer, just go at next ASCO to the melanoma session. You will have the positive results that we will have in 5 years. So they did the neoadjuvant versus adjuvant immunotherapy and showed that neoadjuvant is much better, but this is melanoma where 100% of the patients can have surgery because it's a very simple surgery. What happens when you give neoadjuvant, it happens that although you have very nice response rates, and again, it's 24% of pathological response is amazing, but in the phase 2, it was 63%, and nobody can explain, but maybe this is something we can discuss after that, why you drop from 63 in a phase 2 to 40 to 24 in a phase 3. This is something I cannot, but it just tells you that selection of patients is something we don't understand anything in the selection of patients for immunotherapy. And this is, for me, one of the key issues of the neoadjuvant chemo IO is that 15 to 20% of the patients do not go to surgery. And my fear is that tomorrow in your stage 3, you will say, oh, it's a stage 3, let's start chemo IO. And when it could be a very nice candidate to chemorad, after 3 cycles, it will be a bigger, you will have, this node flare, and then your radiation oncologist will tell you, well, we have to restage completely the patients because I have new positive nodes. Do I have to put these positive nodes in my field? And maybe it will be too big to be eligible for radiotherapy. So I like very much to choose the local treatment up front. And let's be very cautious when we use neoadjuvant, induction chemo IO. TKI, I like very, very much this study. So this study was done before the era of EGFR mutation. It was just when we had gefitinib and an EGFR inhibitor, and that's all. So the good thing was say, well, Kimora is standard of care. Let's give 2 years of gefitinib or a placebo, 2 years of gefitinib, but in all comers. EGFR mutation was not assessed. The study is highly positive, but the gefitinib arm is here. With gefitinib, the overall survival was 1 year less. 1 year detrimental OS with adjuvant gefitinib in all comers. Just to remind you that when you apply 60 to 66 grays in a cancer, you might modify a bit the biology, and nobody knows what is the biology of a cell that is able to resist 66 grays. And an inhibitor that you have that seems to be very nice in the metastatic setting might act a bit differently in the post-chemo IO. Let's always keep that in mind. We don't know what is the biology of these tumors. Cetuximab didn't make it, and concurrent gefitinib is a catastrophe in terms of tolerance, so never give concurrent EGFR TKI with thoracic radiotherapy. It's deleterious because it's very toxic. These drugs are sensitizers to photon. And consolidation trial will be done in the LAURA trial. Osimertinib will be given till progression. So it's not 3 years, it's as long as you're alive, you can take osimertinib, which is also maybe a debate we can have. What about the data? The PACIFIC-R data, there is a small subset of 44 EGFR mutated non-small cell lung cancer patients that you can compare with the wild type. The disease characteristics are quite similar, and the EGFR patients have a poorer PFS. I don't understand that very much. Well, it's a very small population, but it might be that because it's EGFR and because you know you have the EGFR TKI, maybe you switch as soon as you see a sign of progression. When it's wild type, you have maybe a progression, you will wait a bit more to see on the CT scan if it's really a progression or a radiation-induced pneumonitis, for example. But the OS is exactly the same, maybe also because it's the use of the TKI. So the ESMO consensus published by Antonio last year said a very high consensus level, 90% to say no consolidation durvalumab in the EGFR mutated non-small cell lung cancer tumors, even if PD-L1 is high. Can I re-challenge when I give 1 year of durvalumab? This is a question. Very large cohort of more than 1,000 patients treated with 1 year durvalumab. You can see it's all type of tumors. Overall, all type of tumors, response rate is 11%. 14% in the patients with non-small cell lung cancer, but a small cohort. What about the data in Pacific? Only 34 patients had a re-challenge. We have not so much data. We know that half of these patients are alive without progression at 4 years. While it might be something that you can do, there is one formal Japanese study that has tested re-challenge, whatever the type of immunotherapy you receive. So all these patients had advanced non-small cell lung cancer and all receive immunotherapy. So either they had a partial response or a complete response, either they receive at least 6 months with a stable disease. They receive nivolumab. 59 patients are eligible, are available, and you can see the response rate and the PFS are not very, very good. What they show, but it's a very, very small subgroup, is that maybe when you have a very long interval between the end of your first course of immunotherapy and the re-challenge, this is something that could work. And personally, I have to say that when the interval, the free interval without immunotherapy is lower than 1 year, I usually do not re-challenge immunotherapy. New tools, very, very, very important. Minimal residual disease will help probably to select the patients that should be eligible for intensification. Let's remember that ADCs might enter the field of metastatic disease, and you know the story. If it's positive in second-line metastatic disease, ADC will move to first-line metastatic and then to consolidation. So there might be also a place in those patients that receive chemorad, consolidation durva, with still some positive minimal residual disease. There might be a population where you want to escalate the treatment and give something different. And radiotherapy has also to move to a next step that is not all the tumors are the same, and sensitivity to the tumors should be based also on the type of biology to the tumor to give the adequate amount of dose. So my take-home message is that concurrent chemorad is standard of care. 2 cycles of chemotherapy are enough, but probably, as me, you induce the patient so that you can have time to plan the radiotherapy when the field is a bit busy. Platinum is, of course, the standard of care. Consolidation with durvalumab is standard of care in the PD-L1 1+, but there might be a benefit in the negative. And neoadjuvant chemoimmunotherapy will force us to rethink completely the field of chemorad, because we might discuss local treatment after 3 cycles of chemo IO and not upfront as we are doing now. With that, thank you.
Thank you, Dr. Bess. Now it's time for a discussion. I want to invite Dr. Pastorini, Dr. Cascone, Dr. Bess also for the round table. And I'd like to know if there are some questions from the audience, online or in presence. We can start. I have a question for Dr. Pastorino. Do you think it's possible to extend the lung cancer screening to other subjects, not smoker subject, maybe considering other risk factors?
I think this is certainly a need in other areas of the world. So it is certainly necessary for Far East to invest in detection of lung cancer, non-smoking, and younger female, because the majority or at least half of the lung cancer fall in this category. To activate screening in our population, where the risk of cancer in a younger non-smoker is very, very low. At present, it could only be a pilot. I think I would favor a pilot study on families, so on women non-smoking or light smoking with a family history of lung cancer. That is a trial we could afford to do even in Europe. But for the proper non-smoker young individuals, we have to wait for the data and look at the mutations, which are of course much more common in the other side of the world than our side.
Thank you. Are there any questions?
I have a question for the speakers. As we know that multidisciplinarity is actually crucial to guarantee our patient the best approach. What about the patient treated in small centers? Do you think that we should organize some MTD with referral centers, or we should centralize this patient?
Dina?
I can start off. So actually, this is a very critical question. I appreciate you asking. So first of all, I hope we convey really the importance of MTD for patients with resectable and locally advanced, marginally resectable at time, as there will be trials that actually will enroll this population of patients on neoadjuvant paradigm as well in the near future. So really the treatment landscape and the treatment approaches are really changing. And we are fortunate enough to be part of, gigantic centers where we have tertiary centers where we have subspecialty, but as we reinvigorate really the opportunity for patients to participate in trials and even in standard of care paradigms, if they have resectable disease, we have to keep in mind that not all patients can come to major centers. So there are several initiatives also driven by patient advocacy groups that are really trying to implement also as part of major sports and, larger grant initiatives in United States, and I'm sure in Europe as well, where we're really trying to establish an hybrid model where we have a multidisciplinary tumor board once, every 2 weeks rather than usual once or twice a week, where community centers can actually present these patients and really benefit of the expertise or the larger volume that some centers might have to really have the patients still be treated locally in the small center rather than, disrupt the logistics for patients and their supporting system. But so this is something that hopefully we'll see more and more in the near future.
Dr. Bess?
I think it's a frequent concern. So first of all, we should be sure that everybody get proper workup, for example. We talk about ADORA. We don't know the percentage of patients that had a PET scan pre-surgery in ADORA, but it seems obvious for you to do a PET scan. But in a country where you cannot have a crossover to osimertinib because it's not available, it's so expensive, do you think they will perform a PET scan before surgery? So is it really fair to have an adjuvant treatment where maybe a third or 24% of the patients will be metastatic? So I think it's very relevant to say that maybe the stage 3 should be treated in high expertise centers, but I think that delivering a very good care everywhere would be a very, very mandatory first step. I like very much network for rare malignancy. I think this is mandatory to have, for example, surgery for thymoma should be done only in expert centers. Now, if we decide that stage 3 is like a rare malignancy and should be treated in a network, I'm not sure this is something that will be accepted easily. And is it feasible also? But I agree with you, the surgeon, the quality of the surgery is key. And we have seen in the adjuvant treatment that the quality of surgery, but maybe Hugo, you can comment on that, is very, very heterogeneous. I know that in the US, it would be a lobectomy plus maybe picking two nodes and that's all. It's considered a very good surgery, where other will have a very large node resection. So, and radiotherapy also. We have quite, I love very much our radiotherapists, but they are able to really take care of big tumors and they are not afraid. And I know a lot of radiation oncologists, when it's too big, they say, well, it's too big, I will not do it. So, and I think we always think about having good surgeons, but it's key also to have very well-trained radiation oncologists that do only lung cancer and know how to deal with the big tumors.
I don't have much to add. I think in the ideal world, yes. But in the real world, you cannot manage a common cancer as a rare cancer. So the answer could be, as you said, the networking. So the fact that multidisciplinary group may not belong to the same institute. Now we do home working in the majority of a condition. Why shouldn't we? Discuss the cases in the TC that involve a major center and small center and decide which are the critical cases that may benefit from the best radiotherapy or the best surgery. There's no doubt that the quality of surgery is not homogeneous as the quality of radiotherapy, but you cannot move the patient. You may discuss them together.
So just I'm gonna make a question that doesn't mean I believe everything I'm saying, just to be controversial. The truth is that we are used to make the decisions upfront. So if the patient is completely staged, then we decided the multidisciplinary team what to do. But that is in the times of neoadjuvant therapy having limited role and limited impact. Now, for the first time, we know that neoadjuvant chemo-IO is able to actually change impact on the extent of surgery needed. That was not true before that. So we know now that in stage 3 at least, we're likely to decrease the number of radical surgeries to even being able to have a patient with an oncological resection. So the issue is, we are used to say this patient is resectable, this is not. This is not based actually on the surgical abilities. It's mainly based on the extent of the tumor indicating the likelihood of having systemic disease. So let's say we are having a patient that is N3, many surgeons like Dr. Pastorino would be able to take it out. The problem is very likely the patient is having micrometastasis. Now that chemo-IO is particularly good at controlling systemic disease, if Dr. Pastorino is able to take N3s, maybe into the future, we have to see if there is a role for, let's say, single station. I'm just being a bit, out of, we have to study that. But today, if you look at those trials that you presented, the chemo-IO, we have very little information, for example, of N2 disease, multiple N2 disease. So the truth is only good information on one trial out of all of them. And we have to follow expert advice instead of robust data. So taking all of that, to be honest, I'm not sure today we have to make in every single cases decisions upfront. If I'm having a patient which is multiple N2, maybe, or two stations N2, and it's a young patient, is not candidate for right pneumonectomy, likely I'm gonna go chemo-IO and then do remedial stenoscopy before surgery. And if it's N0, I go for the surgery. Just to give an example, where I think that upfront decisions maybe not always the right thing to do. Of course, we have to test that. I'm not saying this is, So what do you think about it?
Well, you have provoked me, actually putting in my head what is not. I mean, I like to remind you that it was a surgeon that introduced mediastinoscopy to avoid the surgery for N2 disease. This was Cliff Pearson, and this was many, many years ago. So the good surgeon stepped back much more often than bad surgeon. So I mean, this is not. I mean, we don't do right pneumonectomy in a stage 3 disease since 10 years or more. We simply don't do it. Salvage sometimes, but not up front. And the same is true for N2 disease. We have not operated in clinical N2 disease without induction in the last 20 years. But what induction is your responsibility, not ours. It's you that have to say, instead of chemo, it is better to do chemo-IO or whatever. This is your responsibility, not the surgeon.
But the question was not that, actually, Hugo. The question was, if the patient is having N2 disease to start upfront, some people may say, well, this is a patient for chemo radiation, not to induction and then surgery. That is the discussion I like to, yeah. So I put it here. If we are having an N2 patient, 2 stations, and the patient is downstaging to N0, maybe that's a candidate.
Okay, let's before you answer, let's ask the room. So you heard what Luis said. N2 patient, no surgery up front. Chemo-IO,
not needing.
okay. Chemo-IO, pathological clearance of N0. Who would go for surgery? Don't be shy. I would go for surgery. Who would go for radiation therapy? Okay, so it's 4 people for surgery and 0 for radiotherapy, which is a big difference. You know?
So first of all, Louise, this is a, I wouldn't say contentious, it's a provocative, question that you have. And it sounds like every Tuesday afternoon at Tumor Board. I mean, it's exactly what happens every week. So this is the reality of things, despite the data that we have. I want to mention that we have patient-related issues that we discuss at Tumor Board, anatomy, function, logistics, and so forth, that we have to keep in mind in 2023. We cannot just look at our patients as a scan, right? And, a composite of organs. And we have expertise and we have opinions and practice guidelines. So as you put all these factors together and a lot of, experts or, hybrids, models in the Tumor Board, you can have, as you can imagine, so many different results across the world. I think you're absolutely correct when you say that we don't know enough from the percentage of a multi-station N2, bulky N2, as compared to N2 single station across trials. This is information that as investigators, we're all trying to tease out from the sponsors. The single institution or investigator-initiated trials can help the field in that setting. But of course, it's the phase 3 randomized trial that is going to give us some more robust answers. I personally feel that as we discuss all these factors in Tumor Board, we cannot take the opportunity of chemoimmunotherapy away for patients with multi-station N2, stage 3 disease, which seems to be benefiting from these approaches, perhaps even more than the stage 2, where the argument can be, do we go surgery up front followed by adjuvant therapy? And that's a well-taken argument, given the cancellation rate 20%. Perhaps in the United States, we're not that much cavalier in doing, pneumonectomies as compared to the Europeans. But remember that there is heterogeneity even in each countries, right? At MD Anderson, we do pneumonectomies, and I'm not a surgeon, but all the time, and we don't understand why pneumonectomies are not allowed in many phase 3 trials. So there are several issues that I think as we proceed with our trials, as we have trials that will take patients that are perhaps not truly resectable up front, and have them to a specific type of paradigm as compared to a neoadjuvant immunotherapy paradigm, rediscuss the patient tumor boards. IRCCS is going to deliver a white paper on all these aspects. But again, it's going to be center dependent. And I think the next steps will tell us perhaps more of the answers.
So what you like to do, what you say is that I might not discuss surgery up front, but rediscuss surgery after 2 cycles. And my answer would be, why don't you rediscuss radiation therapy? Okay, let's take an example. Hypopharyngeal cancer. It's not very far, or it's a squamous, not very far. What are the guidelines? Induction chemo. If the patient has a response, radiation therapy is the treatment because it's a conservative treatment and because it works as well as surgery, if not better. If there is no response to chemo, then they know radiotherapy will be useless. So it's surgery. When we tend to think completely the other way in lung, why don't we do surgery in those patients that are resistant to chemorad, because resistant to chemo, because maybe it's the only way to cure some of them, because a patient that is resistant to chemo probably is resistant to radiotherapy. So it's just that I agree we need trials. We thought at IRCCS about trials, and we end with it's not feasible because we don't see how we will be able to randomize these patients after 2 cycles. We think it will not be feasible, but we might be wrong.
But I think mandate, or at least encourage, the rediscussion of all, potential options, radiotherapy or, additional options after the chemo in patients that have N2 multi-stations, or they're perhaps borderline resectable upfront. And many times we disposition into induction, especially in large centers anyway, and then we will take the approach of definitive chemoradiation. This happens all the time in real world. So I think mandating, a rediscussion at Tumor Board, and then perhaps learning about those experiences, I think will be very helpful.
Yeah. So just, I agree. I agree, Benjamin. I just like to try to say that we maybe do not have enough knowledge The only thing is that as compared to 10 years ago, we can say now today that we have something which is pretty active systemically. That was not the case. And then we have not to be maybe today as dogmatic. Comparing to hypopharyngeal disease, there is a very clear difference in terms of behavior. Hypopharyngeal disease resistant to radiation, to let's say, is mainly a local regional problem. This is not the case on the lung cancer, which is more a systemic disease. And that is why I believe that is something that we have to study. Doesn't mean, you know, the other good thing is that we know that on a feasible patient, chemo-IO is feasible before chemoradiation. That didn't know 2 years ago. And then I'm not that worried that I'm doing, and then I made the final decision on local regional treatment after 3 induction chemo-IO cycles. That I was not as sure 2 years ago, but now I'm okay with it.
Yeah, but it is completely different condition. The problem of you know, first line surgery for into disease is a problem related to the first referral and to the thought of the patient that thinks that the only chance of cure is a surgery. And this is the past, of course, but it remains. Once you have passed this step and you have opted for induction treatment, then it is essential to retest, to rediscuss the patient in multidisciplinary after you have achieved your best response. I do agree that for patient with a poor response, surgery can be an option if it is not a major surgery, and then you can keep radiotherapy as adjuvant. This is what we do. But again, once the patient is in the end of the multidisciplinary group, it is for this group, and particularly for medical oncologists, to rediscuss this instead of sending the patient to the radiotherapist. That's it, because it was unresected up front, and then after induction, it has to go to radiotherapist. So everyone has to share the responsibility in the first evaluation and in the re-evaluation. I hope that the reality will be what you have mentioned, that the chemo, immuno chemo targeted is completely reverting the scenario. But we have not seen this yet. We have not seen a major increase in the referral of a stage 3 disease to surgery after the new therapies. So something is certainly has to be changed or improved. But it is a common responsibility to be shared by all the actors.
Can I ask a question if there is time? Ugo, this is just perhaps out of standard of care context, but to piggyback on Luis' question, just out of interest and curiosity, if there is a robust tumor board for a patient with N3 disease, wonderful ECO-PS, wonderful anatomical condition, just the N3 cytologically proven disease. If patient is dispositioned to chemo-IO and there is a complete radiographic response, you do a bronch, there is no disease, would you take that patient to surgery or not?
I mean, if it is the best option and the surgery can offer something more than radiotherapy, why not? We are ready to extend the indication after new therapies, but this, as I said, this must be a shared decision, and this must be a peculiar condition for the patient. I have not seen many of those cases of N3 disease that become operable after. I mean, they are. I hope I will,
but it's
before I retire, but I think I don't have enough time.
No, it's encouraging to see the willingness. I think it's definitely, you know, moving the field forward.
Maybe we have time only for another question. There is question. There are. Okay.
So maybe I'm just gonna go for another issue, which is we are in Europe and we have here EMA, and then we have more restrictions at the country level. I know in US, maybe in France, in my country, if I have a patient with a stage 1A, 1B, 95% PD-L1 status, I can give chemo, I cannot give atezolizumab today. Even the hazard ratio is 0.42 in that subset in terms of DFS, and patient with stage 1B, 7th classification, the risk of relapse is close to 50%. So what do you do? Should we, in a patient like that, because we know adjuvant chemo is, adjuvant IO is not allowed, should I use chemo IO? This is a perversion of the rules of the, you know what I mean, right? So what do you do?
Well, if in France, adjuvant atezolizumab is not refunded. They decided not to refund it, which is I think a bit crazy. My issue is with a DFS of 0.6, you don't refine a drug, but you still allow to do adjuvant chemotherapy. Adjuvant chemotherapy is a nightmare. Patients stop working for 6 months. They have late side effect. And what is the benefit? OS benefit is the hazard ratio is 0.87. 0.87. So we should be logical. If the payers say no atezolizumab, let's be logical. Then don't give chemo either, because when there is an external patient that come and pay his chemo, we charge 35,000 euros for an adjuvant treatment, which is what it costs. So let's be logical. Let's keep it. So we should, if we restrict. It's a political decision, but we should be aligned with all the adjuvant.
I agree with Benjamin. I think that for me in these situations, I'll tell you, Luisa, I have a very thorough conversation with our patients, because many times they come with literacy now and they will tell you, well, but I have 95%, why you don't want to give me, right? But so you explain to them what's the problem with the stage and, you know, the regulations and support. We have 1%, you have 50%. We're still in the bucket where the 95% will trigger, right, this question. I have a thorough conversation with the patients. At times, I would be in the situation where I'm even inclined to do a peer-to-peer with insurance in US, just to understand what are the, you know, pros and cons to offer back to the patients. But I agree, there are restrictions for one reason. And I have seen a lot of late effect, immune-related, you know, on adjuvant treatment with atezo. And in a stage 1B, that's something that, considering the risk of relapse and that's a ratio that you have, I think it's something that if you put it all in context, you can convince yourself, right, pretty soon that perhaps you shouldn't be doing that.
So thank you all. Thank you, speaker, and the audience. It was a great discussion. It's time for lunch. So let's go for lunch. We will come back at 2 o'clock. Thank you.
Okay, I hope you enjoyed the lunch. It's time to start again with the second. Okay, it's time to start again with the second session dedicated on non-oncogene addicted advanced disease. Let me introduce you, my colleagues, that will be the chairs of this second session, Dr. Marta Brambilla and Dr. Teresa Beninato, both working in the thoracic unit at the Istituto Nazionale dei Tumori of Milano. Teresa and Marta, it's your time.
Good afternoon. Thank you, Giuseppe, for the possibility to be here among such an extraordinary faculty. Now, let's start with the first presentation of this section. It is a very pleasure for me to introduce Dr. Paolo Bironzo from the University of Turin. And today he will talk about the role of new and old biomarkers in the EC therapy. Thank you. Welcome.
So thank you, and thank you to the organizer for this possibility to share with you some of my thoughts about all the new biomarkers. So we can start. These are my conflict of interest. And so the first question is, what do we really want when talking about biomarkers, especially in the case of immunotherapy? We would like to have something with a high sensitivity and high specificity, something that is easy to be evaluated, not only in a big institution, but in all the hospitals, and something that could be reproducible. And these biomarkers could give us some prognostic information or some, hopefully, some predictive information for our patients when we are, as oncologists, planning to treat our patients. And so we can have some information about the treatment strategy, or even the type of treatment, the specific drugs we would like to use. And hopefully we would like to have biomarkers because thanks to all of these things, we could improve our patient outcomes. And what do we have right now is PD-L1, you all know that. These are the last European Society of Medical Oncology guidelines about non-small cell lung cancer without driver alterations. And as you can see, PD-L1 is the one of the only biomarkers or one of the most important predictive biomarkers to choose our treatment strategy. But this is based on results. We know that the PD-L1 positivity with at least 1% could somehow inform us in the advanced disease that immunotherapy may work. But if we look deeper in this data, we can see that the higher expression of the biomarker could probably select the best patients for a single agent treatment, while for the 1 to 49%, according to this subgroup analysis of the Keynote-42 study, this is probably not the case for all patients. And what we know about chemoimmunotherapy is that this kind of equation is not the same. For non-squamous non-small cell lung cancer, it works, the combination of chemoimmunotherapy nearly for all of these patients. And we see something similar in squamous, but in negative patients, the signal is less stronger with the triplet combination therapy. But what is the biggest limitation of PD-L1? Biologists and immunologists told us, and one of the biggest one is the heterogeneity, the intratumor heterogeneity, the spatial heterogeneity in different sites of the tumor, and also the temporal heterogeneity according to the time we take our biopsy. This is a case from our institution of the same biopsy of the same patients, and in different parts of the tumor, you can see different expression of PD-L1. So the first question is the PD-L1 the higher the better? This is the Keynote-24 data about PD-L1 high expressors. Cutoff is 50% of expression. And we can see that pembrolizumab in this study works better. It increases overall survival and progression-free survival as compared to chemotherapy with platinum-based schemes. But we have also data from a series, real-world series, that if we take the cutoff higher and higher, we probably select the best patients that could have the best long-term benefit from single agent immunotherapy. But we have novel ways to look at PD-L1. One is about copy number. We can see that if we have few copy number of PD-L1, the immune systems works better than if we have a high copy number of this of PD-L1. And we have also data of series of patients that if they have a loss, they have a poor prognosis. Progression-free survival is less as compared to those with gain of PD-L1, for example. And also, if we put it along with the PD-L1 expression levels, we can try to select the best patients that could receive the best outcomes with the single agent immunotherapy by putting together these two phases of the same biomarker. And also there are data about functional engagement that has been shown in translational studies that could predict better the outcomes of our patients as compared to the expression of PD-L1 levels. And if we put together the data of PD-L1 expression along with the presence or the absence of the functional engagement of PD-L1 with PD-1, we can also stratify better our patients. And also there are other actors, multiple actors. This is just one example about platelets. There is this paper on Nature Communication from 2021. They show that platelets actively receive PD-L1 from tumor cells, and that platelets could modify the immune system response, a modification that could be changed by applying to the platelets and the immune system cells, of course, the anti-PD-L1 agent. And also this data could become something useful in order to stratify better our patients by looking at another one phases of the same biomarker that we are taking as a dogma at this time. How about tumor mutational burden? This has been a hot theme for lots of years in lung cancer studies. We know that non-small cell lung cancer is one of the tumors, are some of the tumors with the highest tumor mutational burden. And this high tumor mutational burden correlates with some kind of signatures that are pro-immunogenic signatures. And we also, research has also found a possible cutoff on tissue biopsy of 10 mutation per megabase to try to select patients for immunotherapy strategies. But we have also some drawbacks of tumor mutational burden, and are that this kind of biomarker is based on different kind of methods to be assayed. The cutoffs may depend on the methods, on the source of the biomarker, so the biopsy, the tissue biopsy as compared to the liquid biopsy, and so on. So this had lots of layers of complexity. And where are we? Nowadays, we are at this point that when we look at trials using tumor mutational burden as a biomarker, sometimes in the design of the study, in other times as a post-hoc analysis, what we see is that patients with high tumor mutational burden may have a better progression-free survival when treated with IOs, single agent or double IOs, but this does not reflect into survival differences. And this kind of effect is somehow removed by the addition of chemotherapy. But why TMB is likely not enough? That's because the clonality of neoantigens is something that we have to look at. Not all neoantigens act the same for the immune system. We have to look at the antigen presentation machinery that sometimes is not efficient. We have to look also at HLA, HLA-2 heterozygosity that increase the likelihood that what we see as a high tumor mutational burden is something that is significant for this patient. And also we have to look at single nucleotide variants as compared to double nucleotide variants. For example, that there are plenty of data that suggest that this kind of alterations are more immunogenic let me use this word if you're not an immunologist, so pardon me. If we look deeper in this in clinical data, we can see that oncogenes have a role. We know that. We know, for example, that with KRAS mutant tumors, if we have some other commutations, probably it changes the probability that immunotherapy may not work in these patients. For example, in double mutants, KRAS and STK11 tumor patients with this kind of tumors, or also in patients with KRAS mutant plus KEAP1 mutations, while this does seem not to happen in patients with wild-type KRAS tumors. And also we have this data about companion mutations when looking at chemoimmunotherapy series, where this kind of mutation, the sum of the mutations may indicate at least a poor prognostic subgroup. But probably it's not just a matter of single mutations. And for example, for KEAP1, we know that loss of heterozygosity may have the biggest role. It's not just the mutation. And we learned that from the historical data about oncogene addictions. And even here, if we have a mutation, it's not just the mutation, but it's the role of the mutation. And also we have data about diploidy, for example, and we know that diploidy can also help us sometimes to imagine, to predict the outcomes of our patients and to stratify them into patients that deserve a more aggressive treatment, probably as compared to a single agent approach, as an example. Then we have some what I call easy predictive factors that are the oncogenes, and most of the oncogenes, those that are clustered to non-smoking patients, such as EGFR common mutations, as well as HER2 insertion deletions, probably RED rearrangement, but of course ALK and ROS1 rearrangement are poor predictive factors for immunotherapy. And so as we have listened this morning about Durva after chemoradiotherapy in patients with EGFR common mutations, that applies the same for the metastatic setting. So this is an easy way to exclude some patients from immunotherapy. For some of these subgroups, ALK and EGFR, they were not included in most of the registrational trials, of course, but it is something we have to look clearly. And then we can get more to the surface, back to clinical factors, and the most important one is this one. It is smoking status. It's the most important, from my point of view, the clinical factor that we have to consider. We all know, and it is something that is also based on biological aspect of the disease, that smokers and former smokers have the highly likelihood to have a benefit from immunotherapy alone or in combination with other immune checkpoint inhibitors or even with chemotherapy. And also there are new data or some new data about sex. And so gender could influence the likelihood to respond to single agent immunotherapy. And this is a meta-analysis published 2 years ago by Fabio Conforti. And also when we put the gender with the body mass index, we can also learn something about the likelihood probably of our patients to be a responder or not to immunotherapy. And then we have to look at other aspects to get new insights. And some of them are this one. The microbiome is something we are talking every time in every oncological meeting and nowadays in every meeting in medicine, I think. But we have some data about the role of microbiome in these patients. We have also data from our colleagues of nuclear medicine. There are new tracers that could help us in looking in vivo where our drugs are getting, if they are drugs that hit the target. And also we have the other big thing that is ctDNA and the so-called liquid biopsy that could help us in monitoring these patients, and probably in the future we can try to design trials that could increase treatment based on this monitoring or decrease the aggressivity of our treatment based on these dynamics. Sorry, okay. And then there is probably the next frontier, and is putting together all this data, all these folks, just not to be the folks of mine, of some people doing research in lung cancer, but to get back to the clinic. And the one example is that coming from France about this kind of platform to study biomarkers in a prospective way in different populations treated with immunocheckpoint inhibitors with rebiopsies and lots of biological markers to put together with clinical data and try to speculate how to select patients in the next future. And another big example is that is this example that is based in Milan, indeed, and is a way to study from a retrospective and also prospective view, multiple sources of data putting together. Arcela will talk this afternoon later about the potential of artificial intelligence, another hot topic in medicine. And this is probably one of the ways to try to be at least more precise in this kind of imprecision. So to conclude, so old or new biomarker, I would say for now old, but with a closer look at the new ones. And with this, I would like to thank you.
Thanks, Dr. Bironzo. I'm pleased to welcome our second speaker, Professor Andrea Ardizzoni from University Hospital Sant'Orsola from Bologna. Today, he will share with us the most recent advances in IO monotherapy and combo IO therapy in non-small cell lung cancer. Welcome, Professor Ardizzoni.
Thank you. Thank you very much for the invitation. Okay, my topic is single agent immunotherapy or the combination of two immunotherapy agents. My disclosures. Okay, let's start with the evidence that we have to support the use of a single agent IO in advanced non-small cell lung cancer. So even if it is a little outdated, I think the first point, the first evidence that we started from is the use of single agent therapy in the second line setting. And we have 3 studies that compared single agent nivolumab or pembrolizumab or atezolizumab as compared to standard of care chemotherapy, docetaxel, in patients regardless of PD-L1 expression, or in one study in patients with PD-L1 more than 1%. Again, it is the past, obviously, but this curve to me is the most amazing data that we have for immunotherapy in lung cancer, and explains very well the revolution that we have seen with the introduction of immunotherapy in lung cancer. Because in this context where it is the worst scenario, patients already been treated with first line therapy with a prognosis of few months, we now have almost 15% of the patients alive at 5 years. So something that we have never seen in our life in standard practice, for those like me that have some years of experience. And this is something which is not only in the papers, it's not only in the journals, something that we face every day. This is one of our patients that was lucky enough to be enrolled in the compassionate use program with nivolumab in 2015, having been treated already with 3 lines of chemotherapy with very advanced disease, got 2 years of nivolumab, got complete remission, stopped nivolumab because the plan in the protocol was to stop after 2 years, and now 6 years later, without anything, any treatment, still in complete remission. So I would think we can agree this is a sort of miracle in the area of lung cancer. So obviously, this is the past. What the reality now is that these agents now are the standard of care in first line. And as far as patients with high PD-L1, meaning 50% of more of expression, we have 3 studies with similar design that compared single agent pembrolizumab or atezo or cemiplimab versus combination chemotherapy, including cisplatin. Briefly, you know very well the studies. This is the first KEYNOTE 024, that in patients with high PD-L1 and without EGFR mutations or ALK translocations randomized between pembrolizumab or platinum-based chemotherapy for 2 years. And these are the results. And as you can see, immunotherapy doubled the median survival. So we go from 13 months to 26 months. And we double the 5-year probability of survival. So from 16% to almost 32%. And again, this is something that we are verifying in clinical practice. Again, one of our patients started with a terrible situation with brain metastasis, widespread lung with lymphocytic infiltration, lymphangitis in the lung, very heavy symptoms, going into complete remission with the treatment and staying there for almost 6 years now. There are other 2 studies, the Empower 110 that has a similar design. However, here there was no selection for high PD-L1. So the patients were enrolled with any PD-L1 and then subdivided for subgroups in the subsequent analysis. And again, the results in the subgroup of patients with high PD-L1 are highly positive. In terms, as you can see, the numbers are very similar. We have almost doubling of median survival. And the third is the Empower Lung 1, a very similar design to the Keynote 024 with comparison between cemiplimab and a combination chemotherapy platinum-based. And here we have the 3-year survival data showing, again, very similar outcome with a double median survival for cemiplimab as compared to platinum-based chemotherapy. So altogether, we have 3 studies, very similar design, all are positive. The numbers very similar. I've put in the table just to show you that in terms of numbers, so median survival, 1 year, 2 year, 3 year survival, hazard ratio, they are very comparable. So apart from little difference in the study design, et cetera, I think overall they support the fact that for these patients, immunotherapy is now the standard of care for those patients. However, there is a drawback. The drawback is that there is a percentage of patients, approximately 30%, that do not respond, do not do well with immunotherapy. And this is clear in all these 3 studies. As you can see, there is a drop in the PFS curve with patients rapidly going to progression, similar to what happens for chemotherapy arm. So it is clear that there is a part of patients, 1/3 more or less, that do not respond at all or little to immunotherapy. So how can we select or how can we predict? We don't have much. This is one of the studies that I'm proposing my personal experience, our study, but there is also other experience published, supporting the fact that there are some clinical pathological factors that may predict which are the patients who are not going to do well with single agent chemotherapy, mainly the never smokers, the females, some patients with brain metastasis. So there are some factors that may predict this, and we may think for those patients to use something more, like, for example, the combination of chemo and immunotherapy. So let's go to the 3rd point, the 3rd level of evidence for patients who are positive for PD-L1, but not the high positive, so 1% or more. What is the evidence here? We have 2 studies, the Keynote 042 and the Mystic trial. This is the Keynote 042, and this is formally a positive study. As you can see, the first, this box, the red one, the curve, the blue curve is the immunotherapy curve doing better as compared to chemotherapy. The hazard ratio is 0.81. This is statistically significant. However, look at the curve. There is a crossing here. In the first part, immunotherapy is performing worse compared to chemotherapy. And the other point is that this is the PD-L1 high patients. Obviously, most of the benefit here is driven by the high PD-L1 patients. If we concentrate our attention to the low, So 1%, 49. There is no evidence of a benefit of immunotherapy versus chemotherapy. At least immunotherapy is not better than chemo. We can discuss whether being more or less the same of chemo could be positive results anyway, but this is another story. And this is the other study, which is the MYSTIC trial, similar design. Again, look at the curves are very similar. Even the numbers are very similar. 12 months versus 16 months is more or less the same of the keynote 42. Again, the crossing of the curve here suggesting that there are patients that do not benefit from immunotherapy. They do better with chemo, actually. So at the end, the curves separate. So there are patients actually benefiting from immunotherapy even more than chemo, but it is a subgroup of patients, obviously. So in general, I think the conclusion here is that for patients with PD-L1 lower than 50%, there is no clear evidence of a superiority of single agent immunotherapy as compared to platinum-based. Last point on single agent, something very important for our clinical practice. What shall we do in patients that are fragile, poor performance status, like PS2, or elderly patients, or those with comorbidities, which did not enter the previous studies I showed you? We have only one study here, the Ipsos trial, that to me is an interesting study for clinical practice. Here they selected the worst patients, so poor performance status, old age, comorbidities, and they randomized between atezo or single agent chemotherapy in this case. So what we use in clinical practice for this type of patients, vinorelbine or gemcitabine. The study is actually positive. The difference is not huge, but immunotherapy performs better than a single agent chemotherapy. The benefit that the median is only 1 month, but at 2 years, there is a doubling of the probability of being alive with something which is pretty feasible even in this poor risk population. So something that might be useful for clinical practice, even if at this point, at least in our country, it's not possible. The final argument is about, discussion is about the combination of immunotherapy, so-called IO combinations, doublets. What is the evidence here? We have 2 studies, again, the MYSTIC that also had an arm with the combination, and the Checkmate 227. Let's see the data. This is the MYSTIC trial that I showed you before with the other question about single agent immuno versus platinum-based chemo. Here we concentrate on the doublet, which is durvalumab, tremelimumab. Again, as you can see, the problem of the crossing of the curve. So in the first part, chemotherapy is doing better. So there are patients that actually benefit more from chemotherapy than from the combination of 2 immunotherapy agents. Then they separate and the immunotherapy goes up. So overall, this is a negative trial. The study, the difference is not statistically significant. So there is no clear evidence that combination IO could be better than chemotherapy, cisplatin-based chemotherapy in this setting. However, we have another study. This is the Checkmate 227. It's a pretty complicated design. Anyway, the design is a little different. If we select PD-L1 positive patients, where the combination of nivo and ipi was compared to chemotherapy or nivo alone, or for patients with negative PD-L1, where the experimental arm was the same, but the comparator in this case was chemotherapy plus nivo or chemotherapy alone. Look at the curves. This is a positive trial. These are the PD-L1 positive. As you can see, the best curve is for the combination of nivolumab and ipilimumab, 24% at 5 years as compared to 14% for the chemotherapy alone. And there is finally no crossing here in the first part. So it seems that we are overcoming this issue of the crossing of the curve in the first part by using a doublet of IO therapy. And the same applies also for the worst group, the PD-L1 negatives, more or less same results, almost 20% long-term survival at 5 years, almost double compared with chemotherapy, and no crossing again here. So this is, to me, is a positive trial, something that also could also be used in clinical practice. Unfortunately, we are not allowed to have it in the clinical practice. The only point is that in terms of toxicity, if single agent immuno was in general less toxic compared to platinum-based, here there is a balance. Actually, as you can see, if you look at the overall toxicity leading to discontinuation, is actually even higher with the combination immunotherapy as compared to combo chemotherapy. And the toxicity profile is different. There is more toxicity at the hematological level with chemo, and there is more toxicity on the non-hematological level with immunotherapy. So to conclude, I think we have sufficient evidence to say that the anti-PD-1, PD-1 agents have superior efficacy in terms of response rate, PFS, OS, and less toxicity compared to platinum-based chemotherapy in advanced non-small cell lung cancer patients with PD-L1 high, 50% or more. There is a possibility of a long-term survival around 30% at 5 years with pembrolizumab. And so pembrolizumab, atezolizumab, cemiplimab could be considered a standard of care for the treatment of non-small cell lung cancer, PD-L1 high, and there is no inhibitor which is proven to be superior to another at the moment. And the question is any patient cured among those? I think yes, and this is something really relevant for this group of patients. The bad side of the coin is that the other side of the coin is that we have 30 to 40% of the patients that do not seem to benefit a lot from immunotherapy. And these are probably the never smokers, females, poor PS, high tumor burden, high growth rate, etc. Should this patient be treated different with the combination, for example, of chemotherapy and IO, something that at the moment we are not allowed to do in our country. And the superiority, however, of immunotherapy versus chemotherapy in the PD-L1 low is not proven at the moment. Probably there is almost an equal effect, but again, this has not been considered sufficient for registration, at least in Europe. And finally, the combination of nivolumab and ipilimumab is the only combo IO which has been proven superior to chemotherapy, regardless of PD-L1 expression, but unfortunately, this is not available in EU. Thank you very much.
Thank you, Professor. Thank you, Professor Ardizzoni, for this very amazing speech. Now let's move on to the third presenter, and I'm very pleased to introduce our great friend and mentor, Professor Marina Chiara Garassino from the University of Chicago. And today she will share with us the news about the chemoimmunotherapy combination in small cell lung cancer. Welcome back.
Thank you, and thank you also for organizing this today, so I could come in presence and not just virtually as the other years. And I can't wait to have the cocktail at the end of the day, which is, in my opinion, is the best part of the day. So the tradition of this Congress started during the pandemic, and we were used to deliver cocktails around the world, and nobody could receive the alcohol in the United States. They are still telling about this story. So here are my disclosures, and this is the slide that you have seen multiple times in the last year, and the rationale of using the chemotherapy everywhere is that is able to induce the immunogenic cell death, is able to eliminating the immunosuppressive cells, in particular the T regulatory cells, is able to increase the T cell penetration, the T cell function, and is able in particular to eliminate the component, the negative component of the immune system, like the myeloid-derived suppressor cells, and potentially also macrophages of M2 phenotype. So this gave to the birth to an incredible numbers of clinical trials, so we don't have the time to review all of them, but basically we started with Pembro, but in particular in Asia, we are seeing really a lot of new compounds that potentially and can be part of the discussion are very similar to Pembro, Semiplimab, Nivolumab, and the first generation of immune checkpoint inhibitors that we saw. The first trial was the Keynote 189. You remember very well, it was Carbo, Cis, Pemetrexed and Pembro over the chemotherapy. The crossover at the time was allowed because if you remember, the pembrolizumab was already approved for PD-L1 more than 1% at the time. Patients were stage 4 without actionable alterations. And of note, and this is very common to also all the other trials, the PD-L1 was a stratification factor, but all these trials did not have any power to see if there was a difference in terms of PD-L1 positive, negative, or in the gray area between 1 and 49. When I saw for the first time the results in AACR, and I was part of the authors, I was really impressed because the hazard ratio was 0.49. It was 6 years ago, and it was amazing because I think that we have never seen curves like that. But the year after, if you see the results, the Kaplan-Meier curves are still fantastic, but at 3 years, we have alive only 31.3% of the patients. And if you look again in the last presentations that I did a year ago, the number of patients alive at 5 years is 19.4, saying that this is clearly a fantastic revolution, but only 1/5 of the patients is alive at 5 years. So we have to try to move forward the limit of the chemotherapy and try to find other possibilities to have more patients alive at 5 years. Of note, I think is very important, if you remember, the majority of these trials were conceived to receive only 2 years of chemotherapy and pembrolizumab. That was empirically done. There was any rationale behind the 2 years. And I think that what is very important to notice is that if you see in the upper part of the curves, there is a huge number of patients that are still alive without any treatment after a couple of years, but there is also a bunch of patients who relapsed, and many of them died when they stopped the treatment. We still don't know, and we don't understand how we can identify those patients that do very well, maybe the clonal neoantigens. There are many reasons for which they can remain alive without any treatment, but there is a bunch of patients that unfortunately progress and die. We tried to find many times alternatives to PD-L1 expression. The TMB was a large discussion that we had in the last 5 years multiple times. And we know that unfortunately the TMB done on the blood, on the tissue, wherever you like, is not a good biomarker to decide who are the patients that can benefit of the chemotherapy and immunotherapy. So basically this is a treatment for all comers, and we don't know how to select these patients. Similar results were found and presented by Luis multiple times for the 407, which is the twin trial in the squamous population. And as you can see, again, a benefit in terms of hazard ratio, suggesting that, again, the chemotherapy is very important for these patients. But again, if you look at the Kaplan-Meier curves, you see only 18.4% of the patients alive at 5 years. So again, similar situation to the Keynote 189. And so again, the need to continue to invent other treatment after the chemotherapy. And again, similar phenomenon. There is a group of patients that are alive without any treatment, but there is also a huge number of the patients that are unfortunately progressed and died and dead after the 2 years. And of note, also consistently also with the other trial, you can see that the majority of the patients who progressed potentially were progressing also before and not just after the immunotherapy, the 2 years of immunotherapy. As Andrea said before, the Pembro is not the only one. There is also semiplimab, and I will show you also other compounds coming from Asia. Very nice results also in this trial. Also, this population was just a bit enriched because it was done only by the smokers, but again, similar hazard ratio, similar safety, similar results. So in my opinion, potentially all these drugs are interchangeable. The big problem that we have is, can we interchange not just semiplimab and Pembro? Can we interchange also camrelizumab and also, for example, tislelizumab? What is happening now is that the companies are creating their pipelines based on their backbone anti-PD-1, anti-PD-L1. And so I don't know what will happen in the future if we will have something that is not approved in the Western countries, but maybe there is a positive trial with, I don't know, a LAG3, a TIGIT, or whatever. So I think that deciding how we will accept this kind of drugs in the future will be very important. As Andrea said before, for PD-L1 more than 50%, the single agent is a standard of care. I just want to present you this data that are real world data presented during the ESMO plenary last year, that they showed that if you pool all the patients independently by the smoking habits, more or less the single agent and the chemotherapy are exactly the same. But if you look at carefully at the results, we know very well that the patients who never smoked in the past, they do not benefit as the smoker. And as you can see from the pink curves and the blue curves, so I know that in Italy, I think at least when I left, the combination was not approved, but I think that in particular for the never smokers, and I would add also the women, I don't think that the immunotherapy single agent is the optimal treatment. In the group between 1 and 49, I think that the situation is much clearer. This is the meta-analysis done and presented by FDA a year ago, pooling all the trials evaluating chemotherapy and immunotherapy alone. And as you can see, the numbers are not very, very high, but the results, I think that they are very clear. The hazard ratio is 0.68. It's true that this is a pooled analysis, but the results, in my opinion, in this gray category suggest that this is the way where we have to go. Moving to the other part that I think will be part of the discussion later is when to use the anti-CTLA-4. Just I want to tell you that when I went to the United States, the anti-CTLA-4 are widely spread, while in Europe, I think that they are less. So this is the trial, the Checkmate 9LA trial. So 2 cycles of chemotherapy plus nivolumab and ipilimumab compared to chemotherapy and the maintenance according to the histology. So this is a very interesting trial, because if you remember, in the past years, we discussed a lot about the phenomenon of the hyperprogression that sometimes we see when we use the single agent or when we use the combination with the anti-CTLA-4 without the chemo. So this trial incorporating a short course of chemotherapy just for 2 cycles and the maintenance. But again, if you look at the results, and I put everything in the slides, these were the results that were presented for the first time. So no crossing of the curves in the beginning. At 1 year, 63% of the patients alive. But 1 year later, it was 38% again, and we arrived to 27% again. So you see that during the time, independently by what you use, there is a continuous attrition and the loss of patients independently if you use the anti-CTLA-4 or not. So the second, and if you compare the results of the trials with the immunotherapy, with the single agent and chemotherapy alone, like the 407 and the Keynote 189, you can compare only the 3 years. But if you compare the 3 years, we have 38%. If you compare here, sorry that I am blind now, I'm becoming presbyo. So 27% at 3 years, then you have 29% at 3 years, and you have 31% at 3 years. So you don't see a huge difference on the landmark curves. And again, if you look at the results based by PD-L1 positive and PD-L1 negative, you see that the hazard ratio is 0.67 and is 0.74. So the results are not so different. And again, if you look at the results at 3 years, more or less, they are similar and they are the same. So it's part, I say that because big part of the discussion is whether to use or not the ipilimumab, in particular in the PD-L1 negative. And again, if you do again the same comparison, so you see that on the landmark trial, on the landmark curves, you can see that it's true that there is just a bit more for patients treated with the anti-CTLA-4, saying that I'm sure that there is a 5-6% of benefit more in PD-L1, less than 1% in adding the anti-CTLA-4. The big problem is that we are not able to identify who are those patients from the beginning. And again, there is the story that you heard multiple times, that the best way to give the anti-CTLA-4 are the squamous PD-L1 negative, but if you look, 25% on the squamous and 25% or the non-squamous. So the reality is that unfortunately we don't have a biomarker. To complicate further the situation was the Poseidon trial that Andrea presented some minutes ago. So chemotherapy combined with durvalumab and tremi and durvalumab alone. This was already discussed, so I don't go in this part, but if you look at the results in the combination with durva-tremi, again, you arrive more or less in a similar percentage of patients. And to complicate further, if you look at the results divided in non-squamous and squamous, you can see that we see exactly the opposite. So the majority of the benefit seems to be more in the non-squamous than in the squamous. So everything that I told you is just that also the STK11, that is another big discussion that we had in the past, is it seems that we can give some benefit more, and I think that more data will come from MD Anderson, from Fernando Scuridis, saying that potentially for the STK11 or LKB1, this could be the best treatment, but I think that again, we don't know how much is LKB1 is a prognostic factor or it is a predictive factor for which we can give to these patients, and also for KEAP1, the anti-CTLA-4. So to conclude, I think that it is great that we have the chemotherapy because we don't see anymore the hyperprogressive disease, in particular in the first part of the Kaplan-Meier curves. I believe that represents the standard of care for patients with PD-L1 less than 1%. I think that still we have a lot of questions that are without an answer. For example, how long do we have to deliver the immunotherapy and also the chemotherapy? Do we need to decrease the immunotherapy maybe in a second part? There is a trial that was presented in India saying that also a very tiny dose of immunotherapy is enough to maintain the response. So maybe we should de-escalate also this kind of trial. We don't know if there is a best synergistic chemotherapy to combine with the anti-PD-L1 and also the anti-CTLA-4. We know that we can just make decisions based on PD-L1 expression. but TMB may be only for the single agent, and I think that the magnitude, there is some benefit of the anti-CTL4. Potentially, it can be really in the PD-L1 less than 1%, but I think that the reality is that we don't have a proper biomarker yet. Thank you for your attention e grazie di avermi invitato.
Thanks, Marina. Now let's go to the last presentation of this section. I'm very happy to introduce Dr. Erminia Massarelli from the Department of Medical Oncology and Therapeutics Research of Duarte, US. She will update us about new agents and their role in the treatment of non-small cell lung cancer. Welcome, Dr. Massarelli.
Thank you so much for the invitation. It's always a pleasure to be in Italy, and especially in this beautiful city of Milan. So these are my disclosures. So I decided to focus the attention on two different treatment options, which are still not completely approved. So we're talking for the future, hopefully. So one is antibody drug conjugates, and the other one is cell therapy. So to start with the antibody drug conjugates, so I would like to talk a little bit about the structure. So they are antibody, they are linked to a cytotoxic payload by a linker. And not all the antibody drug conjugates are the same because there are all the different parts of their structure actually have a different type specific characteristics. So for example, the antibody, they can be either, for example, so their half-life can be different. You know, we're talking about between 7 to 21 days. And then there are some that can bind to the complements and others don't. The other part is the antigen. So we still don't understand if it really these antibody drug conjugates completely attached to their target, because as I will show you later, some of them really don't match with the expression of the particular specific molecule. And so we have antigens that, for example, so the high antigen density in tumors, not normal tissue to limit on-off toxicity. And then rapid internalization to facilitate rapid transmembrane trafficking, enhancing intracellular ADC toxicity. And then it's important the surface localization, which affects antigen presentation after exosomes are taken up by antigen presenting cells. And then we have the warheads, which are mainly constituted of different type of class of drugs. Some are anti-macrotubule, some other are DNA cleavage, and some other are topoisomerase I inhibitors. Another important characteristics of antibody drug conjugates is the drug to antibody ratio. It is important to understand how many of the cytotoxic payload are attached to the antibody, and also the location, which confers specific characteristics. So an important effect is called bystander effect. So that once the antibody drug conjugate is internalized into the cells, then producing the cell killing can actually leak around the cells that is targeted and produce further cell killing, so enhancing this effect. So there are so many basically targets for the antibody drug conjugates. This is only a small representation of some of them. And the mechanism is that basically the ADC should attach to the specific target and then be internalized into the cells. So the cleavable, non-cleavable linker is hydrolyzed, and then the cytotoxic payload is released. So here is the list actually of all the antibody drug conjugates. They are currently either in trials. There is only one that has been approved in non-small cell lung cancer, HER2 positive, which is TDXT, trastuzumab deruxtecan. Another one is approved in breast cancer, which is sacituzumab govitecan, but not in non-small cell lung cancer yet. So I'll talk about three specific antibody drug conjugates for the sake of time, I couldn't talk about all of them. So two of them target TROP2. So one is datopotamab deruxtecan, which is a TROP2-directed monoclonal antibody, highly potent cytotoxic payload, and has a tetrapeptide-based cleavable linker. So the first trial was TROPION-PanTumor1, which was showed the antitumor activity of Dato-DXd. That's how I will call it, because just it's easier to pronounce, and the safety results. So the response rate was 26%. The median duration of response was 10.5 months. The median progression-free survival was 6.9 months, and the median overall survival was 11.4 months. And about the toxicity, so the majority of toxicity were nausea, stomatitis, alopecia, fatigue, and vomiting. Interstitial lung disease, which is one of the toxicity that was observed, was actually considered drug-related. In 2 cases was grade 2 and 1 was grade 4, and occurred in 3 of the 50 patients. So it was 6% incidence. So this drug was then tested in non-small cell lung cancer in association with pembrolizumab, with or without platinum-containing chemotherapy in TROPION-Lung2. And they were tested 2 different doses, 4 milligram per kilogram and 6 milligram per kilogram in the doublet combination, triple combination. So the response rate for any line of therapy was 38%. This was in all patients. But then when we looked at patients in the first line setting, the doublet treatment was, the response rate was 60%. For the triplet was 55%. When we look at the spider plots, we see that the majority of patients actually achieved the response rate within 3 to 6 months, and actually they maintained it. So this was independent of PD-L1 status. So there were patients, for example, there were 12 patients with less than 1% of PD-L1 who actually responded. And same was the triplet therapy in the first line subgroup. So the toxicity, of course, for the triplet therapy was higher than the doublet therapy. So the majority of, so it was mainly anemia, platelet count decrease, diarrhea, neutrophil count, and neutropenia. So stomatitis was also a problem, and it's a very difficult, I think, side effect for patients to tolerate, and also for oncologists to control, because we can do much more than just give them some topical relief. So all these antibody-drug conjugates have different toxicities. So I'll tell you also about the high toxicity in some others antibody-drug conjugates, which I think are important to decide at one point, because most likely we're going to have one approval after the other, and we'll have to decide how to manage this toxicity. And this might be actually a limit of some of the antibody-drug conjugates compared to others. So the interstitial lung disease occurred in 12 patients, so it was at 10%. It was similar basically for the doublet or triplet therapy. So the other trial that was the lung 04, TROPION-Lung04, where Dato-DXd was associated with durvalumab and carboplatin in metastatic non-small cell lung cancer. So here, overall, the response rate in the overall population was 47%. For the doublet therapy was 71% for the doublet therapy, and then 71% for the triplet therapy. And in the first line setting, the response rate were 50% for the doublet and 77% for the triplet therapy. So, so as you can see, basically the responses, these are color coded. So the blue are 50% PD-L1 or higher, and the green is 1 to 49, and orange is less than 1%. When you look at the response rate, basically it was 50% in the first line setting for the doublet, and basically the disease control rate was 93%. In the triplet therapy first line, the response rate was 77%, disease control rate was 93%. So they were across all PD-L1 expression. So about the safety, there were no new safety signal compared to the other antibody drug conjugates. Was mainly anemia, thrombocytopenia, lymphopenia, neutropenia. So I think it was manageable. We talked about the mucositis. So let's go to the sacituzumab govitecan, which is the other TROP2 that actually I wanted to talk about. So this is a highly potent cytotoxic payload. It's SN38 payload, and it has a high drug to antibody ratio. So at World Lung, actually there was the presentation of the sacituzumab plus pembrolizumab cohorts of the EVOC-02 in first-line metastatic non-small cell lung cancer. So across both cohorts, so basically this was in PD-L1 50% or higher, which was the cohort A, and PD-L1 less than 50%, cohort B. And across both cohorts, the most common reason for discontinuation was progressive disease. There were no significant toxicity signal. So basically in both PD-L1 50% or higher or less, there were responses. So the response rate was 69% with PD-L1 50% or higher. And for the cohort B was 44%. And the disease control rate actually was pretty high, 86% for the PD-L1 50% or higher and 78% less than 50%. The safety signal, as I said, there was the usual toxicities. The majority was diarrhea, anemia, asthenia, alopecia, nausea, neutropenia. And overall, it was manageable. However, diarrhea could be a significant problem for the patients. The next that I've actually chosen for a particular toxicity, which is ocular toxicity, is called tuzumab ravtansine. And this is a CEACAM5 target. So this antigen is overexpressed in several tumor types, including non-squamous non-small cell lung cancer. So the response rate was, so this was actually response rate of 20% in high expressors and 7% in moderate expressors. So this one of the ADC that apparently, so they looked at in patients who had tumors with high expressions versus moderate expression. The other two that I talked about, actually, they didn't look at the expression of the antigen, so it was agnostic. So the side effects were mainly, so the corneal toxicity, so it was 38% of all grade of corneal toxicity, which included keratitis or keratinopathy, and 11% were grade 3 or higher. So I think this represents an important problem that we're gonna probably face because, medical oncologists are not used to treat ocular toxicities and will need a referral to ophthalmology. However, when you look at what was specifically, so it was reversible, non-inflammatory deposits starting at the peripheral of the cornea. And the first occurrence was within the first 4 cycles of treatment for 28 patients. So it was 80% incidence. It was manageable with dose delay or dose reduction. And the prior prophylaxis was not effective, but the treatment basically was topical, so ophthalmologic corticosteroids that were recommended. But they needed referral to ophthalmology. So these are just some of the current ADC trials. It sounds like it's a tsunami, so we'll see which one is going to be approved first. The evolution of the ADC is also the connection between bispecific antibody linked to the ADC. So this is an example of EGFR c-MET bispecific linked to ADC. It's AZD9592, the EGRET trial, which includes cohort for EGFR mutant non-small cell lung cancer, but also for EGFR wild type and head and neck squamous cell carcinoma. So the next I want to talk about is cell therapy. So we know that basically the cell therapy includes the tumor excision and then isolation of tumor infiltrating lymphocytes, for then T-cell expansion, and then reinfusion in a patient after conditioning regimen. So there are several challenges in adoptive cell therapy. One is tumor heterogeneity and antigen escape. The other is T-cell trafficking and infiltration. And then there is an immunosuppressive tumor environment. So this was presented World Lung 2023, and it's actually a first-line therapy. So it LN-145 TIL cell therapy plus pembrolizumab in ICI naive non-small cell lung cancer. So these patients, after screening and tumor harvesting, they actually were treated while the TIL were manufactured. They were treated with a single dose pembrolizumab, and then they underwent conditioning regimen with Cytoxan and fludarabine. And then they received the LN-145 product, the T-cell therapy, and IL-2, and then were kept on pembrolizumab for up to 24 months. So they included actually, so patients were largely PD-L1 negative with high disease tumor burden. Treatment adverse side effects were consistent with the underlying disease, and there were no known safety profile, of the myeloablative lymphodeblation and IL-2. They didn't observe any grade 5 toxicities. What was interesting is that the median follow-up was 18.2 months, but 76% of patients experienced reduction in tumor burden, and the response rate was 42%. So there were different cohorts. So one was treatment naive. So they had 4 out of 5 responses, so 80% response rate. Post-chemotherapy was 43% with 3 out of 7 responses. Then they had a small cohort of EGFR mutated post-TKI. So 1 patient responded out of 7, so 14%. And then there were treatment naive or post-chemotherapy, which was 58%, so 7 out of 12. So if we look at the gene, the molecular tests basically of these patients, we see that in the treatment naive, actually there were 2 patients who had KRAS G12V, another did not have any, these are the responders, any gene alteration. And then of course, the one post-chemotherapy, there was an NTRK gene fusion that was treated and ended the response. What was interesting that responses deepened over time in a subgroup of patients. If you see on the spider plot on the right side, you can see that over time, there were some patients actually that had a deepening of their response, which is very interesting. So infused TIL persisted in peripheral blood, and cell dose did not differ by response. So here you can see that the clones from the infused TIL product persisted similarly in responders and non-responders, and the total cell dose infused was similar among the responders and non-responders. So to conclude, I would say that there are several factors to include about eventually looking at treating patients with ADC. Of course, it's still chemotherapy, even if it's kind of more targeted chemotherapy, but has the side effects. So we will have to decide once all these ADC, at least in the United States, I don't know what's gonna happen in Europe, they will be approved, how to select the right ADC for each patient. There are different toxicities. We mentioned mucositis, ocular toxicity. They're more specific for some ADCs. So the other problem is, do we really look at the marker? For example, there are the TROP2 ADCs or the CMET, but how important actually is the expression of that particular marker? Because it seems that some of them actually are a little bit agnostic. So it's not really important, the high expression versus the low expression. And then about cell therapy, is this cell therapy really possible to be implemented in a large scale? Well, most likely not, because it's going to be done in places where they have cell therapy facilities. For example, places where they're already doing transplants. So it's not really like implementable in a large scale. But I think it's very promising, and we're seeing, you know, that already first-line patients are responding, maintaining response for such a long time. Anyway, so this is material for our discussion, most likely. Thank you.
Thank you, Dr. Massarelli, for your perspective on this tough topic. Now I would like to thank all the speakers of this section, and I will invite you to join the stage to start the roundtable while we are checking for questions from the audience. I will start with one question. In the presentation of Dr. Bironzo, we saw that there are that in the next future maybe we would select our patients and the treatment for them not basing on a single biomarker, but more probably on a combination of them. Would you think that it would be feasible in the clinical practice in the next future, or we are far behind from that point?
Thank you. I think that we're still far from that point. I think that lots of clinical factors actually are evaluated, but as a single clinical factor, not encompassing all the other clinical factors. So there are plenty of publication about from steroids to antibiotics to BMI and sex and smoking and so on. But the big risk is to have a bigger confusion when putting all this data together, not in a clear way. So as I finish my presentation, I think that the only way is to prospectively collect data, thanks to big collaboration like yours, for example, and then try to put the best of this data all together. Some of the things that I talked about are not practical biomarkers. You know, that the story about the platelets is something that is extremely interesting from a preclinical and the research point of view, but I don't think it's something that could be ready-made. And so it's something that help us increasing our knowledge in try to simplify things, because otherwise we will not get the point, I think. And we are not ready at this time to get the point beside PD-L1, which actually, as all the speakers said, it's not the best biomarkers we would like to have.
We are interested also to the point of view of the other speakers on that point.
No, I totally agree. And I would add also that maybe we should try to understand what is prognostic and what is predictive. That is not exactly the same thing. So if we see an association or a correlation with progression-free survival and overall survival, does not mean that this is a predictive biomarker outside the randomization. So there is still a lot of work to do.
I don't want to be too much simplistic, but besides PD-L1, I think the other point that convinced me about being predictive is the so-called smoking signature. So the amount of smoke, maybe the oncogene addiction, etc., they go all together, saying that those group of patients do not benefit too much from immunotherapy. So far, to me, this is the only firm point together with PD-L1. All the rest, it seems to me, very speculative at the moment.
So there are some panels actually that have been implemented, studied. You know, there are some companies that already started implementing these panels. You know, this David Gandara's data. They basically look at an interferon-based signature that I think most likely are going to be the ones that we're going to use in a couple of years. That's what I think. Now they're still in the implementation
For
stage.
poor guys, as we are in Italy, we just look at the smoking history and that's enough.
And sex.
Are there questions for the audience? Don't be shy, especially the residents. We have a big possibility to have a, okay. Bravo.
I have a question for Dr. Massarelli. Are there data regarding the correlation between specific toxicity, such as ocular toxicity with anti-CHECK-1 ADC response of the tumor?
Not really. I mean, so that ocular toxicity is a very particular toxicity of that ADC. So unfortunately, you saw that it was 80%, of patients who experience it. So unfortunately, it's a problem with that antibody, drug conjugates. But it's comforting that it's reversible. So there is no actually biomarker, that you can pick for the patients. Yeah.
I have a question about the presentation of Professor Ardizzoni. You told us about the Ipsos trial, but I would like to ask you which were the toxicity and about the tolerability of atezolizumab in the frailest patient.
But in general, I didn't have time to show it, but in general, the toxicity in this population, which is a fragile population, is not very different from the overall population. So the immune-related side effects are not connected, are not in relation with age or performance status, or other, differently from chemotherapy, where there is a clear relationship between the more chemotherapy you give, and the older is the patient, or poor performance status, and the worse the toxicity. Here, it doesn't seem to be a correlation with poor performance status, age, etc. So the immune-related side effects are the one that we know and are not different in this group of patients. So I think still the comparison is favorable for immunotherapy. The only discussion I have is that at least myself, I like to know also the other people in the room, I do not consider any more single agent chemotherapy as a standard of care in these patients. If I decide, if the patient is so high risk, I may decide not to do anything, just palliative care. But if I decide to do something, I would go for carbopem, low dose, maybe reduced dose, and adapt to the patient. So I would not consider this standard arm as a real standard, but this is my personal view. I don't know if the others agree or not. What do you think?
Actually, I fully agree. I think the control arm in this trial is totally wrong. You're older than 70s, but you're in good shape. You're candidate for chemo. If you're younger and you're not candidate to carboplatin, you're not candidate for chemo. So likely the division also should be, it depends if your health status is deteriorated because of the disease or because of the comorbidity. Because if it's because of the comorbidity, I don't think you're going to help much with carbo, pembro, whatever, and the other way. The good thing, I have to say, is that we got the approval. And then you can use more logics at the time of prescribing. Let's say, when an internal medicine doctor is calling you, they got a 85 years old with a lung mass, and they talk to the family not to do a biopsy because it's too aggressive. You always can say, even this patient doesn't like chemo, if I have a biopsy, just to confirm it's a lung cancer, if the PD-L1 is high, I could give it, let's say, carboplatin, a pembrolizumab or whatever. So it's, and if the PD-L1 is 35, I could do as well if the patient doesn't like to do chemo. If not, I just handle the patient. But I think it's good news for that very only perspective. Just going to take the advantage, I got the microphone, to ask a question on gender. And actually, I think Marina had also made some reflections in the past about that. So you're having a patient which is a female, had smoked in the past. So it's not a never smoker, had smoked 20 years ago, 15 years back, and now is having a lung cancer, and it's PD-L1 60%. would you do single agent pembro or would you do chemo pembro? Or
I feel like to be in the exam. Maybe I failed the exam now. No, I think that this is something that I discuss very carefully with the patient because there is also a matter of toxicity. But if I may, I would go with a combination because the response rate in the overall population is 40%, and in this particular case can be also less. And sometimes if you fail the first line, you fail everything. So I would seriously ask to the patient if she is okay to do some chemo.
I would allow that. I also would give chemo.
Okay. The other two speakers, the question is very
Yeah,
interesting.
so first of all, we are excluding that there is any mutation, right? Because, we in California, we always do molecular tests, even if they're smokers. But yeah, so I would, if the patient is in a good performance status and is young, below, let's say 80. So I would talk about chemo, now, if the patient doesn't, it's their choice. If they don't accept, then they will do IO alone. Right? So, Marina, would you start with IO alone and then eventually add chemo?
I would say no, because in the first 2 months, potentially you can have also the hyperprogressive disease. We saw a lot of very quick progression. So I think that this must be a decision that must be taken from the beginning.
If I can add on this, we have an experience. We, as a common practice, have the use to reassess patients' high risk of progression with single agent after 2 cycles. If they progress, we add chemo. We have now almost 20 patients treated, and we salvage 80% of those by adding chemo. So I think the risk of losing those patients, if you check early, is very small. So this is also a possible strategy to overcome.
And how do you know that is not the chemo alone that is effective?
This is possible. Obviously, this is possible. We should have a randomized study, which is very difficult to do. We never know. Yeah.
Bye, Diego.
Just a question. Thank you for your thoughts. What about the duration of treatment with immunotherapy? What is your clinical practice? Do you use some clinical criteria such as response to stop at 2 years, or do you continue after 2 years?
I stop at 35 cycles without adding nothing more because of the trial. When I use pembro, of course, because of the trial, so I try to be bind to the trial and then go on with the follow-up. Because as of today, I'm not aware about some data that could help me in prolonging treatment. There are people doing PET CT scan, and if the PET is no more, the tumor is no more active, they will stop. Otherwise, they go on. But it's not based on any clinical data, any prospective data, but even any retrospective data. So I would stop at 35. It depends on the agent, of course, because, for example, atezo is not 2 years. If you use atezo, and it's something that I use when I choose among similar drugs with similar results. It's something that I discuss with the patient sometimes. It's like I would start with these drugs, but you know that at 2 years we can stop if everything goes well. But with this other drug, we have not the evidence to stop at 2 years. It's something that you have to probably discuss at the starting point if you choose one drug over another, from my point of view.
So if I may, I add just one point. So first of all, we are talking about less than 10% of all the patients. So I'm always impressed when I see the data of the Keynote-24. They started with 1,500 patients, and at the end they randomized 250. And if you look at the consort, only 32 patients had the problem after 2 years. So we are talking about, unfortunately, a little number of patients. There is only one trial that now is quite old, that is the Checkmate 153, that randomized patients to receive either 1 year of Nivo or nivolumab forever and ever. And what was very interesting, I don't know if Benjamin Bess is still here in the room, but we wrote together the editorial on JCO of that trial also with Walter Torri, because if you divide the patients who achieved a partial response or a complete response, they do much better if you continue. But if you just consider the population of patients who achieve only a stable disease, they do exactly as those who do 1 year. So in the algorithm, I consider also if they had a response before. If they had a response before, I stop and I discuss with the patients whether to continue or not.
Yeah.
This is interesting because I I make the opposite reasoning usually, but based on the data, I mean the data that also you produced about the what happens after 2 years of Pembro, it looks like that those that are in partial response or complete response, they have 80% chances to be without a progression after 3 years. Okay, so this looks pretty well. I mean, why do I have to continue if I have 80% of the chance of being, and I can re-challenge maybe after? So you're saying the opposite now, that maybe if they are, it's good to continue in those cases. Why? Because my fear is that when you are at 2 years, so maybe you have an almost stable disease, or there was oligoprogression that you give radiotherapy and you continue, that I'm a little bit worried about stopping, because it seems that you are keeping the disease staying there, but as soon as you stop it, it might progress. But this is a psychological issue more than scientifically.
Yeah, I think that the only randomized that we have are from the 153. So I think that we don't have the answer. Clearly, in the United States, there is a larger access to the liquid biopsy. So basically, you start with the liquid biopsy from the beginning, and you know that they are shedders. And when they arrive at 2 years, you do the PET scan. If the PET scan is negative, you do the liquid biopsy again. And if they are positive, potentially you can continue. So I think that we are just inventing the science.
Yeah, I agree with you. I don't think we have enough data to say when to stop.
Yeah.
And that's why, you know, we need more of these panels and, you know, especially the MRD, let's say, algorithm, because how can you decide? So I had cases, of course, you know, if they experience toxicity, you have to stop. And I have patients that, you know, are 6, 7 years out. And I bet all of us have these stories. And then suddenly they just come back with like, you know, metastatic disease, you know, I mean, growth of disease. And so you don't understand what happened exactly. I mean, why, you know, after 6 years, suddenly, you know, there is this huge flare of disease.
Yeah,
So, I mean, it's
on the other side, if you have the MRD positive, we don't have data to suggest that they can become MRD negative.
Right.
So
I don't think we're going to have help.
Are there other questions? Okay.
Can I ask a question for about the ADCs? Because
yes.
I'm pretty confused about the positioning of those agents. So
yes.
Based on your experience, where do you think is the main? Because to me, at the moment, the area where there is an unmet need is the second line area, because
right.
there
but they're trying to move it up to the first line. So they're trying to basically replace the partner of the platinum.
But do you think is it logical?
You know,
to me, I don't understand it actually.
I mean, the toxicity is not better. You know, if we're talking about, let's say, pemetrexed, which is a very easily tolerated
just another
chemo.
chemotherapy instead of another one. So I don't really see the reasons. Probably more toxic, more expensive. Are we sure
more expensive?
It is more
so that's so more expensive. Yeah, I agree. In more toxic.
So
in
it
some
should be
cases.
much more effective to convince me that this is the right, I don't know.
Yeah. So, I mean, I agree with you. So they're gonna be first approved in second line, most likely. So, and then eventually, with all these trials, they'll probably be approved in first line too. We'll see.
Okay, we have a question.
I wanted to ask you, in your opinion, in a patient, for example, with PD-L1 superior to 50%, but with STK or KEAP1 mutation, if you can choose, and we said in Italy, for example, maybe we can't, but if you can choose, if you go for chemo plus immuno, even if it's, I don't know, 90% of PD-L1, or you choose with other.
Fortunately, I don't have the information, so it's, to me, it's not an issue.
It's not an issue. No, I think that this is a never-ending topic as the other one. So we know that LKB1 for sure has a very bad prognosis, and LKB1 is a big gene with multiple mutations everywhere, and not all of them, they are lack of function. So we don't know what is also true and what is a fake LKB1. And in general, the LKB1 are associated to a low PD-L1. So it's not so common to see a PD-L1 very high, LKB1 loss. This is the case for me. Another case for me to go with a combination of what is a big question mark. If you listen to the data of Ferdinando Scoulidis, you go with a combination with EP. And if you look at the data of the Keynote 189, you go with a combination of chemo. In any case, these patients, they have a bad prognosis if the LKB1 is true.
Yeah, I agree. You know, I usually use in STK11 and LKB1, you know, I use the combo with CTLA4 and anti-PD-1, just because we have some data for the Poseidon also. So it's, but you know, it's not very clear at this point. So.
ADC.
Another question for all the speakers. In your clinical practice, do you ever perform a biopsy after IO treatment? And what kind of information do you look for if you do?
I mean, only for experimental protocols, but usually in the clinical practice, I personally don't think to find a different molecular pattern in a patient that have received chemotherapy and IO. There is no selection there to at least for those markers, those profiles that we are able to do, and we do not make any very wide panel, just the 60 genes or 100 genes. And I don't think we're going to find anything different from the beginning. Maybe we find something different about the immunosignatures or something, but this is an experimental area.
Yeah, I don't do the biopsies as well, if not for a clinical trial.
Yeah, I do the same.
Yeah, same for me. The only possibility would be, you know, if you're suspecting progression, you know, there is flare of lymph nodes, and so in that case, I would probably biopsy to confirm progression.
Other questions? No. Okay. I have a question for Dr. Massarelli, but also for the other speakers. If you have to bet on the best chemo and immunotherapy strategy in wild-type non-small cell lung cancer patients, which drug family or strategy would you choose?
Well, you know, it's just saying in general, wild type. So we talk about STK11 and LKB1. They're different. You know, it depends. You know, if you don't have any molecular findings, particular, frankly, you know, I don't use that often ipi-nivo in chemo, only in some particular cases. For example, PD-L1 0 or brain mets. Sometimes I use them. The STK11, I use them, but otherwise, I just used PD-L1 or PD-1 and chemo.
After the progression, what, in your opinion, the best new strategy for the future?
Oh, okay, for the future, okay.
So it's very difficult to say, because now, frankly, the combo immunotherapies, the novel immunotherapies, for example, TIGIT, or we have so many trials on there is OX40 agonists or 4-1BB. Nothing looks really appealing so far. So clinical trial. So for me, clinical trial, but I think cell therapy could be a possibility. Even if it's a little bit cumbersome, but I've seen responses after failure of chemo on trials. Yeah.
Or the other speakers?
I completely agree. I think that clinical trials at this point are the best way to try to select the future treatment of these patients. And about ADCs, if I can add, I'm more interested when ADCs are developed along with a kind of biomarker to select patients, because otherwise I don't think that we will see some dilution probably of the effect, and we will not get the best evidences against docetaxel. We lost many patients in trials without biomarker selection against docetaxel with whatever put against docetaxel without giving nothing more to the patient. So I think that it should be time to try to select even with this kind of fake chemo to try to select patients. So for example, tuzamatimab is going in this direction. We don't know how it will work in the phase 3 trial, but try to select patients.
Yeah, I think that we will, maybe I'm wrong, but we will never see the drug as we saw in the past for multiple other drugs. I think the future will be maybe fragmented in multiple other possibilities. And again, I think we should come back and find biomarkers, because without biomarkers, we don't go very far.
At the moment, based on phase 2 data, I would go for ADCs if I might use those. Obviously, we have to wait for the phase 3s, but I think it should be pretty easy to win against Taxotere there. I don't know, maybe.
Yeah, no, you are right. And I think that they will arrive, and I hope that in ESMO we will see something. But there is another trial that, in my opinion, was very interesting. That was Pembro and Ramucirumab. They are running now the phase 3, so it's quite tolerable. And maybe if the trial will be positive.
We have time for just one last question. If no one has one. May I ask you what is your point of view on maybe dietary or lifestyle changing a bit to improve the immunotherapy efficacy in this context, since maybe metabolism has an important effect in this therapy?
For all. It's for all. I mean, we know that the microbiome, is very important in response to immunotherapy. So I think the probiotics, and the problem is that there should be specific products, because it's very, vague, telling a patient, okay, take probiotics, but of course, which one are you going to take? Because, but it's pretty clear that microbiome is, there is also, I don't know if you saw the fecal transplant that was actually effective in some patients. So I think the microbiome is very important in the response to immunotherapy, but unfortunately we don't have products yet that are specific.
Yeah, they're actually running an Italian trial about this kind of selected products against the observation. I think that the big problem here is controlling most of the other factors, because even if I take these probiotics and then I go to McDonald's and eating, beef that comes from wherever and so on, it may change a bit. So it's difficult to control lots of variables when using this kind of interventions, I would call them. but for sure there is something, even the physical activity. We know that adjuvant treatments are best tolerated in patients that are active, while not thinking about the same things to a fit organism when doing immunotherapy. There are also those data about the time of infusion from the VGIF, for example, from the group of Benjamin, about the time of infusion. So it's a crowded area, and it's difficult to find, I think, the solution, but something to study.
No, I agree what was already said. So I was thinking while he was asking that at the global level, people who are in the United States and they eat junk food all the time, they don't have different outcomes from the Italians, so that they have a better diet. Having said that, I think that maybe we have to improve the conditions in general for the immunotherapy. There are also some data saying that if you deliver the immunotherapy at 5 a.m., there is the peak of the T cells, and you can exploit the benefit of the T cells. So the fasting is associated to an activity of the T cells and also of the reduction of the myeloid components. So I think that we can improve. I'm not, and clearly also the microbiome, I'm not sure that the diet could be something like the tyrosine kinase inhibitors, that you don't have to drink the grapefruit, otherwise you are done. So I think it's a multifactorial condition again.
Too complicated, I think. I don't have anything to add. I think that, as was said, too many variables. It's difficult to plan a study, clean study to prove that. So we can continue to collect information, maybe large database, maybe artificial intelligence may help us, but at the moment I would not recommend to my patients anything apart from the treatment.
Okay, I think that our time is over. I want to thank all the speakers for this discussion, and it's time for coffee break. I just wanted to remind you to be on time for the next session at 4 p.m. sense.
Okay. We arrived at the third section dedicated to the oncogene-addicted advanced disease. So let me introduce you my colleagues, Claudia Proto and Mario Chipinti, both work with me at the Istituto Nazionale dei Tumori in Milano. Claudia and Mario, welcome.
Good afternoon, everybody. First of all, I would like to thank my friend Giuseppe for this kind opportunity. It's a great pleasure for me and for my colleague, Dr. Chipinti, to be part of this amazing meeting and to meet you today. We are starting this interesting session on the advances in oncogene-addicted non-small cell lung cancer. Before starting, I want to remind you that, like in previous sessions, we will proceed first with the presentation, and then during the roundtable, we will have time for question and discussion. However, Dr. Philippe has to leave earlier, and she will not be present during the roundtable. So we have to change the order of our presentation. She will be the first speaker. And all in this case, we will have the time for some question immediately after her talk. But let me introduce Dr. Philippe from Vall d'Hebron University Hospital of Barcelona. And she will show us updates for BRAF, MET, HER2, and KRAS positive patients. Welcome, Dr. Philippe.
Introduction. It's a real honor for me to participate in this meeting. Thank you for the opportunity. So as you mentioned, I'm going to review the situation of patients with BRAF V600, approximately 2% of lung adenocarcinomas, HER2 mutated patients, 2% of the patients, MET exon 14, that represents approximately 3% of all lung adenocarcinomas, and also KRAS G12C mutation, approximately 15% of all adenocarcinoma patients. So I'm going to start with BRAF. In fact, the BRAF alterations are present in 4 to 5% of non-small cell lung cancer, but the target is the BRAF V600 that represents approximately 40% of BRAF alterations. So the agents approved are only for the BRAF V600. And you know that the bemurafenib was analyzed in 2 trials, in the AXE trial and also in diagnostic trial. And overall, bemurafenib was associated with a response rate of 42% and a median PFS between 5 to 7 months. And the next step was to analyze the dabrafenib in patients with BRAF V600 previously treated. And again, response rate in 33% of the patients, median duration of response of 9 months, and median PFS of 5.5 months. But it was clear that there was a need for a dual MAP kinase pathway inhibition in patients with BRAF V600. So the combination of dabrafenib plus trametinib was analyzed in patients with BRAF V600. First, in patients previously treated with chemotherapy, and in this patient population, the response rate with this dabrafenib-trametinib combination was 63%, with a median duration of response of 9 months. And then the combination was analyzed in patients with BRAF V600 mutation without prior therapy. And in this case, the response rate was 64%. The median progression-free survival was 14.6 months, and the median overall survival was 24.6 months. So the combination of dabrafenib plus trametinib was approved by EMA for patients with BRAF V600. We have long-term results with this combination in patients with BRAF V600 published in JTO. So the authors analyzed the 5-year survival rate of these patients treated with Dabra plus Trame, and it was 19% of patients were alive for those previously treated, and 22% of patients treatment naive were alive at 5 years. And also there were an analysis showing that probably those patients with concomitant genetic mutations in the PI3K pathway at baseline were the patients with poor prognosis. This year, during the ASCO meeting and also published in JCO, the combination of encorafenib plus binimetinib was presented. There is a cohort of patients treatment naive, 59 patients, and the response rate was 75%. The duration of response was not reached. The median progression-free survival was also not reached. And there are 39 patients previously treated that received this combination, and the response rate was 46%. The duration of response was 16.7 months, and the progression-free survival was 9.3 months. And also, and this is from the discussion, there was an analysis of the toxicity of both combinations. And when we analyzed the dabrafenib plus trametinib combination, the most frequent toxicities were nausea, vomiting, dry skin, peripheral edema, diarrhea, and pyrexia. And there was a permanent discontinuation due to treatment emergent related adverse events in 22% of the cases. And with the combination of encorafenib plus binimetinib, very similar toxicity in the most frequent nausea, diarrhea, fatigue, and vomiting, and with a permanent discontinuation to the treatment-related adverse events in 15% of the patients. There are some analyses about the potential mechanisms of acquired resistance in patients with BRAF V600. This is a study performed mainly with liquid biopsy, and according to this analysis, mechanism of acquired resistance included activating mutations in MAP kinase and PI3K pathways. Let's move on to the second oncogene that I am covering today, the MET exon 14. This, as mentioned, is present in 3% of non-squamous patients. The patients with these molecular alterations are older when we compare to other oncogenic alterations, more smokers, and is especially relevant in those patients with sarcomatoid histology. Mainly, we have two agents approved in this scenario, tepotinib and capmatinib. Tepotinib was approved according to the Vision trial. In this trial, patients in first line, second line, or third line were included. And patients were included based on liquid biopsy and also on tumor biopsy. And overall, for those patients treatment naive, the response rate with tepotinib was 45%. The median progression-free survival was 8.5 months. And for those patients, these are the patients treatment naive. And for those patients previously treated, the response rate was 44%, and the median PFS was 11 months. There was an updated information of this agent, and overall, when we analyzed those patients in first line, the response rate with tepotinib was seen in 60% of the patients. The median duration of response was not reached. Median progression-free survival was 16 months, and the median overall survival was 21 months. And when we analyzed the patients treated in second line with tepotinib, the response rate was 47%, median duration of response 12 months, and median overall survival 18.8 months. Here there is a difference. Tepotinib is approved by EMA as a second line treatment after chemo plus immuno or immunotherapy alone. And this is a difference when we compare to FDA that approved also this agent in first line. And it's the same situation with capmatinib that was approved in the same situation after chemotherapy and immunotherapy. This agent was analyzed in the Geometry Mono-1 trial. In patients previously treated, the response rate was 40%. In patients treatment naive, the response rate was 67%. And also, there was an updated information about patients treatment naive. 60 patients were included. The response rate with capmatinib was 68%, overall survival 30 months, and median progression-free survival 12.5 months. So 2 agents in patients with MET exon 14 approved by EMA, but in our case, after previous treatment. Toxicities are very similar between tepotinib and capmatinib. When we can expect from these inhibitors is peripheral edema, nausea, and diarrhea. In the majority of cases, grade 1 and 2. And also during the World Conference, it was a presentation of amivantamab in patients with MET exon 14. 97 patients were included. The response rate was 33%. For those patients treatment naive, the response rate with amivantamab was 50%. For those patients previously treated but without MET therapies, the response rate was 46%. And for those patients previously treated with MET therapies, and this group is 53 patients, the response rate is 21%. And we have also some analysis about the mechanisms of acquired resistance for those patients treated with MET TKIs. And again, the mechanisms include MET mutations in approximately 35% of the cases, as well as off-target mechanisms of resistance, including mutations, amplifications in KRAS, EGFR, and BRAF. HER2 in lung cancer, I'm going to focus only in patients with HER2 mutations. We mentioned approximately 2% of the cases, most common in women, never smokers. And I think we have a very promising agent that is trastuzumab deruxtecan that was analyzed in the DESTINY-Lung01 trial. In this trial, 91 patients with mutations were included. Response rate with trastuzumab DXd was 55%, and there were responses in patients with immunohistochemistry positive, negative amplification, and also without amplification. The patients were included according to the mutation status. And median progression-free survival is 8.2 months, median overall survival 18.6 months. Toxicity, ILD, in this study was presented in 27% of the patients, although grade 3 or higher only in 6.6%. And the next step was a randomized phase 2 trial in these patients. These are patients with HER2 mutations previously treated with chemo and immunotherapy, and there was a randomization between trastuzumab deruxtecan 5.4 milligrams per kilo versus 6.4 milligrams per kilo. The response rate was exactly the same with the 2 doses, but the ILD was lower with a dose of 5.4 milligrams per kilo. So FDA approved trastuzumab deruxtecan after chemotherapy for patients with HER2 mutations at this dose, 5.4 milligrams per kilo. And we don't have still an approval. There was also an analysis in this study, and patients with a prior brain metastasis also benefited from trastuzumab deruxtecan in patients with brain CNS metastasis. The response rate was 54%, 55% for those patients without brain metastasis. And also this agent was active for those patients that receive 1 or 2 prior lines, but also for the patients receiving more than 2 prior lines with a response rate of 43%. And finally, the last topic is KRAS mutation. As you know, is the most common oncogene mutation in non-small cell lung cancer. 25 to 30% of the patients is mutually exclusive with other oncogenic targetable alterations. And the KRAS G12C is the most frequent among the KRAS mutations, represent 45 to 50% of all KRAS mutations, and in general represents approximately 15% of all molecular alterations. And in 2013, it was discovered a regulatory cysteine pocket of KRAS G12C, and allosterically inhibitors were developed. And this slide from Pasigianni showed the timelines of KRAS G12C inhibitor development, sotorasib, adagrasib. We have also divarasib, but also other agents, KRAS inhibitors now under clinical development. Very briefly, sotorasib was analyzed in a phase 2 trial in patients previously treated with chemo and immuno. Response rate was 37%, and the median progression-free survival was 6.8 months. Very similar results with adagrasib. 112 patients were treated. Response rate in this scenario, second line, is 43%, with a median PFS of 6.5 months. And recently, the data with divarasib was published in the New England Journal of Medicine. There is a cohort of 60 patients with non-small cell lung cancer, slightly lower number of patients when we compare to sotorasib or adagrasib, but very promising response rate, 43%, and a median PFS of 13.1 months. The median duration of response for patients with non-small cell lung cancer was 14 months. And also the GDQ443 compound that was also analyzed in patients with non-small cell lung cancer presented at ASCO with a response rate of 44%. And we know the results of the randomized trial in patients previously treated with chemo plus immunotherapy, comparing sotorasib versus docetaxel. This study is positive for the primary endpoint, that is progression-free survival. Sotorasib was associated with higher response rate when compared to docetaxel, and in general was well tolerated. There are no differences in overall survival. There are a number probably of potential explanations. Crossover was allowed, and also this study, the primary endpoint was PFS, so the number of patients included are rather limited. And also at ASCO, it was a presentation of biomarker subgroup analysis from this trial. And also the patients with STK11 benefited from sotorasib, and also the patients benefited from sotorasib irrespective of PD-L1 status. We know also some mechanisms of acquired resistance to, in this case, the publication is with adagrasib. There are new KRAS mutations as a mechanism of resistance, also by fast-track alterations with RAF/MAP kinase, but also KRAS amplification. So the next step probably is to analyze these combinations in first line, but at present, immunotherapy has a clear role for patients with KRAS. We have the combination of sotorasib plus pembrolizumab or atezolizumab. This combination, the toxicity, grade 3/4 treatment-related adverse events were really relevant. But Pasigianni also presented the combination of adagrasib plus pembrolizumab in treatment-naive, and it seems that the response rate was 49%, and it was a very better tolerated combination. And also, there was a presentation at ASCO and also in the World Conference with a combination of chemotherapy plus sotorasib as a first line. So at present, the situation of KRAS inhibitors is in second line, but there are a number of studies analyzing these inhibitors in first line. So this is my last slide. For patients with BRAF V600, we have trametinib, dabrafenib approved. This is a challenge in some countries. In our country, it's not reimbursed, so we treat these patients with immunotherapy, probably chemo plus immunotherapy. For patients with HER2 mutations, chemotherapy is the treatment of choice. There is also trastuzumab deruxtecan indicated in ESMO, but is not approved by EMA, so also we have another challenge. For MET exon 14 skipping mutations, according to the ESMO guidelines, we have both chemo plus immuno or camimatinib or tepotinib as a first line. We have previously discussed that we are using in second line according to the regulatory agencies. And for patients with KRAS G12C, there is a need to treat with immunotherapy. And I think at present, the KRAS G12C inhibitors are in second line. And thank you so much for your attention.
Philippe, for your complete overview. Now we have time for some questions. Any question from the audience? No question. I start with one question for you. Thinking about anti-KRAS treatment,
In your opinion, what is the best setting, front line, second line, and what about the type of treatment? Monotherapy, combination treatment?
I think this is a very important question that we need to analyze in the further studies. The reality is that, in my opinion, now the place of KRAS G12C inhibitors is in second line after chemotherapy and immunotherapy. But there are, as I mentioned, a number of trials analyzing the combinations. It seems that probably the combination of chemo plus sotorasib, the response rate is really high, but we need more data in PFS. We have 2 phase 2 trials presented, and the PFS was around 6 months. The reality is that there is an ongoing phase 3 trial comparing chemo plus sotorasib versus chemo plus immuno for those patients with PD-L1 negative tumors. And also, I think the combination probably of KRAS G12C plus immunotherapy as monotherapy may have a role also, no? And there is also a randomized trial comparing KRAS G12C plus immunotherapy inhibitor plus immunotherapy versus immunotherapy for those patients with PD-L1 50% or higher. But in general, what we have seen is that, you know, immunotherapy is active for patients with KRAS G12C. In the prior session, we discussed STK11, but even for these patients, there is some kind of advantage. So I think it would be not easy to change the first line treatment for patients with KRAS G12C.
Thank you.
Do you think the combination of chemotherapy plus immunotherapy plus anti-KRAS is feasible?
Thank you. It's a very good, also a very good question. I review for a presentation, and there is, I don't know if it's feasible, but there is one study ongoing analyzing the combination of chemotherapy plus pembrolizumab plus adagrasib. No, so but we will see. So. Why not? We have seen the results of FLAURA in patients with EGFR mutations with the addition of chemotherapy plus osimertinib. Perhaps in patients with KRAS G12C may have a role to combine everything if the results are better. But yeah, we need to have a look in the toxicity, a clear look in the toxicity of these combinations.
And we need the ideal patients.
Absolutely. Very good performance status patients. Yeah.
Question from the audience. Okay, the last question. In patients with the BRAF V600E mutation, there is no first-line phase 3 comparison study between chemoimmunotherapy and target therapy. What do you prefer if you have both in the ideal world in your clinical practice?
No,
because in Italy we have the possibility to give dabrafenib and trametinib as first line, but I don't know if in Spain it's possible.
We don't have the reimbursement for any patient with BRAF V600 in Spain. This is the reality. So we need to look for potential clinical trials. So we participated in the PHAROS trial, for example, and it was an opportunity for our patients. So this is, I think, these are patients that if I had the opportunity to decide, probably I would treat the patient with targeted agent at the beginning, and then probably to give chemo plus immuno. But yeah, I think the results are 60-80% response rate. It seems that the results are slightly better for those patients treatment naive when we compare to those patients previously treated. And if the combination is not doing well, we can treat with chemo plus immunotherapy. But yeah, there is no randomized trial, so
okay.
Thank you, Dr. Philippe. So I'm glad to introduce you the next presenter. That is Professor Francesco Grossi from the University of Insubria. And he will talk us about the use of next generation sequencing in non-small cell lung cancer from tissue to blood. Thank you.
Okay, good afternoon, and thank you very much, Giuseppe, for the invitation. It's a pleasure to stay here today. So the purpose of my talk is to discuss the NGS and non-small cell lung cancer from tissue to blood. So these are my disclosure. I'm not, I am clinician, I'm not a molecular biologist, so I give you my point of view of clinician for NGS and tissue and the blood, the use of NGS for tissue and blood for the evaluation of the genomic alteration. So I start with the ESMO guidelines, and then I briefly discuss the advantage and disadvantage of tissue biopsy and liquid biopsy, and some important news, I believe, in some trials about the use of liquid biopsy that is very easy to use for some reasons, but now is not probably the practice in most of the centers, especially in our country. And at the end of presentation, some take-home message, and I discuss the barriers to universal biomarker testing. So what about the ESMO clinical practice guideline? This is the last version published this year. As you can see, we start to evaluate in non-small cell lung cancer the PD-L1 expression. And then in non-squamous, the fact of the adenocarcinoma, that is the most important. Non-squamous, the incidence is, the adenocarcinoma is around 80% of all the non-squamous. And we evaluate in these patients, we test for oncogenic drivers. And it's very important because we decide we can determine the therapy in this setting. But it's also interesting to see in this guideline that we have also to check in the squamous cell carcinoma, in particular in patients, in young patients with age less than 50 years. It's probably new, this indication in young patients. And also in never smokers or light smokers, that means patients that smoke less than 15 pack per year, or long time ex-smokers so that quit smoking more than 50 years ago. So in this population of squamous cell carcinoma, we have to consider the testing because we can find in some situation some positive test. So what about the recommendation for the use of next generation sequencing? This is the ESMO Precision Medicine Working Group that recommend the use of next generation, not only in advanced non-small cell lung cancer, but also in prostate cancer, ovarian cancer, and cholangiocarcinoma. And we can consider in some institutions, they consider large multi-gene panels that are important because there are some interesting commutation also for studying for select patients for immunotherapy. I mean, we can use probably most of the center, we use small panels because have an acceptable cost, less than the large multi-gene panel. It's interesting to see that this ESCAT, the ESCAT is the ESMO scale of clinical actionability for molecular targets. So it's important because it defines 6 different levels of clinical evidence for molecular targets according to the implication for patient management. So in the level 1, it's the most important level, we have targets ready for implementation. So we have the study that recommend the use of the target therapy for a selected targets. And we have also a level 2 where we have the investigational targets that define a patient population that benefit from targeted drug. And also interesting the level 3 because we have demonstration in other tumor types, but we can probably recommend the use of agents in this particular situation as an off-label. And it's important, the ESCAT, because we see also the ESCAT level in the new guidelines. This is the old ESCAT recommendation. Today, almost all the target that which we evaluate in non-small cell lung cancer are level 1, 1A, 1B, 1C, depends on the trial, the data that we have. But in the past, we have only EGFR, ALK, MET, BRAF, ROS, and TRAC and RET, level 1 ESCAT. R2 and KRAS was level 2. And in the squamous cell carcinoma, we have in the past, in the first edition of the ESCAT, we have only NTRAC as ESCAT 1C. So if you look at the new guidelines, you can see that all the targets are in ESCAT 1. And we can use these agents as a first-line treatment or as a second-line treatment after chemo or chemo plus immunotherapy. There are some new kits in town, not included in the last version of the guidelines, in particular the NRG1 inhibitors. In particular, the zenocutuzumab wins the FDA breakthrough therapy designation for NRG1, so probably is one of the new target, and these agents will be probably one of the new agents that we can consider in the future. So what about the liquid biopsy? Liquid biopsy, we can consider liquid biopsy, I mean, blood, because we can consider also the liquid biopsy in other situations. And it's important, the liquid biopsy, because we can not only evaluate the circulating tumor DNA, that is very important because we can evaluate the point mutation, deletion, but also translocation and amplification. But we can also evaluate the circulating tumor cells that are important for evaluating the minimal residual disease in patients resected. As we know, we can evaluate the genomic alteration also in malignant pleural effusion, pericardial effusion, in sputum or in other body fluids. And if you look at the difference between the liquid and the tissue biopsy, for the tissue biopsy, we have some important advantages. In particular, we have pathologic information that we do not have in the liquid biopsy. We have the assessment of DNA and non-DNA biomarkers. So now we can evaluate also the RNA in the tissue. And also we have the PD-L1 assessment. The disadvantages for the tissue biopsy is the longer the time for have the results, turnaround time. And also sometimes we have a limited tissue quantities, so that could be a problem. It's normally the biopsy is invasive compared to the venopuncture for the liquid biopsy. And disadvantage is that the progression of disease, we need a rebiopsy that is not always feasible because sometimes we have progression in brain or in bone, so that is a more difficult evaluation of the tissue. The advantages for the liquid biopsy are the high concordance rate with the tissue, the rapid turnaround time, is minimal, obviously is minimal invasive, is repeatable, so we can monitoring the disease with several liquid biopsy. And another important point is that better capture the tumor heterogeneity and clonal evolution compared to the tissue biopsy. But there are also some important disadvantages of the liquid biopsy. In particular, at the moment, there are some assay for evaluating RNA in the liquid biopsy, but it's not the practice. So we can consider only DNA biomarkers. There is an increased cost if used concurrently with tissue testing, and we have sometimes a false negative. But if you look at some comparison between the tissue biopsy and the liquid biopsy, probably we have higher complete genomic profile using liquid compared to tissue biopsy. For example, in the Jordi Ramon trial demonstrate that only half of the patients have enough tissue for evaluate the genomic alteration compared to liquid biopsy that we have more than 90% of the cases. And also in the Nile study and in Pennsylvania studies, we have more than 30% of targetable mutation detected only in the plasma. So the rescued is around 60% of the patients. So it's I believe that it's a good point in favor of the liquid biopsy. So Rolf proposed in a very nice paper a kind of diagnostic algorithm for the use of liquid biopsy and tissue biopsy. In particular, if you have available on your left the tissue samples, we have two different approaches. The sequential approaches means that first you evaluate the tumor tissue and if it is adequate for genotyping. And then you can use the circulating free DNA analysis in case of incomplete tumor genotyping. And the other approach is a complementary approach that it makes sense to consider when you have tumor tissue scanned over with uncertain adequacy. So you can, concurrent to the evaluation in the tissue, evaluate in the circulating free DNA at the same time. On the other side, if tissue samples are unavailable for tumor genotyping, it's better to the plasma first approach. And if it is okay, if you find some mutation in the DNA, okay, you can stop, but you need a rebiopsy for tumor tissue genotypes in case of absence of targetable drivers in the plasma evaluation. So the liquid biopsy, in favor of liquid biopsy, is that you can start also in some situation of non-small cell lung cancer suspicion. There are two very nice trials, the Libellule trial in France and the Accelerate in Canada, that demonstrated that the liquid biopsy was informative in up to 80% of the cases. And the turnaround time with liquid biopsy upfront was only 7 days. So you reduce the time to treatment initiation of 20 days, from 40 days to 20 days using the liquid biopsy. So it makes sense probably when you need information to start immediately the treatment. So this is an interesting approach, confirmed with another trial that demonstrate that plasma NGS reduce the time to treatment. So liquid biopsy, we know that we have used a lot when we used osimertinib as a second line in patient progressed after first or second generation EGFR TKI and in patients with EGFR T79 mutation. So it's important after acquired resistance, the evaluation of the new mutations, new alteration. And if you look at the Helios trial that evaluate the biopsy in the tissue at osimertinib progression, you see that less than 40% of patients are evaluable for genotyping, for evaluating new alterations. If you look at the results of the AURA3, in terms of AURA3 was the trial that compare chemotherapy versus osimertinib. In the evaluation of acquired resistant mechanism to osimertinib using the liquid biopsy, as you can see, there is very interesting, very good results in a selected, obviously in a selected laboratory that evaluate not only the new mutations in DNA, but also the acquired amplification, acquired fusion, etc. So it's probably only kind of research in a very selected laboratory, but it's interesting to see that with liquid biopsy, you can evaluate almost all the patients for new genomic alterations. It's also interesting if we consider the liquid biopsy, if we can evaluate the progression during first generation or second generation EGFR TKI using the circulating tumor DNA evaluation of the T79M mutation before the progression, the radiological progression. In the Apple trial, is a phase 2 trial with 3 different cohorts, is the not comparative trial that evaluate in one cohort patient treated with gefitinib until progression seen with a comparison at the circulating tumor DNA of the T79 mutation, or using RACIST, the radiologic progression. And in another arm, they treat patients with gefitinib until radiological progression. So it's interesting to see that they switch immediately in the arm that evaluate the progression using the circulating tumor DNA. And the switch from gefitinib to osimertinib before RECIST progression, so before the radiological progression, looks promising in terms of overall survival. Unfortunately, it's a small group of patients because it's only 8 patients, but demonstrated that the switch before the radiological progression makes sense because we anticipate the progression, and probably we start to treat immediately with a third generation of EGFR TKI. Another important point is the clearance of the circulating tumor DNA. In the FLORA trial compared osimertinib versus first generation EGFR TKI, gefitinib, and erlotinib. In patients with the circulating tumor DNA at baseline and that have clearance of circulating tumor DNA, we have better progression-free survival compared to patients without clearance. After 3 weeks, the median PFS in patients with the clearance after 3 weeks was 19 months for osimertinib in group of patients with clearance compared to 11 months in the group of patients without clearance, and same at 6 weeks in favor of patients with the clearance of circulating tumor DNA. And we found the same results in the same clearance is important also for the other targets. For example, in the trial with lorlatinib in ALK-positive patients, in patients treated with adagrasib for KRAS mutation, in patients treated with tepotinib or savolitinib for the MET exon 14 mutation, for BRAF with 6600E mutation. So we have the same results. And this is, I believe, important because if we don't have clearance, probably we can consider for these patients also a combination. For example, we have now data of osimertinib combined to chemotherapy. If after 3 weeks we don't have a clearance of, or 6 weeks better, a clearance of circulating tumor DNA, we can consider probably in this population a combination with the chemotherapy, continuous osimertinib combined to chemotherapy. So it's interesting, I believe, this use of liquid biopsy for the clearance of circulating tumor DNA. And obviously is very interesting in early stages of disease. For example, after surgery, we have data. This is a very nice paper published in Nature by Abosh this year that demonstrate that in patients with negative for circulating tumor DNA, we have better freedom from recurrence compared to patients with high circulating tumor DNA. And again, if you look at the ADORA trial, at baseline, ADORA trial is patient treated in adjuvant setting with osimertinib. In patients at the baseline, there is only 24% of patients with the detection of circulating tumor DNA. And there is a clearance after surgery of circulating tumor DNA in 75% of the patients. Only 25% of the patients are no clearance, no circulating tumor DNA clearance. And it's interesting to see that at 3 years, the 80% of the patients are without progression, without minimal residual disease, compared to only 50% of the patients with minimal residual disease. So again, we can consider the clearance in 2 different settings, in patients with advanced disease or in patients resected. And for example, also in patients resected, we can evaluate the molecular relapse and probably consider to treating earlier the patients, like for ovarian cancer using the CA125. But we haven't data, so it's only an hypothesis, but it's interesting, this paper published in JTO that evaluate the molecular progression that appears months before the radiological progression, the radiological relapse. So for this reason, it's only the EGFR classic mutation, the deletion in exon 19, but it's also interesting this use of liquid biopsy. So in conclusion, for the practical recommendation for liquid biopsy, now we can consider a liquid biopsy in advanced disease. So it's important for the biomarkers that guide the therapy, but it's also important, could be also important for monitoring the response to the treatment for the acquired resistance. And then we can also probably in the future recommend the liquid biopsy in for monitoring neoadjuvant setting, for monitoring the molecular residual disease and the molecular relapse. So not only during the treatment, but also in the follow-up. What is the situation in the European countries about the availability of liquid biopsy? As you can see, in Italy, seems that we use liquid biopsy. I'm not sure about that because probably when we have to evaluate the T79 mutation, we have used a lot the liquid biopsy, but now I'm not sure about this EU data. And as we know, there are a lot of barriers to universal biomarker testing due to the tissue. For example, we do not have enough tissue, but for this reason, we can consider the liquid biopsy, but in the liquid biopsy, we can evaluate DNA, and about the RNA is not in the practice at the moment. The turnaround time is not fast enough with the tissue biopsy. Probably with liquid biopsy is a little bit better. And then we need the reflex testing. Now is not common, the reflex testing in our hospital. And another important issue is who pays, so the cost of this exam. So in conclusion, NGS is the test recommended in advanced non-small cell lung cancer to evaluating the genomic alteration. Liquid biopsy is something probably important because we can use not only for the evaluation at the diagnosis of of the genomic alteration, but also for monitoring the treatment and evaluate the progression before the radiological progression. And probably there is a growing evidence that is not blood testing or tissue testing, but is complementary. So we can use both, starting with the tissue, because tissue is the issue. So tissue is always the most important evaluation that we can have at the beginning of the story in our patients. We have some limitation about specificity and sensitivity, but and lack of standardization in some situation, but we believe that in the near future the development is really rapid. So thank you very much for your attention.
Rossi, for this very interesting presentation. Let's move to the next speaker, and I am very honored to introduce Professor Luis Pasares from the University Hospital 12 October of Madrid. Today, he will talk about new perspectives for EGFR mutated patients. Welcome, Dr. Pasares.
Okay, so thank you very much. Thank you for this invitation to this forum of discussion that I'm really enjoying very much. So my talk today is basically to review what is going on, maybe what is going on into the future in the EGFR mutation space. Classical, but also for those patients that are having less common mutation, even the exon 20 mutations. So you see here more or less a map of the mutations within that gene that are relevant at the terms of therapeutically guide our treatment. And as you see here, I would say grossly, some 85% of the cases had exon 18 and exon 21, the so-called classical mutations, the quick message. Some 5% are in the exon 20, mostly are insertions that are some low number of very rare other mutations. And there are some still 10 to 15% exon mutations that are so-called rare mutations. And then we will try to address them differently, because from the beginning, we realized that only those patients with classical or maybe close to classical, let's say, mutations do respond well to TKIs. So indeed, for a couple of decades, we've been using TKIs. We know they respond to first generation TKIs, then to develop second generation. We learn the mechanisms of resistance, particularly those that are mediated through modifications on the ATP binding pocket, typically the so-called T79M mutation, and also the bypass track, let's say, outside of the pathway mechanism of resistance. And we have more or less an idea of how to tackle the disease. So we typically use TKIs on those patients with classical mutations. And we learned that those patients that at the time of progression to first generation or second generation TKIs, if they do have T79M mutation, they do better on third generation TKIs that actually adapted to the new configuration of the ATP binding pocket of the kinase as compared to chemotherapy. So the question is, you have a patient today with untreated EGFR mutated lung cancer. What is the best treatment? And this is what I'm going to try to address over the few minutes when we're talking on the classical mutation. First of all, what is the best treatment as today? Different ways to prevent a resistance to emerge. This is a big issue, a big problem. Universally, all patients on third or second generation TKIs do develop resistance. So this is something we have to prevent to happen. Then if that happens, what are the subsequent treatments, what we may do? And then we will spend some few words on exon 20 insertions and in the very uncommon EFR mutations. So first of all, ways that we can do to prevent resistance to emerge. So the more obvious thing would be, instead of using osimertinib or other third generation TKIs at the time of progression, at the time of developing a resistance due to the T79M mutation, maybe if we do it earlier, we can prevent that to happen. The other ways would be to use TKIs plus angiogenics, chemotherapy plus angiogenic, and even some other drugs in combination, with TKIs, with third generation TKIs. I'm going to see. So, of course, we know from the FLORA trial that the combination, the use of osimertinib as compared to third generation TKI improves outcomes. Of course, increase a bit the response rate, but more importantly, do have an impact on PFS and actually do have an impact in survival. So what you should expect here is a PFS in the range of 19 to 20 months. And as you see here, maybe a survival that is going in the close to 30 to 36 months at least. And actually, that is maybe improving over time, not because osimertinib is doing better today as compared to 3 years ago, but because we have better drugs on third and fourth line. And typically patients are living longer, not only because of one single treatment, but because even in trials, we compare the new drug with the old drug. The patient is benefiting from the new drug, but also from the old drugs. It's getting one after the other, right? So that is important to take into account. Another important issue is that osimertinib, the third generation TKIs, do have good pharmacology, particularly good penetrance on CNS. This is something where the disease typically habit to go. and therefore it's important in terms of clinical benefit for the patients. We prevent progression on the CNS to happen. Remember, some 20–25% of those patients do have metastasis at diagnosis, but more than 50% develop metastasis on CNS over time. So it is really a very important issue for a patient to prevent CNS disease to happen. Even if you were not improving survival, it's not quite the same to stay alive for 5 years with or without brain disease. The number of implications, let's say driving, the type of work you can do and so on, it is very important. So very important, we are preventing CNS disease to emerge. So, and we have seen this morning that because of the success in the late stage, we are also using now in the early stage. And indeed, we are able to prevent relapses. We don't know if we are able to cure any more patients, but at least we're really impacting survival in those patients. As may happen with other drugs, we have seen that with PD-1 and PD-1 inhibitors, we are now developing a lot of Pepsi Coke type of drugs, some Me Too's. This is one of them, fulmomertinib, but there are some, at least 6 or 7 drugs that are being developed very close, particularly from Chinese companies. Truly, you look at the data comparing with third generation TKIs, they look very much the same as compared to osimertinib in terms of efficacy and in terms of response rate. So the good news is that maybe we are spending a lot of resources and patients on those trials, which are not very sound scientifically, but at least we may decrease the cost into the future, and particularly we may help many people to have access to those drugs, which I think is an important issue as well. So the second strategy has been to put a anti-angiogenic on top of the TKI. We have done this with first generation and with second generation. We have done a number of trials, and the truth is that this is representing what typically happens. There is a clear increase in PFS without impact in OS, and this has been a rule in the some 5 to 6 trials that have been done so far. This is true not only with antibodies, with VEGFR or VEGF antibodies, bevacizumab or ramucirumab, but also it's true with TKIs, with multi-kinase TKIs. So anti-angiogenics are improving somehow PFS, but no OS, at least with third generation and second generation TKIs. And more recently, we have some data with osimertinib, and the data are even less encouraging. So it looks like even the anti-angiogenic signal is pretty important in the biology of EGFR mutant disease. I don't think in combination with third generation TKIs, it has any utility, at least in the first line setting, and we have enough data to abandon that purpose at this stage. So the third thing to do is not very scientific, is with what we have been doing, the oncologists for ages, which is every time we are getting a drug, we put some chemotherapy on top and see what happens. And this is what we have done here with chemotherapy and first generation TKIs, but also second generation TKIs. And you see here, there were some trials, at least with the platinum pemetrexed combination, showing that chemo plus TKI is better. It's improving PFS, it's improving OS. The truth is that this has been done in the gefitinib era. So at the time we got those results, we got in parallel the data from the third generation TKI. Then the question is, should we use third generation TKIs or a first generation plus chemotherapy? Of course, if you ask to any patient, they will choose the third generation TKIs alone. So lately we have seen some data using chemotherapy
on an intercalated fashion. Maybe you remember this data presented last year this year at ASCO. So the trial was comparing standard of care, gefitinib, first generation TKI, as compared to 2 months of gefitinib, then chemo for 3 courses, and then gefitinib forever. So it's intercalated. The idea was to prevent, to kill some of the emerging resistant clones after a couple of months of treatment. And you see that there were some modification of the trial. Instead of using gefitinib, they were using osimertinib in some more or less 80 patients in this trial. You see here that in the initial cohort with gefitinib, there were some improvement in PFS using intercalated chemo, no impact on OS. But then you look at the data with gefitinib, with osimertinib, the truth is that there were no either difference in PFS or OS. So I don't think it's a clear role in this small trial, at least, to do intercalated chemo. But the more recent news is about chemo plus OSI in this first line era. And this is very fresh data from the World Lung Cancer Meeting. The FLORA-2 study was, so as you may imagine, patients with classical mutations, no prior therapy. No prior therapy means no TKI, no chemo. And patients were actually randomized to receive OSI alone or 4 courses of oxy plus PEM plus carbo or cisplatin, and then maintenance with pimetricid plus OSI as compared to OSI alone. And as you see here, there was a clear impact on PFS. The main endpoint of the trial was PFS by investigator, has a ratio 0.62. That means you're preventing 1/3 of the progressions to happen all along the study period. Same data when reviewed by an independent committee. And the truth is that all the patients seems to benefit very much the same. And this is also true, or particularly true, in the subset of patients with CNS metastasis. You see here that the hazard ratio were particularly good, 0.47. So you're preventing half of the progressions to happen on those patients as compared to those without. You see here that there was somehow a difference. Of course, this is a subset analysis, and therefore you may use maybe some of those data to see which patients are more likely to benefit. Well, looking at the data, it seems that every single patient is benefiting in terms of PFS, because we don't know yet how much is the impact on in OS. Because when you shoot the OS, you see that there is very, let's say, overlapping, a lot of overlapping on the curves. Remember that the maturity rate here is very low. I think it was in the range of 20% only, was close to 50% in terms of PFS events. So I think this is really important. Indeed, there is some signal for the PFS too, which sometimes is anticipating what will happen in terms of OS when more follow-up is there, but we still don't know as yet. So no clear difference in responses, but so the key message here, I think, is that we have an improvement in PFS, hazard ratio 0.62, particularly patients with CNS metastasis may derive more benefit. Some initial data positive in PFS2, no maturity in the data in OS. And of course, as you see here, the safety summary is as expected. Those patients treated with chemo do have more side effects because of the chemo and because those patients are progressing later. So they do have more treatment, more duration of the treatment with osimertinib. So as expected. But if you look at the individual data, those there are no new signals of particular, let's say, worriness. Okay. One of the other strategies we may do is we know that some 15% of the patients will develop MET amplification at the time of progression. Some of the other strategies trying to add before MET amplification emerged a MET inhibitor. And this is being tried with a number of agents. And I just put in here the data you remember of the Chrysalis trial, the cohort first line, where responses were seen in 20 out of 20 patients on the initial trial. And that gave rise to the Mariposa trial, where, as you see here, patients are treated with a third generation TKI close to osimertinib, lazertinib plus amivantamab, as compared to osimertinib alone plus lazertinib. And this is, of course, a placebo-controlled trial. So every one patient and investigator are blinded. That is the reason we use a number of blinding strategies here. And we'll see what this trial give us into the future. The second part of the talk is going to somehow concentrate on subsequent treatment. So those are patients that have received osimertinib and they do progress. What do we have to do? Well, we know that those patients do have a number of mechanisms of resistance. Some 15% of the patients will develop MET amplification. Some 10-15% of the patients will have some mechanism of resistance related to the EGFR gene, typically mutations that are affecting the hydrophobic forces on the ATP pocket, C1797S mutation, and some others less frequent. And the rest are unknown or sometimes bypass track mechanisms, let's say mutation in BRAF, HER2 amplification, mutation in RAS, and so on. What happens if the patient have amplification of MET? Well, we have a number of trials that have used, at the time of progression, OSI plus a MET inhibitor. And we have data with small molecules, TKIs. This is the case of the INSIGHT-2 trial with tepotinib on patients that had progressed to osimertinib. You see here response is very close to 50%, not only if the MET amplification is diagnosed on tumor, but also if it's diagnosed on liquid biopsy. And as you see here in a recent update at the time of World Lung Cancer, the data in PFS is 6 months and survival is in the range of 1.5 years in terms of median survival in this setting. Of course, we have very similar data with other TKIs or with amivantamab. I wouldn't say at this stage there is a clear difference. Maybe using a TKI, MET TKI is easy to tolerate in terms of side effects, but no clear data. So the good thing is that we have also data that patients that had received osimertinib, they progress to osimertinib, even sometimes go to chemotherapy. Amivantamab is providing responses in some 30% of those patients, whether you give it alone or in combination with osimertinib. And you have a high expression of MET in the tumor tissue, the response rate is higher. High expression measured by immunohistochemistry, and in this sub-analysis, it suggests that responses is even 90%, even the number of patients is very low. What is true is that this have given rise to a different trial, which is in patients that are progressing post-osimertinib. Patients are treated with chemotherapy, with or without lazertinib plus amivantamab. So it's chemo plus lazertinib, plus amivantamab plus or less lazertinib. And we know that the trial is positive because of a press release. And I think on a very recent meeting, likely ESMO, but I don't know, those data will be presented. So somehow maybe also have here an opportunity to add on those patients. The second strategy is what happened to those patients that do have this mutation that is somehow affecting the binding pocket of the ATP of the EGFR. Well, we know that there are a number of 4th-generation TKIs that are actually able to bind to this new configuration of the ATP pocket. And we know that they are in phase 1 trials. We have seen some of them, and we have seen some early data suggesting that some responses at least are happening. And it looks like you're having a tumor or that is having C1797S mutations on tumor or in blood is most likely to respond. The third approach is suggesting chemotherapy. So you have a patient that is present to OSI, you do a biopsy, liquid or solid, and it's negative. Maybe as Dr. Rossi suggested, you do liquid, and if liquid is negative, you go and do the solid biopsy, the solid tumor biopsy. There is no identification target, saying what you do. You typically do chemo. So the question for these patients was, should we use chemo or should we use chemo plus something? Well, the data now with the Mariposa maybe suggests that chemo plus amivantamab is better, plus or less laser. We'll see the data. The other question was, if we add immunotherapy to those patients, are we helping them at all? Well, we know that immunotherapy is not working a lot in this subset of patients. Those are cold tumors, very little infiltration. They typically do not respond to single agent Pembro or Nivo or any PD-1 or PD-L1 therapy. And you see here in a number of randomized trials now, at least 4 randomized trials, the data suggests that we are not adding much when adding immunotherapy, a PD-1 or a PD-L1 inhibitor in this setting. There were some initial data suggesting that chemo plus an anti-angiogenic plus a PD-1 inhibitor may be doing something in some sub-analysis of trials. The most convincing evidence today suggests that maybe you're impacting somehow, minimally in PFS, not in OS. And that is my take, and I do not typically use it. Anyway, it's not approved by the agencies in our environment, but anyway, I don't think we have a lot of data to use it. Just finalizing, what happened when your patient had already received chemotherapy? We still have some opportunities. For example, you see here the data with the ADC directed against HER3 with the deruxtecan topo-1 inhibitor as a payload, responses in some 40% of the patients, as you see here in the initial data. Now we have some follow-up studies presented at World Lung Cancer. Responses not in the 30% of the cases. Safety profile much improved as well, which is very important. And still we have some additional bispecific drugs. This is a HER2, HER3 directed antibody. Responses in the initial data, now in 40% of the cases, but 63% of the patients. And I think very likely this agent, which is having some toxicity, of course, but very likely we are having here an agent that many of our patients will benefit into the future. Okay, just let me finalize in 5 minutes, if I may. Just a couple of words on exon 20 insertions. Remember, this is about 5% of the EGFR mutation. We don't know very much even the implications of the configuration of the ATP in that case. Even the group of the Emmy Anderson had actually contributed very much to solve. What is true is that there are a number of insertions, not all equal, and the commutation profile is not similar to the classical mutations either. In terms of agents, we started to see agents develop through a study of the structure function studies. The initial was a pan-HER2 inhibitor, posiotinib. Responses only happened in that case in 15% of the patients because of toxicity. They couldn't push up the dose, particularly mucositis, rash, and diarrhea. Some of the new agents of the class, mobocertinib, sumovertinib, and CLN-081, the same class of agents do have improved efficacy and improved safety profile. As you see here, CLN-081 responses happening more or less in some 40% of the patients, 41%, and as you see here, the tox profile is much better, nearly no grade 4 toxicities, and the same is true for DCD 908 responses, again, in some 40 to 60% of the patients, depending where the mutation was located. And again, we didn't have the issues of toxicity such as torsade de pointe, increased QTc that may happen with mobocertinib, even with responses in the range of 28%. So taking all together, I have to say just recently we have seen that a new third generation TKI, furmonertinib, is also able to induce in this setting good responses in 80% of the patients, but at the expenses of very severe toxicity. So I think we have to fine-tune the dose. I don't think this is feasible in every single patient, but of course, at least it's giving us some new opportunity. And of course, we have the case of savibantamab, the anti-MET AEFR bispecific monoclonal antibody that we know will induce responses in some 40% of the patients as well. Of course, you see that all the patients are inducing PFSs in the range of 8 to 10 months. So responses 40%, duration PFS 8 months is very much what you expect for any of those agents. Depending on the patient, if you have the two agents approved, maybe you will decide which is the best one. Of course, savibantamab is the issue of the initial infusion reaction during the first or second infusion, and the toxicity, diarrhea, rash, and pyronychia is more frequently happening with the others. At the end of the day, we still pending phase 3 data in this case. There is one trial with mobo as compared to chemotherapy in the first-line setting, no data. There is another trial, Papillion, in the first-line data, in the first-line trial with exon 20 insertions, chemo versus chemo plus savibantamab. And of course, in this case, we again know that there is a positive trial, there is a press release, and those data will be presented at a closed meeting. It looks like could be ESMO, don't know either, but this is what we expect, all of us. Last thing is uncommon mutation. Just remember, this is about some 10 to 12% of the mutations. And we know that not all of those mutations are equal. Indeed, the studies based on structure modifications, function is helping us to classify all the different type of mutations. And likely, the more you see with this new classification, you see a lot more homogeneity in the responses to TKIs. Particularly relevant, I would say, are the so-called PACs, which is the P-loop alpha C helix compression. So are modifications that are actually compressing the P-loop and the alpha C helix. So they are somehow pushing those structures within the molecule. There are three main type of mutations you should remember. One is the 719X type of mutations, 3%. The second is the 768 type of mutation, which is about 1%. And then there is a third part, which is the H1 mutation. The only thing is that we now know this type of mutation, the H16, is actually behaving like the classical mutations. You go back to your slide, it would be somehow put it here on the classical like type of mutations because you're responding to third generation, and the type of modification is inducing on the TAP pocket is similar to what happened in exon 21 and exon 18. So in summary, you have a patient with one of these rare mutations. If it's 768 or 719, use afatinib and you're getting responses in some 80% of the cases. You get in the 861, because it's a classical mutation, you're getting more responses if you're using a third generation. Use osimertinib, which makes all the sense. And remember, if you're using second generation in these two cases, PFSs in the range of 14 months, you use osimertinib in the 861, you also get a median PFS of 15 months. Still, there is some extra complication. Some good number of 15% of the mutations do have mutation in more than one EGFR-related gene. So you have mutation in more than one place. And how should you classify those called compound, complex mutation or compound mutation? Well, you're having two common mutations within the same patients, let's say exon 19 and exon 20, or sorry, an exon, let's say A61, you should use a third generation agent. You have any agent, any type of mutation, plus a T1790M mutation, please use third generation as well. On the other hand, you have any uncommon mutation, plus an uncommon mutation, or an uncommon plus a common, always use a second generation. And that is an easy rule, maybe to follow in the clinic. So I'm not going to summarize everything in 2 minutes, but stay tuned. Thank you.
Pasares, let's move on to the last speaker of this section. That is Dr. Shirish Gajil from the Henry Ford Cancer Institute of Detroit. He's connected online and will talk us about the new update about ALK, ROS1, and TRAC non-small cell lung cancer. Welcome.
Can you hear me?
Yes. Yes.
Okay. I also want to say I want to apologize in advance. Sometimes in the hospital there are overhead announcements, and so I may have to pause for a second or so. I wish I was in Milan right now, a lovely city, and would have been with so many different friends. I also want to mention that my presentation is a little maybe out of order in that I am presenting based on availability in the US, and I'm not always aware about what the availability in Europe is. And hopefully folks like Dr. Philippe, Dr. Garasino, and Dr. Pazares can update you on that. These are my disclosures. Dr. Grossi did a fantastic job about molecular testing. I just wanted to mention in the context of fusions that what I'm going to discuss, I just wanted to mention that NGS testing is even more critical in some ways than mutations. And even in the US right now, the NGS test rates are not as high as they need to be. Probably around 60% of the patients have NGS testing done. But more importantly, when it comes to fusions, it's important to recognize, and Dr. Grossi mentioned this, that RNA-based testing is very relevant. This is data from Memorial Sloan Kettering that showed that when they added RNA-based testing after DNA-based testing, when the DNA-based testing did not yield a targetable alteration, in about 16% of the patients, a targetable alteration was identified. And this is an older data set from 2019. It is quite possible that that percentage may be even greater. And so fusions are less common, but probably the detection rate is lower because RNA-based testing is not being used in all patients. And Dr. Grossi showed this slide, and I just wanted to highlight that there are limitations in terms of identifying fusions with liquid biopsy. And so a negative liquid biopsy doesn't indicate that the patient's tumor doesn't have a targetable alteration, particularly when it comes to fusions. I'm going to start off with ALK since we have the most data and it is more common than the other fusions. But I also want to say that the principles that we have learned from ALK fusion lung cancer are applicable to other fusions. This slide I wanted to put up mainly because I wanted to highlight the demographics, particularly the young age. So the median age of lung cancer in the US is about 71 years, and the median age of ALK positive lung cancers and also ROS1 positive lung cancers, which there's a big overlap in terms of demographics between those two groups of patients, is only 52. And so the impact of this disease, and I don't want even a 90-year-old to get lung cancer, but the impact of this disease is in some way greater in this patient population, since many of them are in the prime of their lives. Now, as everybody knows, once ALK was identified, the clinical trial started with crizotinib. But I'm starting with ALEX because this was among the first trials, not just in lung cancer, but in solid tumors, where a targeted therapy was evaluated against a next generation targeted therapy as a frontline treatment. And even to this day, for somebody who's been doing or managing lung cancer patients for 23 years, this remains, it sort of generates a sense of awe for me because there is no chemotherapy involved in this frontline trial. And as I'm sure everybody's aware of the data, that the next generation ALK inhibitor did provide superior outcome. Now, this is investigator-assessed progression-free survival. But according to investigator-assessed progression-free survival, there was a tripling of the progression-free survival in patients with alectinib as compared to crizotinib. One of the important advances that have occurred, in my opinion, and Dr. Pazar has mentioned this in the context of EGFR, is the activity of many of these targeted drugs against CNS metastases. In the ALEX trial, almost 40% of the patients had baseline CNS metastases. All these patients underwent brain scans, even if they're asymptomatic. And if you look at the patients who did not have brain metastases at baseline, so this is the right-hand curve, what was found was among patients who were treated with crizotinib, almost a third of the patients at 12 months developed brain metastases, whereas that rate in patients treated with alectinib was 4.6%. So there are patients who don't have clinical evident brain metastases, but do have micrometastatic disease. And these drugs, such as alectinib, and then with other targets also, or when it comes to EGFR with osimertinib, they're not only treating clinically evident brain metastases, but also treating micrometastatic disease. And I genuinely believe that this is an important factor in contributing to the improvement in progression-free survival seen with these targeted agents, not just over chemotherapy, but over first-generation targeted drugs. There is an improvement in survival was observed with the ALEX trial, though this was not statistically significant, partly because the follow-up needs to be long enough in these patients. Mind you, the median survival has not been reached in alectinib-treated patients. The median survival in the FLORA trial, just to provide a perspective, was 38 months treated with osimertinib. So you need a long-term follow-up to show a statistically significant difference. Of course, even with a longer follow-up, one may not see that. Now, I do think that this survival difference has a certain meaning. And the reason I feel that is if you look at the outcomes with crizotinib in the ALEX trial, rather, the outcomes were very similar to the Profile 1014 trial, the first trial that randomized patients to crizotinib or chemotherapy, where the 4-year survival was 56%, and the 4-year survival in the ALEX trial was 51%, lending a certain degree of credibility to this survival difference between patients treated with alectinib versus crizotinib, though again, want to emphasize was not statistically different. I will say that before the CROWN results came out with lorlatinib, I felt that we had reached a plateau with the next generation ALK inhibitors because the data was very similar with brigatinib, with ensartinib as it was with alectinib. But clearly the CROWN results have changed a paradigm that a next generation ALK inhibitor like lorlatinib that is more potent in the preclinical models as well as activity against CNS metastases does appear to benefit to a greater extent. So this is the first data set of CROWN results with a median follow-up of 18.3 months and a very impressive hazard ratio of 0.28. Mind you, this was a blinded, independent central review assessed hazard ratio and not an investigator assessed. Just to provide a perspective, at the same time, median follow-up of 18 months with the ALEX trial, the 12-month progression-free survival was 69%, and it was 80% with lorlatinib in the CROWN trial. I do have to say that the crizotinib treated patients did perform somewhat underperform compared to the crizotinib treated patients in the ALEX trial, and that difference did somewhat contribute to the better hazard ratio. Nonetheless, 0.28 is just an phenomenal hazard ratio considering what was observed with other next generation ALK inhibitors. Now we have a longer follow-up published by Solomon and colleagues this year, now with a median follow-up of 36.7 months. I hope this shows up well. At 3 years, 63% of the patients treated with lorlatinib are progression-free. Mind you, the investigator-assessed progression-free survival with alectinib in the ALEX trial was 34 months. This is now a longer, this is a blinded independent central review, and you see a 63% 3-year progression-free survival rate, quite remarkable. And again, this to a large extent, I believe, was because of its CNS activity. Again, like the ALEX trial, I'm showing the data in patients who did not have brain metastases at baseline. And as you can see in these patients, there is no evidence of progression in the CNS among patients treated with lorlatinib, whereas that was 50% progression in patients treated with crizotinib. Again, these are patients who did not have brain metastases, and this is impressive CNS metastases. And I believe the data among patients who did not have brain metastases, in my opinion, conveys the CNS activity even better than the activity observed in patients with baseline CNS metastases. Now, does that mean everybody should get lorlatinib? And I can tell you that there are certain experts, at least in the US, that do believe that all ALK patients should be treated with upfront lorlatinib. And I'm somewhat resistant to apply this to all patients, partly because one, there are patients who do well with the earlier drugs such as alectinib, brigatinib. And in addition, lorlatinib does have some unique side effects such as hypertension in 10% of the patients, what is called as mental effects, including memory, mood effects that are seen, edema, peripheral neuropathy, and hypercholesterolemia. Now, most of these adverse effects can be well managed with dose modification, where you reduce the dose of lorlatinib, and the drug discontinuation rate in CROWN trial was only 7%. Nonetheless, these side effects can be impactful in a negative way for the patients, particularly considering that these patients are going to remain on this drug for a very long period of time. So could we be more selective in the way we utilize these different drugs? One possible way, and again, going back to what Dr. Grossi suggested, is looking possibly at ctDNA. This is data from the CROWN trial, and they collected baseline ctDNA as well as at 12 weeks and 24 weeks. And what was found is that the patients who did not have a sufficient decline, so the ctDNA was detectable at baseline, but at 12 weeks and 24 weeks did not have a sufficient decline in the ctDNA, did the worst. And actually the patients who did the best were patients who did not have any ctDNA detectable at baseline. So could we use ctDNA prospectively in clinical trials, ctDNA as a tool to identify patients that need to be escalated to a drug like lorlatinib, from a drug like alectinib or brigatinib, possibly, but trials will have to be conducted. And could we be more selective, more precise in our treatment approach? We know that the ALK portion in the EML4 ALK fusion in all patients is the same, but the EML portion of the gene varies, and based on that variation, there are different variants of EML4 ALK, variant 1 and variant 3 being the most common. And maybe there's data to suggest that variant 3 patients don't do as well, whereas in a very, very small data set from MGH, there's a suggestion that lorlatinib may provide better outcome in variant 3 patients. So it is possible that we use ctDNA co-mutation status as well as the variant, specific variant identified in the patient's tumor to guide us on what best treatment the patient needs. Of course, trials will have to be conducted to define those outcomes based on the ALK inhibitor used. And at least for me, ALK inhibitor used rather, and at least for me at the present time, I tend to use alectinib in most patients, but I do consider lorlatinib, particularly in patients with CNS metastases, because I believe the CNS efficacy of lorlatinib was the best across trial comparisons, but does appear to be the best. And then also in patients who have high volume disease, because it appears that lorlatinib is more potent. Whether that is the better approach or should everybody should be treated with lorlatinib, I feel remains to be seen. Now, irrespective of which ALK inhibitor you start off with, eventually these patients do develop progression, as was mentioned by Dr. Pazares, in EGFR mutation positive patients. And what is emerging is that the type of resistance mechanisms when lorlatinib used as a second-line therapy after initial ALK treatment includes development of what are called as compound mutations. So not just one ALK mutation, but multiple ALK mutations. And there are now fourth generation drugs such as NVL-655 that are being developed that, at least in the preclinical model, have shown activity against these tumors that have compound mutations. What is interesting is that even if a patient develops a compound mutations with two different mutations that individually can be inhibited by lorlatinib, when they occur concurrently, lorlatinib may not be effective, and at least in preclinical models, drugs like NVL-655 are effective. However, what is interesting, and this is very limited data presented by Dr. Philip from the CROWN results, that when used in the frontline setting, lorlatinib, we may not see as much on-target resistance mechanisms, but more bypass and other mutations that emerge as a resistance mechanisms. And the numbers are extremely small, but one possibility is MET amplification. This is a patient of mine. This shows the ctDNA in this patient, shows the ALK fusion, but also shows MET amplification that was not detected at baseline. And this was 2 years after receiving lorlatinib. And so we added capmatinib to lorlatinib. And you can see 6 weeks later, shrinkage of tumor. And there are now multiple case reports of using ALK inhibitors with MET inhibitors in patients who develop MET amplification as a mechanism of resistance. And so there's value in defining the mechanism of resistance at the time of progression. Moving on to ROS, an important aspect is there's a lot of overlap between ROS and ALK, though not all ALK inhibitors are active against ROS. And another important feature is that there are multiple gene partners. EML4 ALK accounts for 85% of all ALK translocations, whereas there are multiple gene partners observed in ROS1 translocated non-small cell lung cancer. There are 2 drugs that are FDA approved. First was crizotinib. This was in the phase 1 trial, the Profile 1001 trial. 53 patients enrolled, a PFS of 19.3 months. And then there's data, the other drug that is approved was entrectinib, very similar outcome observed with entrectinib with a response rate of 67%. But what was important to note is that it did have activity in the CNS, so the number of patients was very small. So this table shows the comparison. Please ignore the rest of the table because this has been outdated, but these are the two drugs that are FDA approved for treatment of ROS1 positive non-small cell lung cancer patients, and very similar activity, except that there is CNS activity observed with entrectinib, though the numbers are very small. However, now we have new drugs, data of which has just become available this year from taletrectinib at ELCC 2023. This is from China, showing a median PFS of 33 months with about 70 patients enrolled. So again, this is across trial comparisons, but does appear to be more pronounced, somewhat better than crizotinib or entrectinib, and also with intracranial efficacy response rates of over 90%. Similarly, repotrectinib was presented at World Lung in Singapore, and this slide was taken by from Dr. Jessica Lin's presentation of an educational session presentation at the World Lung session. And this was with repotrectinib with a median PFS now of 35 months, again, very impressive, 90% intracranial response rate. So it's quite possible that these next generation ROS1 inhibitors might become the standard of care frontline treatment over crizotinib and entrectinib. Now, again, as in ALK, patients do develop mutations, and the main ROS1 on-target mutation is a solvent front G2032R, and there are drugs now that can inhibit G2032R. So lorlatinib was evaluated post-crizotinib or other TKIs. And important to note, though, it has a response rate of 35%. It does not inhibit G2032R. So it may not be appropriate to just use lorlatinib post-progression after frontline crizotinib or entrectinib. Repotrectinib and taletrectinib have shown activity against G2032R, and those are the patients where the activity is best. Overall activity in patients treated with frontline crizotinib or entrectinib is about 35 to 50%. And activity has also been observed with NVL-520, another drug that lacks the TRK inhibition that is seen with repotrectinib and taletrectinib. And I will come to this issue a bit later on, that TRK inhibition does contribute to some of the side effects observed with these drugs, whereas NVL-520, at least in the preclinical model, doesn't have the TRK inhibition. We'll have to see whether the side effect profile is better than some of these drugs. So we do have options, particularly for patients who have on-target resistance mechanisms following upfront ROS1 inhibitors. So at the present time, our approach is entrectinib, crizotinib. We move on to a next generation TKI, particularly in patients who have a resistant mechanisms or to chemotherapy and clinical trials. Moving on to RET, and I know this is a very busy slide. I just wanted to highlight the fact that it is present in 1 to 2% of lung cancer patients, far lower than papillary thyroid carcinoma, where it is much more commonly observed. And also mention the common fusion partners, though there are several fusion partners that could be present. We also looked at real-world data and found that the outcome of patients who have KIF5B as the partner gene, which is the more common partner gene in RET fusions, don't have as good as an outcome as patients who have the CCDC6 partner gene. Again, emphasizing the fact that though we focus on the gene that is the primary driver in these fusions, such as RET and ALK, there can be contribution of the partner gene in terms of tumor biology and possibly activity of these TKIs. As everybody knows, in the past, cabozantinib and drugs like cabozantinib and vandetanib were used, but they were not as effective because these were multi-kinase inhibitors, and therefore there was a limit due to toxicities as to the dosing that could be done, whereas pralsetinib and selpercatinib are much more selective in terms of RET inhibition, and therefore they're better tolerated. The activity is also quite impressive with a response rate of 84% seen with selpercatinib in the Libretto 001 trial. in patients who are treatment naive. And this led to a promising progression-free survival, a median of about 22 months in patients who are treatment naive. And again, a common theme, there is CNS activity observed with the intracranial response rate very similar to the overall response rate of 85%. Similar data has also been observed with pralsetinib in terms of the response rate, as well as intracranial activity. Now, important to note that these TKIs, though selective, have some unique side effects. So sulfatinib can be associated with dry mouth, diarrhea, elevation in ALT, AST, and also hypertension. Something to note, as much as 20% of the patients can develop hypertension with these drugs. Pralsetinib, in addition to hypertension and AST, ALT elevation, we can see cytopenias. So generally, these are laboratory toxicities. It is felt that pralsetinib affects JAK2, causes JAK2 inhibition, and that is the reason why cytopenias are observed. But again, generally, these don't have clinical consequences. Finally, I wanted to mention regarding toxicity that one can develop chylothorax and chylous ascites. This was initially reported with sulfatinib, but has also now been seen with pralsetinib. It's not a common event, occurs in about 5 to 7% of the patients. But kindly note that if the patient develops pleural effusion or ascites, that is not assumed to be progression, but appropriate assessment is performed to identify whether this is a drug toxicity. As mentioned again, same with ALK, same with ROS, resistance can emerge with these drugs. But an important point, the data that has become available with sulfatinib and with pralsetinib is that we don't see as much on-target resistance as was observed with ALK and ROS1. Again, we see MET amplification, and therefore the next generation RET inhibitors, which not only are more potent RET inhibitors, but also inhibit the resistant mutations, which do occur, but only in about 10% of the patients. The role of these drugs, particularly in the second-line setting, is unclear, though there are several drugs that are undergoing evaluation. To finish up with TRK, important to know that there are multiple TRK1, TRK2, TRK3 genes, and fusions of all three can be involved in non-small cell lung cancer. I must say this is very uncommon in my own practice. I've never diagnosed a patient with TRK fusion, though it definitely does occur. There are 2 drugs that can be considered, at least in the US, for patients with TRK fusion. The data is this is lung cancer patients enrolled in a phase 1 studies with both these drugs. With a median PFS with larotrectinib of 35 months and 14.9 months with entrectinib. Now, important thing to note is TRK inhibition is associated with side effects, including weight gain, dizziness, withdrawal pain, a very unique side effect that is once you hold a drug or discontinue the drug, the patient can develop body aches. In very small percentage of patients, it can be quite severe. And so these side effects are not only seen with these TRK inhibitors, but also seen with drugs such as lorlatinib, repotrectinib, and taletrectinib. It's that TRK inhibition that contributes to these side effects. So important to note some of these unique side effects. As Dr. Pazar has mentioned, there are antibody-drug conjugates, both the HER3 antibody-drug conjugate, patritumab deruxtecan, and datopotamab, the TROP2 ADC, that are being evaluated in patients with fusions. The data available is extremely limited, but it is something worthwhile to keep an eye on as to whether these drugs have a role in patients who have progressed and don't have targetable resistance mechanisms. Finally, I wanted to finish up with these 2 data sets. Dr. Pazar has mentioned about FLAURA2. And my concern about FLAURA2 is particularly when it comes to fusions, whether we will start doing studies of adding chemotherapy to these targeted agents. I contend that infusions, generally, particularly when it comes to ALK and ROS1, the targeted drugs provide even better benefit than what we see with osimertinib in EGFR patients. And I don't think it would be appropriate to initiate trials in a non-selective way of chemotherapy plus a targeted agent. I'm certain that there are some patients in whom there is a role for doing chemotherapy early on, whether it is co-mutations such as P53 status or ctDNA analysis that helps us select this patient remains to be seen. But I sincerely hope that FLAURA2 doesn't mean that we have to now do phase 3 studies of chemo plus every targeted agent, particularly when it comes to fusions. And finally, recently we had a press release from Genentech Roche that alectinib did improve in the ALINA trial PFS in disease-free survival in resected non-small cell ALK-positive non-small cell lung cancer patients. And the question comes up that if in the advanced setting, these drugs have shown a certain have exceeded a certain threshold of efficacy, do we have to do adjuvant trials in every target to document the efficacy of these drugs? And I feel probably not, though that's a topic for further discussion. Thank you very much.
Thank you, Dr. Gagil, for the very interesting presentation. Thank you to all the other speakers for their outstanding presentation. We are very late, so we have time only for one question per speaker. Don't be shy. No, okay. I have a question for Dr. Grossi. Will liquid biopsy ever be able to replace tissue sampling in clinical practice? Or tissue is the issue per l'eternità?
I believe that at the moment, no, because the problem is the RNA. So at the moment, we cannot have this evaluation. And probably in the future, I believe that the situation changed, and probably, I'm not sure, because the tissue is the issue and probably is complementary to the tissue, the liquid biopsy. But in the future, I believe that we have some important news also for RNA. I hope.
Okay, thank you. Have you a question for Professor Passares?
Let's be question Professor Passares.
Can I ask a question to Dr. Passares?
Okay.
Okay.
So Luis, wonderful to see you. Would love to know your take on FLAURA2. How would you use that data? Again, it's not yet approved in any jurisdiction, but if it was approved, how would you use that result in your practice?
Well, I think that's a relevant question. At present, looking at the data, some patients that maybe I see that they need a quick response, that they are at, I see they are at risk of early progression or something clinically is frightening me, or maybe the very cases with brain metastases, which I don't know because it's just this sub-analysis, which is not very robust. But other than that, I will comment the data with the patients, but my inclination would be for TKI alone, at least in most of the cases. That is the truth. Because as we mentioned, here is, we like our patients to live, the longer the better, but having the better quality of life and so on. So I'm not pretty sure that we are helping a lot by anticipating that. And I would assume patients are going to be against in many cases. But it has to be individualized, to be honest. But my initial taking is that, and I'm doubting, looking at the shape of the curves and so on, that we are going to see ever a survival improvement, to be honest. You? What are you going to do?
I completely agree. My hope is that it doesn't become the default standard in EGFR patients. My worry very candidly is once it gets approved in the US, there might be a lot of use of chemo plus osimertinib, which I don't know would be the right interpretation of the results. As you mentioned, we'll need to be very personalized in our approach.
Of course, it would be nice to see some other type of sub-analysis, like let's say, what happened with those tumors that are p53 positives and, you know, commutated and some other analysis, but if not, it's going to be difficult.
Okay, we have one question for Dr. Gaggil from the virtual audience. Especially in HLK positive patients, do you think that a sequence drug strategy can still have a role, or the best choice is the use of the potential most effective drug as first treatment?
Yeah, the general approach is to use the most effective drug. However, I think as drugs become more and more effective, one wonders whether it is a strategy that should be much more nuanced. So when we had only chemotherapy as our option, I feel like it was obvious that we needed to use targeted therapy in most instances. But as we now are reaching a point where we are getting better and better drugs, and there are at least some patients who develop a very prolonged benefit on earlier generations of targeted drugs, I think the approach of using the next generation drug, even though it appears to be more potent, in all patients may not be the best approach, at least in my opinion. And I think I would revert back to what Dr. Pazares mentioned in the context of FLAURA2, that I think it would be worthwhile to be much more nuanced, try to understand the patients who are at risk of early progression, try to understand the patient who have a relatively poor prognosis, and then assess whether the best upfront drug provides better outcomes than not so effective drugs that also provide a long progression-free survival. We will need a lot of trials to sort of understand that. And I'm hoping that liquid biopsy can help us, because I think if you just wanted to follow progression-free survival, it would take many years to complete those trials. And I think developing proper tools to understand long-term efficacy at a relatively early point will allow us to conduct those trials where we do targeted treatment based on a variety of factors and understand if the outcomes are improved by selecting certain patients for specific drugs. It was a long-winded answer to tell you I don't know, but at the present time, at least when it comes to ALK, I am trying to use alectinib in most patients and lorlatinib in a select group of patients.
A last comment on this topic from Professor Grossi and Professor Pazares.
You know, I have to be honest that when I first saw the data of the CROWN, I didn't change my practice most of the time. Nowadays, I tend to do it with some patients and at least comment the data. And I also feel toxicity is not as bad as I was originally, you know, after getting used to lorlatinib and to the side effects and to manage those. So I'm a bit more comfortable, and I would say I tend to offer. So those are, I mean, the main point is CNS disease. I think this is going to impact in the long run in some other outcomes, but you know, those patients are living very long today, years and years, and it's very important not to live with CNS disease. At least I think that is a clear, let's say, a very relevant fact in the natural history of a patient. So I'm more inclined now. I didn't do at the beginning, but when I saw the updated PFS, particularly PFS in CNS, I'm more inclined to use also here this thing, which is best drug first, second best second, third best third. And this is something that I'm typically doing, and I'm mostly doing nowadays.
I agree with the general rules that the best first, but in this situation, we have no comparison between alectinib or brigatinib and the lorlatinib. So for this reason, probably we need also sequential treatment. So in this situation, due to the activity in all the mutation that appears after treatment with second generation TKI, probably we can consider the lorlatinib as a second line after the alectinib or brigatinib. So for this reason, I mean, we need a sequential treatment. So in this situation, if we move lorlatinib first line, the sequential treatment is only with chemotherapy or other agents, not with other ALK TKI. So for this reason, I believe that second line for lorlatinib is good. But it's, I mean, it's an opinion, but I agree that the best first, so probably the best is lorlatinib, but we do not have the comparison.
But I mean, I understand we don't have the comparison, so if we have it, we didn't argue. But now the data, you know, is looking more and more robustly better. So then that is the thing. So this, you know, this thing that we need something at the time of relapse, of course, but the first thing we need is relapse not to happen or to be delayed. So if the drug is better, I don't have the issue. The main problem is that they don't have being compared head to head. That is honest. Yeah.
Okay, thank you for your answer. We would like to go on with the discussion, but the time is really over. It is time for the special lectures. Special lectures generally don't have questions, but I think we can do at least one question at the end of each lecture if the speakers agree. So let me to introduce the chairs of this last section. Diego Signorelli from Niguarda Cancer Center and Giuseppe Viscardi for Monaldi Hospital of Naples. Diego and Giuseppe, welcome.
So, good afternoon, everybody. First of all, thank you, Giuseppe, for giving me the opportunity to be here also in this year at this very amazing meeting. And so let's start the last session with the first speaker, Professor Gabriela Sozzi. Professor Sozzi, she's the head of Tumor Genomics Unit at Istituto Nazionale Tumori in Milan. And she will talk about new biomarkers for early diagnosis of lung cancer. Thank you.
Thank you to Beppe for kindly choosing me again for this fourth edition of a cocktail with lung cancer. As you can understand from my title, I'm talking about biomarkers in a quite different setting from the setting you heard today. We are searching for biomarkers, and our group and other people around the world, obviously, to improve the benefit of screening and to better understand and detect early lung cancer. So these are the major points I will focus on during my presentation. Let's start with an overview on lung cancer screening, even though after Pastorino's talk, I don't have to say any more, unless that at present, the major benefit for health for lung cancer is early detection through low-dose tomography. And this assumption is based on the results of the three major trials: the US trial, the Italian, the Belgian, Netherlands trial, the Nelson trial, and our smaller MILD trial. All of these trials, although with different number of screening rounds, different follow-up, and machines, nonetheless demonstrated a significant reduction in lung cancer mortality. the common finding of these trials is the remarkable increase in the detection of early stage lung cancer. Stage 1, 2, over 50% detection in this randomized trial. And I remind you that only 10-15% of stage 1, 2 are detected in the real life without screening. So even though CT has reached a very advanced specificity due to the introduction of new machines, software, and so on, artificial intelligence too, nonetheless, the development of non-invasive biomarkers could still be helpful in the screening settings in at least these three major areas to identify and better select a high-risk population and determine individual personalized screening rounds in high-risk individuals as a second-line test to resolve those indeterminate suspicious nodules identified by CT and therefore potentially decreasing false positives. And finally, during surveillance after curative resection for lung cancer to identify early lung cancer, early recurrence of lung cancer. I'm going to focus on the most advanced biomarkers that have reached an advanced validation step. And speaking on cell-free DNA biomarkers, certainly epigenetic changes seem more informative than specific tumor genetic changes such as mutations or copy number. And the targeted methylation classifier Galleri, also called the GRAIL, is the one who has reached the most extended validation in this large-scale clinical trial. For example, the case control trial, they found they tested the efficiency of the Galleri classifier to detect and also to determine the site of origin of 50 different cancer types. Indeed, the test showed a quite good specificity, over 99.5%, at a sensitivity around 50%. Interestingly, sensitivity was different across different tumor types. This is a MCED, a multi-cancer detection test. Concerning lung cancer, overall sensitivity was around 75%. However, when we look at sensitivity of Galleri for stage 1 lung cancer, as you can see here, there is a clear drop in sensitivity, less than 22%. So the major limitation of this classifier is that has been validated in case control studies. So the study design is probably different than is not informative of the screening population. And therefore, I'm aware that there is a large program, mainly in UK, including the Summit trial, Pathfinder trials. They are trying to validate the classifier in a targeted population, the screening population target. Very recently, the same team has validated has evaluated the performance of Galleri in a very large prospective cohort study, enrolling symptomatic patients that referred for primary care at 44 different hospitals in England and Wales. And in this large study, over 6,000 participants, they achieved with the Galleri classifier quite a good grade of sensitivity, 66% of overall sensitivity at a sensitivity over the 98%. Sensitivity was lower in stage 1 in all cancer types, around 24%, increased with increasing stage, increased with age. And look at lung cancer, as you can see, there is overall sensitivity was around 78%, but here again, when looking at sensitivity across stages, it is clearly visible that in stage 1, sensitivity is less than 10%. And the other finding is that looking at symptomatic subject, stage 3 and stage 4 are the most frequently detected in this cohort. So this is not precisely the good setting to validate an test for early detection. The other cell-free DNA test that has reached an advanced validation phase is the Delphi. Delphi is based on a genome-wide analysis of fragmentation patterns, based on the assumption that cell-free DNA released from tumor cells has more variable fragment size compared to cell-free released by normal cells. And the team here, the Delphi team here, has developed by wide genome sequencing and an accurate bioinformatic pipelines cross-validation of machine learning, a cancer model that was validated in 2 independent cohorts, the discovery cohort, a Danish cohort, and a smaller validation cohort, again from Danish. This is the output of the performance of the Delphi, good specificity over 80%, however, again, sensitivity, which is very low, quite low, at least but higher than GRAIL, around 50% sensitivity for stage 1, 2, increasing with increasing stage. The SEM team, the Delphi team, has recently published this paper in CHEST, where they use a similar study design as GRAIL. They are looking for the efficiency of the test in symptomatic patients, a symptomatic subject referring to hospitals. These are subjects either with symptoms or also with or without abnormal imaging. They performed the Delphi classifier, and they look at the efficiency of the classifier compared to symptoms. And indeed, they found that the classifier, the Delphi test, had a better accuracy in detecting cancer compared to symptoms, either specific symptoms or the number of total symptoms presented by the subject. Here, again, the flow is that the cancer detected in this cohort were mainly stage 3-4, 83%, and thus this study is informative for detecting not early stage but late stage lung cancer. However, by combining Delphi test with symptoms, the area under the ROC curves show real better, very good results. So we are awaiting again here for validating Delphi, and we are actually collaborating with the team to prove the efficiency of these tests, which sounds important in a screening population. So we are really recently collaborating and sending samples to the company. Circulating tumor cells. This is another biomarker. I have inserted this slide because I was in a liquid biopsy meeting last week. Indeed, this French team has evaluated the value of CTCs in a real screening setting by combining CTC detected by the ISET technique, a technique based on the isolation by size and morphology, with low-dose CT, with imaging, so radiomics and biomarker. They use a small cohort, 600 volunteers with COPD, a condition predisposing to lung cancer. Also, all of you know this. The sensitivity of ISET for CTC detection was quite low. Sensitivity was 26% at baseline, so to detect prevalent lung cancer at a good specificity. Unfortunately, when looking at the performance of the test to detect incidence cancer, these around those arising at subsequent round of screening, so T1 and T2, the test is not clearly able to detect any cancer, and indeed the same author concluded that at present CTC detection, at least using ISET technology, there are many other technologies now, but is not suitable for cancer screening. What about RNA biomarkers? This is, to me, a very interesting category. And at least a couple of studies have shown the good performance of RNA small circulating RNA. This very recent study was published a month ago in JTO. Sikosek and collaborator developed a diagnostic model based on circulating small RNAs using a very multicentric large cohort, 7 different centers from US and Germany. Interestingly, to mimic a real-world screening setting, they selected subjects with the eligibility criteria of NLC, so subject aged over 55, smoking history over 30 years. And also, the other good story is that they analyzed all blood, not plasma or serum, collected at diagnosis at confirmed lung cancer in cases or excluding ruling out lung cancer for controls. They used a very deep and ultra deep RNA, small RNA profiling with an accurate bioinformatic pipelines. They developed a classifier called MILUNG, composed of 18 small RNAs, which was validated in a large cohort, large validation cohort, 500 subjects. These are the results. Interestingly, half of the features as composing the classifier are microRNAs, the other are small RNAs of other types. Performance was overall quite good, better in higher stage disease than stage 1. Again, here, the MILUNG score of the 18 signatures showed here, showed a sensitivity, probability of detecting cancer in more than 50, around 60% of stage 1 lung cancer. So this is very promising. Although the accuracy is higher in small cell lung cancer and squamous cancer compared to adenocarcinoma, which is the major finding in screening trials. So this study has certainly some strengths, which is the robust pipeline and the use of all blood, and also in a small subset of patients, they also use dried capillary blood spots, thus suggesting the possibility of performing sampling at home, which is a major point. And the weakness are the focus on prevalent lung cancer, not on incident lung cancer, which are the major issue, and the lack of association with radiomics and sensitivity, which is relatively low in stage 1 and adeno. So the other large category of RNA biomarkers are microRNA, and in our institution we started already more than 10 years ago with a strategy of lung cancer risk prediction through the use of circulating microRNA combined with radiomics, with CT. To make short, a quite long story, we, starting from a pilot screening trial, we identified 24 circulating microRNA composing diagnostic and prognostic signatures. For the validation of these signatures, we generated a unique classifier, 3-level risk classifier, MSC, microRNA signature classifier, low, intermediate, and high risk, which was validated in 1,000 volunteers of MILD. And here you could confirm the quite promising sensitivity and specificity of the classifier. And based on this promising finding, we launched in 2013 the BioMILD trial. BioMILD was the first prospective trial combining blood biomarkers with radiomics, with the low-dose CT in a screening, for lung cancer screening. And in fact, we aimed, and the results were published last year in Annals, we really aim to evaluate the utility of combining the two markers to predict an individual risk, and based on the individual risk, send subject to further screening rounds. We also wanted to determine the possible value of our assay to discriminate those indeterminate lesions found by the radiological examination. So the accrual is here. We started with more than almost 10,000 volunteers, ended up to the trial with 4,119 volunteers admitted using very strict criteria, excluding previous lung cancer diagnosis, excluding lung nodules under surveillance, or CT examination less than 1 year. They were offered CT, blood examinations with MSC classifier, and also functional measurements. We classified our volunteers into 4 risk categories: double negatives, the majority, 65%, those having only one test positive, either MSC or CT at baseline, that were sent to and the double positive subject with both test positive, 5% overall. And these subjects were sent to different screening intervals according to their individual risk. So we courageously sent to 3 years the double negative subject, to 1 year the intermediate subjects, and the double positive were sent to 3 months or even shorter intervals. These are the findings. Lung cancer cumulative incidence was clearly and significantly higher in double positive subjects compared to the other risk categories. And among the CT-positive participants, the discriminant power of our classifier was maximal at 2 years, as you can see here, and then tended to decrease over time, but we used only the baseline value of the test without considering repetition. The hazard ratios, the Cox models were also quite informative, a strong effect of CT alone, but also significant effect of MSC alone, and a major effect by combining CT and MSC. We then look at the possible predictive value of MSC by looking only at prevalent cancer. So we excluded baseline cancer detected at baseline, and we confirmed that MSC has predictive value. The model MSC plus CT has a predictive value also for incidence lung cancer. Again, with a maximum efficiency at predicting cancer at 2 years and a decrease over time, as expected, and a major effect of the combination of CT and MSC in the Cox models. Recently, we are assessing the value, the usefulness of a longitudinal assessment of a MSC test over the 6 years of follow-up. And these are the results which are really interesting, because by repeating MSC, by considering the results of MSC at each round of screening, the lung cancer prediction is significantly higher. As you can see here, the course remains very open over time, over 6 years. So the lung cancer risk prediction of MSC increases significantly by repeating the test every year, every time the subject comes back to the hospital. And concerning mortality, we look at mortality, and again here, the double positive subject had a significantly higher mortality rates than the other risk groups. And this was true for CT alone, for MSC alone, and for the combination of the two, which was most prognostic than the other factors. This is a very new and interesting finding that I already discussed with Marina previously. Our model, MSC and CT, was able to pick up lung cancer incidence with the same efficiency in men and women. This is a gender study. However, when we look at the mortality, the prediction of mortality of our model, it was significant only to predict lung cancer mortality in men, but not in women. And the reason of this is that women in our screening trial do not die. I mean, the mortality in females is very, very low. And this is a finding already reported, in a small population in the Nelson trial. They had few women. Also, the NST found a major benefit in women. This is clearly evident here. And to this purpose, we are currently studying the biology of female tumors in the TCGA study, the one who Ugo showed in the morning. We are performing a wide genome, transcriptome, metabolomic, immunomic profile of these tumors to find out if we can explain somehow this difference in benefit of screening between men and women. So these are the take-home message of the BioMild. Indeed, we showed, I think for the first time, that the combination of radiomics with the blood biomarker is helpful, can define individual lung cancer risk, reduce unnecessary repetition of radiological examination without major detrimental effect. And that we noticed that MSC is a little more informative to discriminate indeterminate positive lesions, because in a CT negative subject, the cancer are so low that the addition of MSC doesn't add anything significant. And this is all. So let's conclude with the ongoing studies. What are we doing now? We are thinking that the combination of different biomarkers could be more helpful, more than a single biomarker. And based on these hypotheses, we developed. Also based on the finding that I'm going to present briefly on, that the origin of our MIRNA composite classifier were the immune population, so were released mainly from immune cells. in collaboration with the team of Licia Rivoltini at our institution, we decided to look at the circulating immune profiles of the biomilled subject. And by performing an high-resolution flow cytometry using a small training and validation set to develop a model, we noticed that at least these 4 populations, myeloid-derived suppressor cells, intermediate mono and exhausted activated cytotoxic T, were able to significantly differentiate early cancer patients versus controls. In parallel, we developed a gene expression signature encompassing 4 genes, encompassing the 4 subpopulation to have a more flexible tool to be used in a clinical, an RT-PCR-based tool. And indeed, we noticed that this classifier, either the flow and the RT-PCR test, were able to identify lung cancer in MC-negative subjects, suggesting the possibility of rescuing the false negatives results. And indeed, we also stimulated a chain rule approach for lung cancer screening by combining the 2 tests, MSC and ISC, in indeterminate lung lesions, and noticed that negative predictive value could be raised to 99%. And based on this assumption, we can send the participants to longer screening, those having the 2 negative tests, to longer screening intervals. We are progressing with these studies. We have funding from Ministry of Health. Last year, Ugo and Pasolino and Mattia Boeri got this support from Ministero to have a study on the biomilled set, combining by artificial intelligence, radiomic features with blood biomarkers, MSC and ISC, the 2 blood biomarkers, to develop the personalized, more refined personalized risk model. I just included a couple of slides that Mattia gave me to recognize this other approach very shortly. Given the strict relationship between our microRNAs and immunity, we took advantage of the Apollo trial, the trial run by Thoracic Oncology unit at our institution, the former team of Marina, now led by Pepe and colleagues. And we look if the MSC could be helpful to distinguish the patients more benefit of ICI, of immuno-oncology. And indeed, we noticed that when that MSC high-risk patients have a worse prognosis in Apollo and a worse prognosis when treated with single-agent immuno-oncology. However, this phenomenon was totally rescued, so it lost prognostic, worse prognostic value when in patients, in subjects that received the combination of ICI and chemotherapy. And indeed, this other representation shows this finding, MSCI in combo have a better survival than single agent subjects. And based on these preliminary findings, Claudia Proto and Mattia Boeri have applied for a grant. They won this grant with this trial called ARC, where they test the hypothesis that in a prospective manner, they will accrue non-small cell lung cancer patient 3C4 stage with PD-L1 over 50%, no driver alteration. They will perform MSC test, and MSC high-risk patients, which are usually 25–30%, will be randomized in 2 arms, a control arm receiving only single-agent immuno-oncology, and experimental arm receiving combo until progressive disease. And we are waiting for the results. I know that the trial started these days. The first patients were enrolled, and so good luck to the investigators. I wish to thank the collaboration. This is the thoracic screening team. The clinical oncologists are obviously acknowledged here. The leader is Ugo Pasolino, as you can see. I want to remind you, to the young people, that this type of screening study is so complex, so difficult, so long, can be done only by multidisciplinary teams. So strict collaboration between thoracic surgery, radiologists, statistician, smoking relation offices, and obviously the lab. This is my lab, and I wish to thank particularly Mattia Boeri, who is the one who developed the MSc test. And thank you to you for your attention.
Thank you very much, Professor Sozzi, for your presentation. Are there any questions from the audience? I have just one question. Among the issues of many liquid biomarkers, there are the barriers related to their introduction in clinical practice. Because of a lot of reasons, such as the costs, they are generally expensive, the turnaround time to achieve the results. But do you think that MSSC test could overcome these barriers?
Yes, I think so. I think that so far costs for our liquid biopsy tests are really dropping. MSC in particular is a very simple test, is an RT-PCR test using LNAs probes. The cost of this test is around 100 euros. And the good news is that we finally, we are approaching to a technical transfer of our test to a certified lab as a benefit corporation with a certified lab in Milan, Cogentech. They are developing and the test in a certified conditions, and they will try to transfer the test to the national health system, because I mean, the scientific proof validation of the test has been done. And so we think it's time to go and offer the test to volunteers, to smoking volunteers together with CT, which is the standard of care, obviously. I mean, we believe that the best combination is biomarkers and CT. We cannot think that in 2023, you do not do low dose CT for early detection, unless you can't do it for, health reason. And in this case, you can do the test only, and you can follow the test over time. I think that we are now reached quite a good step forward to releasing the test in the real world. We also.
For your very interesting presentation. Okay, so go ahead with the second lecture of this last session. I'm very pleased to introduce Dr. Arcela Prelai, my friend Arcela Prelai. She works at lung cancer unit of Istituto Nazionale Tumori. Arcela is also a PhD student of artificial intelligence at Politecnico di Milano, and moreover, coordinator of just born AI on lab in Milan. She will give us a presentation about the role of artificial intelligence in patient selection and treatment tailoring.
So hi everyone, thank you Visky for the presentation, and to Giuseppe, because I have to divide it to Giuseppe for this very kind Congress. I mean, our traditional Congress born from Marina here. I'm very happy. So two few things. I have to cut 5 minutes because we are a bit in delay. And so the other thing, I have to take your attention because it's 6:30 p.m. maybe. So to take your attention, especially the one of Giuseppe, and to make the link to Giuseppe, I bring this analogy and introduction of AI here today. Giuseppe is passionate to the antique Greece, so here are. And let me just introduce to you and say that, like the science of Greek myths, AI promises are alluring. So it's also tempting to delegate to it a significant part of our work. However, like Ulysses beat the Sirena songs with carefully planning and disciplines, we must be cautious, but not scared. So it's not magic, it's science. Okay, so just to introduce you that this is a really initial of our long journey in AI, and I would like to start directly with some challenges because I mean I decided to do this presentation in a more perspective ways and just to give you some of the tips and things that we are studying now and where AI is going and which are the main problems that we have to face. So first of all, we know that one of the main problems in oncology is the number of patients. So we have basically a low number of patients and unfortunately, retrospectively, a low quality of the data. And we really need to work in these two parts of the big volume data in order to at least be equal or better, let's say, one day compared to other sectors in AI. So another challenging, which is very important for us, is how we can implement AI from research to clinical practice, because this is another question. So there are many publications today, and all of them are at the research level. There are few of them in a diagnostic path, which can help us in clinical practice today. The other thing is how we can face this problem with the patient, because today, one day we have to explain our patient how AI works and which are the algorithm paths, which is the black box behind and the reasoning behind. So this is another problem to face. And the other thing which Marina likes very well, a lot, it's that the problem of the AI algorithms is that they do not have the context that we have. So the medical doctors that have started and studied for a lot of years medicine, I mean, they know the context. They try with their brain, they have a really good reasoning and sometimes know to say, I don't know, why the algorithms still has to be trained to say, I don't know. And this is the uncertainty of an AI algorithms. So these are all the things related to the trustworthiness and the models itself. However, there are, many problems with the digitalization. So for example, there are many data to be processed, and there is a very timely loading in these, for example, to radiologists, pathologists, and us that are every day working a lot in our daily practice with patients. The other thing is that we need new infrastructures, new digitalization, new labs, for example, as dry lab with GPUs, with high calculations that can help us to process all these data. And last but not least, we do not have to remember that all these data processing and sharing that we need to put together really with this high technology and progress, we are so far from a very high progress in legal and ethical framework, and we need to really work a bit more. So I'm just focusing very briefly to some of these challenges to explain you more in detail. And the data matter, I'm very happy to present you today this project, which is Apollo 11, and is running from 2 years now. And the aim of Apollo 11 is to be one of the first model of data-driven research in AI. Data-driven research means that in case of biomarker study and design, so we need to try to shift from historical hypothesis-driven to data-driven research, which means that it's enough with one, we don't have to do anymore. I mean, one question, one hypothesis and one answer to a protocol, because it's a really high load work with AI. So we need, for example, in this case, maybe to do a more general protocol, in case master protocol, for example, focusing on a certain disease with a major certain problems, like in this case, biomarker. This is Apollo 11 focused on biomarker study, prospectively collecting and longitudinally collecting lung cancer patients' data treated with innovative therapies, next generation therapies, immunotherapy, and target therapies. And the focus when we designed this project is to leave also to give the possibility to the centers to be independent on their data. So the data are decentralized. They mean that they talk the same language with the same ECRF. And the objective is that we have now built the architecture with a federated learning that's trying to talk within among the different ECRFs. And at the same time, we are building now the federated learning design for also images, which would be very personalized within each center. Finally, the Apollo 11 aim, it's also to collect the biomarker material in order to be ready, I mean, to answer every question that we have, and not only to wait and waste time for many years and by collecting material only when you have the question. And all of them, the aim is to analyze with AI analysis. So the second question, how we can translate from research to clinical practice. This is, I can say now, a quite accepted paper on systematic review analysis of oncology that we did this year. And this systematic review is presented, it's about 19 studies, the most interesting studies based on cancer immunotherapy and AI biomarker. And the thing is, as you can see here, but that I want to underline is that there are many interesting data related to biomarker discovery part. However, there are no studies in these, at least at the data cutoff that we collected, that has methodological design ad hoc with AI. So for sure, this is a great challenging, and I'm happy also to present you this prospective study, which is a European Horizon European project that we developed and within 2021 together with Dr. Garcino. There are 16 partners involved in different cancer centers in Europe, Israel, and US. And the aim is obviously to answer to the most important question that we have in non-small cell lung cancer, so predicting immunotherapy response by collecting real-world data and multi-omic data retrospectively, but also prospectively. And so there are three cohorts mainly in these projects. So one is retrospective, collecting real-world data such as and the real-world data, but also images such as radiomics and digital pathology in around 2,000 patients, develop and prospectively validate these models prospectively in other 2,000 patients, but also we go more in depth with multi-omic analysis in a bench of 200 patients in order to understand a bit more the adding value of all these omic within our real-world data and new generation of real-world data, which are the images. So as I said before, mentioned trustworthy AI, it's really a very recent field, but it's very interesting because it's challenging because at the one hand, it's very good. There are very good models now that can explain you, for example, how we build the model in AI within, especially when we have real world data. However, there are hot topics and challenging within images because still we are able to predict, for example, and explain the local images, however, not the global ones. So these are a very challenging field. And I'm happy to present this work, which is a very good collaboration with University of Chicago and Politecnico, which I started this year during my visiting at University of Chicago. And so the question here, the main objective, it's a complex design, but the main objective here is to understand from different multimodal modality, the correlation, the explainability between models, for example, between pathomics and radiomics, and also transcriptomic data, etc., in order to understand and to do also a cost-effective analysis and to understand if we can imply and we can understand and guess some biomarkers from images instead of other type of transcriptomic biomarkers, for example. So, but let us see also the other side, the positive side. So, and which can be the AI perspective in this case. So for sure, in this era, we are facing with new type of biomarkers, which are the images, for example. We had the images, we collected already, so are part of real world data because we have it at house. However, we need a lot of effort to analyze them, but they are very, very informative. And I can say you that images, so radiomics and digital pathology, are the two main fields that will rapidly change in the next 5 years our clinical practice. So the other thing, interesting, more perspective things that with AI, we are, as Gabriela said, we are interesting data with how we can not only analyze static data, but also longitudinal ones. And also with AI, we can start to understand how we can shift from 2D images to 3D images, not only radiomics, there are very kind papers, but also in pathomics part, which I will show you an example. And also the data, the open source repositories are very important in order for us to try to understand, to validate the AI algorithms. So these are very important. At the last but not least, the education. So we are here different people, and many of you are resident doctors, but I have a group from Politecnico, which are bioengineering. So we need dual type of education. Them has to know more as they are doing today in lung cancer, but also we need to know a bit more on AI. So just another analogy to say that related to the biomarker, I bring you Mona Lisa, which is represent the well-established biomarkers, so which are the genomics one that we know, but also, I mean, Dali, which is the new generation of biomarker, and he can represent our images. But the thing is that with AI, the aim is not only to create a sum of them, but also to create, let's say, a room for new discovery and new representation. So related to the longitudinal analysis, there are very interesting, and I'll show you a paper if you can go and read it. So the thing is that with longitudinal data that, for example, in Apollo 11 we are collecting, would it be interesting that with deep learning to understand the trajectories and all the informations that patients collect during their journey, the disease journey, and in order to, let's say, also adapt our algorithms and to influence better the outcome compared to static and predictions. So this is a very good paper. It's an example of that that have used in pancreatic cancer in this case. However, there are 24,000 patients, and a really interesting how they develop these algorithms, deep learning algorithms, to study the patient trajectories and to predict pancreatic relapse in this case. So moving from 2D to 3D, it's very interesting, and this is a new paper published this year. And on the idea was how we can, I mean, face better with pathology. We know Monica is here; she knows very well there are many problems when we do all the pre-analytic things with the pathology and the biopsy. So in this case, what they demonstrated also with some packages with AI. Visualization is that probably leave the 3D pathology would be very, very interesting and would give us more information. And the thing is that we have to build more powerful AI tools in order to analyze this type of data. And finally, as I said, this is a very interesting publications, and this on Nature Medicine, on Twitter images, pathomics images, and also neural language processing. So they basically created this open path, which is the larger data open source database in pathology today, with around 200,000 patients, with 32 hashtags that they use. And what they was able to do, basically, what they did, take all the publications that were there out within today, and they really outperformed. So this, I'm sorry for but this PILP, which is their signature, and the algorithms were able to outperform all the previous publications. This is why I said the data matter, and this is an example. And finally, related to the education, I mean, if you remember, the Tower of Babel was not built at the end because they didn't talk the same language. And so the idea is that we need really to talk the same languages with different figures such engineers, medical doctors, data science, in order to talk together the same languages. I'm very happy to say that we are more and more shifting for wet to dry, but not only a shift, it's a shift of idea. But the thing is that these laboratories has to be obviously a hybrid work. So both of them matter in the research, and this is just a representation of a figure of our lab that has been recently opened. So saying that, I'd like to thank you everyone for the attention. Thank you to Marina, and thank you to Giuseppe for inviting me, especially the lab, the lung team, which has working a lot for this data and sustaining us in this research. Thank you.
we have time for one question. I have a question for you. In your presentation, you showed as AI focuses on deductive model, analyzing real-world data to discover new pattern not otherwise visible. In this context, what do you think about the use of synthetic data or generation of so-called synthetic patient? Which opportunities or challenges?
So thank you for your question. I mean, this is another hot topic. I couldn't, but would be one of the list of the really challenging in, but it's not a challenge in AI. This is a great challenge in AI for oncology, because creating synthetic data in oncology, it's really risky. It's risky because we are individual, we are very different. So, and there is no consensus of that. There is no publication. We discussed when we meet in University of Chicago with Marina and Alex, which is the head of the data science department. And we discussed about it because really there is a need probably to develop some guides for synthetic data in oncology, but I would say not only in oncology in general for patients, but to build the synthetic data based on different data types. For example, what I imagine would be more simple, what we are doing now, especially with images. However, you imagine how we can build, it's very difficult to build the synthetic data in transcriptomic fields or genomic fields, which is quite, I mean, peculiar. So there are many, there is no data there, but for sure we need to go more in depth with that. Yeah.
Okay, thank you very much, Arsi. Last but not least, it's a very great honor for me to introduce the next speaker, my colleague, my friend, Roberto Ferrara from San Raffaele Hospital in Milan. He will talk about immunosenescence and biological hallmarks of aging in the immunotherapy area. Roberto, you have the floor.
Thank you so much, Giuseppe, for the invitation. Thanks, Diego, for the introduction. So 7 p.m. is perfect time for senescence, and so this you fit perfectly with the topic. These are my disclosure, and this is my agenda. I will talk about 3 different types of ages: chronological age, biological age, and immunological age. And in the last part of this talk, I will show you some data about xenotherapeutics, that are pharmacological intervention in order to reverse senescence, and also lifestyle intervention in order to modify immune senescence. So cancer is a disease of aging because, as you know, as oncologists, most of the cancer patients, at least as thoracic oncologists, most of the cancer patients are elderly patients. 70% of our cancer patients are elderly patients. And it is estimated that in 30 years, so in 2050, there will be an 87% increase in the cancer diagnosis in patients older than 80 years. So that means that a silver tsunami is coming, and we are not able to deal with this tsunami because probably we don't know which are the hallmarks of aging and how these hallmarks of aging are able to guide our treatment choice. But most of the people, they think that aging is something bad happening to our body, but actually aging makes us unique. As you see in the picture, there are 2 different ladies. One is 95-year-old and she's running a marathon. The second is 77-year-old and she's on a wheelchair. So there is a big gap in chronological age, but both women, they have the same life expectancy. This is because there is also a big gap in the performance status, so in the clinical condition, and this gap in the clinical conditions counteract the gap in the chronological age. So even if you see 2 women of 80-year-old, probably if the performance status is very different, also their life expectancy is very different. So the message is that chronological age has some limit, and probably we should stop to treat the age of the patients, and we should consider the patient as a whole also regarding the performance status. But performance status is not enough. because this is a survey from International Society of Geriatric Oncology in 2019. You see that around 50% of oncologists, they think that their elderly patients, they could live more than 1 year, but actually these patients, they live less than 6 months. So they have a high expectation regarding the survival of these patients. And 20% of the thoracic oncologists, they think that elderly patients, they will live probably less than 6 months, but finally these patients, they live more than 1 year. That means that if we use chronological age and if we use performance status, as oncologists, we are not very good in estimating survival of the patients. We need something more than these two parameters. And probably geriatric oncologists, they do it better because they use a lot of domain to evaluate the elderly patients, not just the chronological age, not just the performance status, but also the mood, the socioeconomical status, the mental health, the nutrition, and so on. So as you can see, using the G8 score, and this was done 10 years ago actually, using the G8 score in 50% of the patients who have a very good performance status, 0, 1, elderly patients, you find some impairment in other domain, and these impairments are correlated with survival in these patients. But beside the chronological age, we have another kind of age that is biological age, and senescence can be a synonym of biological age. One message that you have to remember regarding senescence is that senescent cells are Highlander cells. They are cells that are unable to proliferate because the cell cycle is blocked, is stopped, because there is an upregulation of P53 and P21 and P16, but there are also cells that are they're unable to die because they don't die because they have an upregulation of BCL2 and BCL-XL that are anti-apoptotic protein. And the second message about senescence is that these cells are functionally activated. They produce cytokines. There is a senescent associated secretory phenotype. So there are 70 different chemokines and cytokines, interleukin-1, interleukin-6, interleukin-8, VEGF, and these cytokines are responsible for tumor progression and tumor growth. Senescence, as many immunological phenomenon, is a double-edged sword because it can be pro-tumoral or it can be anti-tumoral. It depends a lot on where is happening senescence, because when senescence is happening in the tumor, it means that tumor cells, they are more immunogenic, they are recognized by T cells, they are recognized by NK cells, and they are eliminated by the immune system. But when senescence is happening in the stroma, so it's happening in the fibroblasts, it's happening in the extracellular matrix, it's happening in the immune cells, is something bad, because fibroblasts and the immune cells, they produce the senescent associated secretory phenotypes, so chemokines and cytokines that are able to promote tumor growth. What about immune senescence? Immune senescence is a global remodeling of the immune function. It is characterized by the reduction of naive T cells. So it seems that the immune system is not able to recognize the new antigen, and is also associated by a low grade of inflammation, chronic inflammation, that is called inflammaging. Senescence is associated probably with the chronological age, but is not just the only cause of immune senescence. We have different causes of immune senescence beside aging, such as cancer diagnosis, because cancer diagnosis is associated with the senescence of T cells. Also, previous chemotherapy is associated with senescence of T cells. And finally, also infection from cytomegalovirus or infection from COVID-19. What about the relation between immune senescence and the outcome from immune checkpoint inhibitors? First, we can say that age somehow is connected with an immune suppressive microenvironment. It's characterized by an immune suppressive microenvironment because there is a negative correlation between age and TCR clonality, and this means that the immune system of old people is unable to recognize new antigen. And in the tumor of the old people, there are less T cell and more myeloid-derived suppressor cells. And T cells in the tumor of the old people, they express a lot of checkpoint inhibitors, such as LAG3 and TIM3 and PD-1. But immunosenescence can somehow influence the outcome of immunotherapy in non-small cell lung cancer patients. This was tested with the Giuseppe Lo Russo in 80 patients treated with immune checkpoint inhibitors and 61 patients treated with platinum-based chemotherapy. We measured actually the age of T cells in the blood of these patients using flow cytometry, using 3 biomarkers, CD28, CD57, and KLRG1. In the blue square, you see that these are non-senescent T cells, so are young T cells. And if a patient has a young immune system, you see that 40% of these patients, they respond to treatment with immune checkpoint inhibitors. But if the patient has an old immune system, so if there are senescent T cells, you see that 96% of these patients, they had a primary progression to treatment with immune checkpoint blockade. And immunosenescence or immunological age may be a much better biomarker compared to chronological age. You see on the left part of the slide, people, the age of 65 years is not able to discriminate who are the people who benefit from pembrolizumab, while immunological age and so immunosenescence is correlated with the worse prognosis upon immune checkpoint inhibitors. And this probably is a predictive more than prognostic, because we measured also immunosenescence in a control cohort of patients treated with platinum-based chemotherapy, and we did not find any difference according to the age of T cells of these patients. And we also try to understand in these patients what are the determinants, what are the causes of the senescence of T cells. We found that there was no correlation with chronological age. That means that old people can be senescent or not. It's not important the chronological age, but we found we measured by VIR scan more than 200 epitope of virus in the blood. And we found that there was a strong correlation with CMV infection, and this is a paper in Press. We found that CMV infection is correlated with T cell senescence, and so probably also know if there is a previous infection from cytomegalovirus can be also a biomarker for treatment with immune checkpoint inhibitor. So it's an information that we should collect for our patients. Just a few words about, because lack of time, about cynotherapeutics. We have two different classes. You have just to remember that there are cynolytics and cynomorphics. Cynolytics are drugs that are able to clear and to destroy, actually, eliminate the senescent cells. And most of them, they are inhibitor of BCL2 or BCL-XL. Cynomorphic are different because they don't clear senescent cells. They just modify all the pathways that are associated with the secretion of chemokine and cytokines from senescent cells. And this drug actually never arrived to the clinic because of the problem of off-target effects, off-target toxicity. This is a senescent PET. It means that is used a tracer for beta-galactosidase, that is a metabolic biomarker of senescent cells. And this means that the PET is also positive not only in the tumor but also in the vessels, and because endothelial cell and macrophages, they can be senescent as well. And if we use, for example, cynolytics, we target not only the cancer cell, but we target also vessels, endothelial cell, macrophages, so we can have off-target effects, off-target toxicity. And the same is for cynomorphics, actually, because if we, for example, inhibit P38, P38 is an important pathway of senescence. P38 is expressed also in the brain and is expressed also in the liver, and we can have liver toxicity or brain toxicity from these agents. Lifestyle intervention, we can modify senescence with diet, probably yes. These are some data from models that show that if we use intermittent fasting, there is an increase in naive T cells, and so a decrease in senescent T cells. And probably we can also use some nutrients such as resveratrol, that is a polyphenol actually. So it's in grapes normally. And resveratrol is able to actually modify, reverse the senescence of T cells, because reduce the number of dysfunctional mitochondria, because senescent T cells, they have a high dysfunctional mitochondria that are reduced with the use of this polyphenol. Finally, gut microbiota is also a way probably that can modify and reverse senescence. Akkermansia mucinifila has been associated with benefit from immune checkpoint inhibitors in non-small cell lung cancer patients. But regardless of cancer, Akkermansia mucinifila is also a bacteria that is present in the gut of supercentenarians, so in very, very old people. This is because Akkermansia probably is associated with low inflammation coming from the gut. So if it's associated with reduced inflammation coming from the gut, probably is associated also with reduced senescence associated to that inflammation. And Arcela was talking about artificial intelligence. So also artificial intelligence has tried to understand which is the biological age of our patients, and this is a kind of face age. So with the picture of the patients, some feature of the face are associated with the biological age of the patient. And you see that the face age is a prognostic factor in these patients. These are patients from Maastricht University program. So I was a little bit curious to apply this a kind of similar algorithm, but very not so complex to us. So that's me and Diego 3 years ago in the same Congress. I was 34 and Diego was 38. And actually, in that time, I measured the level of all the T cell in my blood, and I found that just 5% of T cells were senescent in my blood. So according to the literature, 5% of T cells means a biological age of 21-year-old. And so the next question for Diego will be, if I'm 21-year-old, what will be the percentage of senescent T cell in your blood? And how can we be sure that you are still 38? No, 40 now. So just to conclude, the chronological age does not mirror biological age, and Diego is an example. Cellular senescence is context dependent, so can be pro-tumoral or anti-tumoral. Immune senescence may be a negative predictive factor for immune checkpoint inhibitors. Senolytic and xenomorphics are difficult to be implemented in the clinic because they have off-target toxicity. And lifestyle measure can probably are a more exciting way to modify and reverse immune senescence. And with this, I would like to thank all of you for your patience to be here, and also my previous group in National Cancer Institute, Gustavo Rossi, and my current group in San Raffaele University.
Wonderful presentation. It's true, I'm older than you, I know.
Not just chronological.
Not just chronological. No. Any questions from the audience? Okay. Just the last question, Rob.
Mm-hmm.
What are the main differences between senescent and exhausted T cells?
Okay, yes, the difference is that both of these cells, they do not proliferate actually. Also T cells that are exhausted, they do not proliferate as senescent T cells. This is a similarity, but senescent T cells, they are able to produce cytokines. So they produce TNF-alpha, they produce interleukin-6. Exhausted T cells, they usually are not functionally activated. So when there is an exhaustion, there is no production of cytokines most of the time. And the second point is that senescent T cells, they are not antigen-specific T cells. Normally, they are T cells bystander T cells that do not recognize the antigen of the tumor. Exhausted T cell in the tumor, sometimes they can recognize the antigen.
Okay, thank you very much.
Thanks, Roberto. Unfortunately, the time is over. I think today has been a wonderful day of science. Just allow me to say thank you to all the speakers, the chairs, and the colleagues present here and connected online. I also want to say thank you to the sponsor and the provider who helped to make this meeting possible. I hope we will meet again next year. Thank you again. And now we can drink. The cocktail is at the first floor. Bye.